Chairman of Bangabandhu Medical University, and our Professor Dr. Shamal Chandra Devnath, Professor of NITOR, and Professor Arsimina, ex-Indian President of Orthopedic Society, but he extremely apologizes not to be here for his due business. So today, our first session will be chaired by our Chairman of Bangabandhu Medical University, Abu Jafar Chaudhry Biru. I think he's here, and our Professor Shamal Chandra Devnath. So may I request the chairperson to conduct the session, our first session, and first speaker will be the Professor Jamal Ashraf. He's from India and this is the Secretary of APOA. So I think Professor Jamal Ashraf is here. Yes, sir. Thank you very much for your nice communications. Sorry for the late to start. So Shamal Chandra Devnath, please, sir. You come on the dais and conduct this session, our first scientific session. Thank you, everybody.
It's a great pleasure for me to be chaired for the first session of our Boscon 2021. I will not spend more time because our speakers are waiting eagerly. I welcome you all for this session, and I think it will be more informative and serve our purpose for academic interests. First paper will be given by Dr. Jamal Ashraf of India. His topic is on pylon fracture, fracture anatomy, treatment algorithm. I'll request Dr. Jamal Ashraf to start his business. Thank you.
Can you all see my screen? Is my screen visible? Hello?
Yes.
Okay, can I start now? Should I start? Hello?
Yes, please start.
Thank you. Thank you to the organizers for inviting me for this Boscon. I've been there on previous occasions, and it's always a pleasure interacting with the young surgeons from Bangladesh. Today, I'll be speaking on pylon fractures, treatment principles. Now, these are the key principles in management of pylon fractures that have to be meticulously followed in order to achieve good results and minimize complications. I will go through each as I proceed with my presentation. Number one, we have to understand the problem at hand. Historically, treatment options suggested have been confusing. This prompted a number of studies to be undertaken to try and outline the protocols of treatment. And thanks to these studies, supported by scientific evidences, in recent years, we have a better understanding of the injury patterns, and therefore we have evolved in our treatments. Now, if I were to show you these two clinical photographs and ask you which one is more a serious injury, if your answer is you cannot comment on a clinical photograph, you're absolutely correct. Now, this is the radiology. Now, my second question would be, are these two injuries similar? Well, they most certainly are not. And because of this, staging protocols are important. Judgment is required, and when in doubt, you have to follow protocols which guide you how to treat an individual case-by-case scenario. Number two, soft tissues are unforgiving. Soft tissue damage is the most important part of the injury. It is paramount that we understand the extent of the internal damage in our patient, for it will dictate the proposed plan of treatment. And it was this that prompted Joseph Schatzker to say that this is one fracture which is fraught with many difficulties, most significant of which is the soft tissue complication. And it is because of this that we are now today propagating less invasive methods of fracture stabilization. Number three, accurate reduction is the key. Now, this holds true for all intra-articular fractures, especially of the weight-bearing joints. But important to remember, for reduction accuracy, we must first understand the fracture, the pattern. Only then can we put it in place. And this has now been made possible by improved diagnostic modalities. We know that in these fractures, there are three major fragments: the medial malleolar fragment or the medial fragment, the anterolateral fragment or the Chaput's fragment, and the posterolateral fragment or the Volkmann's fragment. Now, there is consistency in the fracture configuration in a majority C3 fractures. This was emphasized by a paper published in the Journal of Trauma, which said that these fractures have a triradiate or a Mercedes-Benz sign. The study also emphasized that in addition to specific fracture lines, specific zones of comminution are present. If we understand these, we can fix them properly. Number 4, proper radiology is essential. Without radiology, without knowing what is wrong, you cannot correct it. And it is therefore recommended that you have all proper views. For improper views give you false information. This was a study that was published in Clinical Orthopedics that emphasized the importance of having CT scans. They gave surgeons X-rays, told them to write treatment plans, and then provided them with CT scans. 64% of surgeons changed their treatment plans that were made prior to having CT in their hand. Number 5, fracture reduction and classification and patient factors would dictate the treatment. Now, we are all familiar with the AO classification, which divides these into extra-articular, partially articular, and completely articular ones. But a more practical classification for understanding purposes is rotational injuries, low energy injuries, without much comminution and marked without much displacement, easy to treat. High energy axial injuries. These are the difficult injuries to treat, for they have marked comminution, chondral impaction, and often articular debris. Now, this is going to be our deciding factor. What is the status of the fibular fracture? Is the fibula fractured in a tension mode, or is it fractured in a compression mode, or is there no fibular fracture at all? Number 6, most cases will need surgery. When dealing with low energy injuries with insignificant soft tissue involvement, we can primarily reconstruct the fracture and mobilize early. However, it is the high velocity trauma that is a different ballgame altogether. Now, post-injury CT angiograms have revealed that blood flow and soft tissue oxygenation are impaired after high energy injuries. These remain acute for the first 7 to 10 days. This will give you a rough idea when not to operate on these. The dictum is early surgery, more complications. Now, it is based on a principle of stage treatment, which is distracting and stabilizing the joint and waiting for the soft tissues to recover completely. Now, even the external fixator is important. It should have a bicolumnar posterior distraction. It should be put both medially and laterally to control the deformity and reduce the talus correctly. It is important we disimpact the articular fragments. Also important that we check the AP and lateral views of the external fixator, for if at this particular stage, the alignment is well maintained, your surgery at a later stage will become easier. Important, get a CT scan done only after you have had your external fixator in place. Now, the size of the fragments, the degree of comminution, and the exact fracture lines may vary. Here, this sketch section X-ray is very important to understand how you will do your surgery. The interval between the medial and the anterolateral fragment is often the path for seeing inside the joint. This will dictate which incision you should use. Also remember, the most prominent part of the tibia on the medial aspect is called the medial shoulder. I will come back to this again. So the principle would be you span it and then scan it. And once you have your CT scan in place, you plan your surgery. Another important point, what should be the timing of internal fixation? Different studies advocate different times of waiting, but all agree that we should wait. Surgery should be delayed on a case-to-case basis. Number 7, surgical and implant choices. Now, the fibular fracture anatomy dictates the implant placement and therefore the incision choices. If you have a medial displacement, you need to prevent the varus, and therefore it is better to use a medial buttress plate. If you have a lateral displacement, you need to prevent the valgus, and therefore a lateral buttress. However, in certain aspects, in high energy injuries, you may have no fibular fracture, but because of the impaction of the talus and severe comminution, you may require multiple approaches and multiple buttress plates. Now, coming back to my medial shoulder that I said earlier, when the fracture, this is the medial shoulder. If the fracture line exists medial to the medial shoulder, then an enteromedial approach is indicated. Here on the contrast, if the fracture line exists lateral to the medial shoulder, a lateral approach is suitable. If you don't have a CT scan, ideally you should, then you can decide on the injury pattern. If you have a varus injury, better to fix with a medial plate. If you have a valgus injury, better to fix with a lateral plate. So the determining factors in your surgery would be what is the fracture pattern, how involved are the soft tissues, and how do you want to fix it? A few case examples. A relatively easier C1 fracture fixed with a percutaneous medially placed LCP. Now this is a more complex fracture. It's a C3 type of fracture. So we fix it with a MIPO plating of the tibia and fix the fibula with a titanium elastic nail. As you can see, there is about 6 degrees of a valgus malalignment, which can be appreciated on the lateral view, and about 10 to 12 degrees of a posterior angulation. Now, we did not correct it because we thought it would not be an impediment to good results. The fracture went on to heal in about 12 months, and the patient had good functional results. This is another case example of a C3 type of fracture. Here, this is your fracture line. So it is running lateral to the medial shoulder. And therefore, we use an enterolateral approach. First, we look inside the joint, elevate the posterior fragment, then align the medial and the lateral fragment, put in interfragmentary screws from the medial to the lateral, place an enterolateral LCP, and the screws through the enterolateral LCP engage the posterior fragment. This is the post-operative picture and the final picture at 6 months when the fracture is well united with good range of movement and articular surface is well maintained. Another example of a C3 fracture. Now, as you can see that this is a fracture that requires that we provide it with a lateral support. We fix it with an enterolateral LCP. Here, for the younger surgeons, I would like to say that when you're dealing with such a small fragment, an enterolateral fragment tends to provide you with better purchase due to its multiple holes in the distal fragment. Another example of a C3 fracture with a medial malleolar imprint. Now, although this fracture requires an enterolateral plate, you need to buttress the medial fragment by a separate anti-glide plate. Similar example of a C3 fracture where the medial malleolus is displaced. You have to align the medial malleolus and this has to be done open under vision, articular reconstruction. Then you place an enterolateral LCP to reduce your fracture and buttress the medial malleolus by a separate anti-glide plate. So in conclusion, I would like to say that timing is the key to achieving success. Understand the anatomy. Important that you have the correct approach. Accurate reduction is essential for intra-articular fragments. Don't have a fancy for MIPO surgeries. Often MIPO is not indicated. You need to open it and do the correct procedure, but at the same time, be soft tissue friendly, plan, and then do your surgery. As Robert Salter had said, decisions are more important than incisions. Thank you for your patient hearing.
Thank you, Dr. Jamal. Sachin illustrated an elaborate discussion of a difficult subject in trauma surgery, trauma management, like pylon fracture. Thank you once again for nice deliberation. I will, if there is any question and answer, I will invite everyone to put their questions, and it will be discussed at the end of the session if we have enough time to discuss on the matter. I will invite next speaker, who is from Bangladesh, our beloved Professor Dr. Shahidul Islam. His presentation is on uncover the burden of osteoporosis and fragility fracture. Professor Shahidul Islam, sir, please start.
Hello. Excuse me, can you hear me? Professor Shamal?
Thank you, sir. I can hear
Can you
you.
hear me? Yes. Thank you very much for inviting me for my presentations. The topic of my presentation is uncover the burden of osteoporosis and fragility fractures. Welcome all the participants for this presentation. Sorry. So 1 in 2 men and 1 in 5 men over 50 years will experience the fragility fractures in their lifetime. Combined lifetime risk for fragility fracture is 40%. Weak and fragile bone that breaks easily, an enormous burden worldwide. Globally, about 9 million fractures occurs annually. That is 1 fracture every 3 seconds. 10,000 fragility fractures in Europe every day. So 2 million osteoporotic fractures in United States, and it has serious consequences like disease, quality of life, function, independence, and increased morbidity and mortality. I will discuss it later. About 70% of women over 70 who have osteoporosis are not diagnosed in primary care. Only 1/3 of the vertebral fractures come to the clinical assessment, and about 80% of the people who have had at least 1 osteoporotic fracture are neither identified nor treated for osteoporosis. So you can see this paper, about 2.7 million new fragility fractures in 6 European countries in 2071, and it will give rise to, in 2030, there will be 23% increase in number. You can see lifetime risk of fragility fracture from the age of 50 years are equivalent risks for the cardiovascular disease. And at the same time, lifetime risks of hip fracture from at the age of years equivalent to stroke. So, osteoporotic fractures in women, comparison with other disease, you can see here, huge burden of osteoporotic fractures in United States, about 2 million women, and compared with heart attack, stroke, and breast cancer. This is the important slide. According to the American Society for Bone and Mineral Research, they say hip fractures occurs annually about 258,000 people, but 25% mortality within 1 year. In heart attack, 720,000 of people suffers from heart attack, but mortality rate is less than 10%. And breast cancer, 230,000 people, 230,000 people suffers from breast cancer, but mortality is within 1 year 20%. If we calculate this, that there will be 64,500 mortality within year after hip fracture, and 72,000 mortality within 1 year after heart attack, and only 56,000 mortality within 1 year after breast cancer. At the other slide, you can see lifetime risks of fracture in women is 50% fracture, and breast cancer is 12%. So there are a lot of measures, a lot of awareness, a lot of screening program for heart attack and invasive breast cancer, but there is no such program for the fragility fractures or osteoporosis prevailed all over the world. So you know what is osteoporosis? This is a low bone density, a microarchitectural deteriorations of bone tissue that enhance bone fragility and increase the risk of fractures. Bone density depends on age, hormones, environment, genetic factors, lifestyle, medications, and nutrition. And you can achieve max peak bone mass within 20 years only. And you can have a plateau up to another 20 years. And there is a decline. And after 45 years, especially in a woman, there is a sudden fall of bone mass density because of menopause. And there is a chance of fracture or fragility fracture. So what is fragility fracture? Fragility fracture, the fractures occurs due to minor trauma or fall from a standing height or less, or even if someone want to lift some light weight like 5 to 10 pounds and he sustained a fracture. In other words, by this trauma, there will be no fracture in a normal individual. So the common site of fragility fractures are spine, hip, and upper extremity, especially lower end of the radius and upper end of the femur. And there are other sites of fragility fractures. Regarding the hip fragility fractures, the significance in white women, lifetime risk is 1:6. This is more than breast cancer. And whatever surgery, whatever treatment you give to the patient, there will be 20 to 25% mortality within first year of life. And fracture, biggest fracture, that is double risk of sustain another fracture. There is profound loss of function, like 40% unable to walk independently throughout their life, and 60% require assistance throughout their life after having the fracture, and 1 to 20% will require long-term nursing care. So this is a huge burden for the society, especially for the older people. There is the common fragility fractures, fracture neck femur, trochanteric fractures, and virtually there is an important factor that all fragility fracture around the hip should be treated surgically. There is minimal options for non-operative treatment, only reserved for the patients who will not survive surgery. There are other complications of surgery added to these old people. So, and we need early surgery to improve outcome. Early surgery in our setup, especially the developing country, is very much problematic. We have limited facilities. There are modalities of hip fracture, like already I've said. Sometimes there may be impacted fracture. We can treat it with close reduction internal fixation by fixed screw, but maximum fracture needed replacement hemiarthroplasty or total hip arthroplasty. Already I have said, these are the modalities of intertrochanteric fracture. We can use DHH, or sometimes in this recent years, we are trying for proximal femoral nailings and giving good results. But result, whatever facilities you give, already I have discussed what are the significance of fragility fracture around the hip. The vertebral fragility fracture. Epidemiology, common in osteoporosis, that is 1.4 million occurs worldwide. One span fractures occurs every 22 seconds. A 50-year woman has a 16% life risk. 1/3 fractures are clinically diagnosed, and remaining 2/3 remain undiagnosed and gradually become the burden. So this fragility fracture spine may lead to back pain, deformity, loss of height, poor mobility, reduced respiratory functions, and sometimes associated with 8-fold increase in mortality. Fracture, biggest fracture, 1:4 chance of another fracture in the next 5 years. The modalities of treatments mainly depends on the conservative management, that is non-surgical treatment, but it depends. So when there is no red flag signs, we can go for conservative treatment for 6 weeks, and if improved, that is VAS score improved, there is no limitation of activities, or there is no intolerance of analgesic, we can continue conservative treatment. But if this is not possible, we may go for like vertebroplasty or kyphoplasty, or sometimes we may need 360 fixation with this augmentation with cement, but these are associated with some complications like leakage of cement, or there may be vein thrombosis and other complications during operation. If we go for 360 fixations, there may be chance of implant failure, implant loosening, or adjacent segment degenerations. These also are the problem and becoming burden for the geriatric patients. This is the paper published in 2019, and The main message is to us, please diagnose and timely treat the osteopenia or osteoporosis is a paramount importance for preventing mortality and morbidity. There is another fractures, distal radius fractures. Gentlemen, distal radius fractures occurs usually in early age of osteoporosis, because when one tries to fall, they want to prevent without the straight hand, and there is a fragility fracture of the distal radius, and it gives you information that there will be more fracture in future. You should be cautious. You should go for screening and treatment of the osteoporosis. And sometimes maximum we treat conservatively, but sometimes we need open reduction internal fixation. And how we prevent fragility fractures? Already I have said, fragility fractures, if we want to prevent, we should start in early childhood. That is first 20 years of life. This is the time if we take adequate amount of protein like 1.2 gram per day per kg body weight, and if we take sufficient calcium, vitamin D, and if we go for physical exercise, that is, if we go for weight-bearing exercise, especially, it stimulates bone. If we go for resistance exercise, it stimulates bone. If your bone does not experience any weight bearing or gravity, your bone will say, I will give way. You don't need beginning of your life for weight bearing exercise, adequate diet, and resistance exercise. And at the plateau phase, you should continue this. But when there is a chance of fragility fractures appears, especially in the late age, we go for screening and we go for starting the treatment. For assessment of the fragility fractures or osteoporosis, we can see only the tip of the iceberg. The maximum portion remain uncovered by us. We can assume a fragility fractures or osteoporosis by presence of some risk factors, with some family history, with some medical history, especially in case of secondary osteoporosis, in case low back pain and height loss, and by some physical examination, but more standard form is the diagnosis by doing for fragility fracture. You can see here, age 50 years, T-score minus 2.5, there is 12% risk of fragility fracture. But the same person, T-score 2.5, at the age of 70 years have 24% risk of fragility fractures. So National Osteoporotic Foundation recommends osteoporotic screening. Woman is 65 years or older, man is 70 years or older, fracture after 50 years, woman of menopausal age with risk factors, postmenopausal woman under 65 with risk factors, and man is 50 to 69 years with risk factors. We did a minimum short study at Nitor and Dhaka Medical College, and we found that there is a 41% osteoporosis among 200 populations, 111 being female and 109 being female and 91 male. And we found 41% osteopenia and 35% osteoporosis. And our calculation is 1 in 2.2 females suffers from osteoporosis sample size. After doing bone mineral density, we should go for assessment of the fragility fracture. We use usually fracs, but unfortunately in our country and other underdeveloped country, there is no fragility fracs. If we put all the values in the frac box, we can determine the major osteoporotic fracture or hip probability of hip fractures. And national guideline for National Osteoporotic Foundation published in 2010, they say whom to treat after exclusion of secondary causes, treat postmenopausal women and men aged 50 years and older who have osteoporosis or hip of spine fractures, or his or her DEXA is 2.5 or below in the hip or spine. Or if you have T-score -1 to -2.5, that is osteopenia, but you have 10-year risk of fragility fracture, more than 3% or more than 3% in hip region, or more 20% or more than 20% for major osteoporotic fracture. So for the treatment, already I have said you have to take adequate protein-rich diet, vitamin, calcium, vitamin D, calciums, and there are some drugs available all over the world. Like one group, block bone breakdown. The main drugs of this group are bisphosphonate and denosumab, and somebody also used selective estrogen receptor modulators. But in a severe fragility fracture, especially old age, we can use teriparatide. This is bone formation. There is some bone formation also. So preventing a secondary fracture, I want to draw the attention of the medical professionals that the medical profession, even now, has been inadequate in diagnosing and referring the patient for screening and treatment after sustaining a fragility fracture. It is still underestimated, underreported, underevaluated, undertreated, and invisible burden to the populations, especially for the geriatric populations and to the physicians all over the world. So in summary, fragility fractures occurs structurally weak bone due to osteoporosis, and fragility fractures are associated with profound functional loss and mortality risks. So fracture prevention is critical in osteoporosis, and we high rate of recurrent fragility fracture. There's a high rate of recurrent fragility fracture. So timely screening is necessary for diagnosis and initiation of osteoporosis treatment. Thank you. Love your bone, protect in future. Thank you for patient sharing.
Thank you, sir, for his time-demanding presentation on osteoporosis and fragility. Like that of tip of the iceberg, almost whole scenario is hidden from us. We can't find it, we can detect it and treat it timely. Thank you once again. Such a very important topic on this session. I'm now inviting my first chairman, Professor Abu Jafar Chaudhuri Biru, if he can want to join and speak on and invite our next speaker. I am offering him to come on scene. Professor Abu Jafar Chaudhuri Biru, if he is with me, he can join on Zoom or any devices. I think he will join later. We can move on. We can move on to next topic. Next topic is on by B. Shiva Shankar of India. His presentation is on 10 commandments to get good outcome in intertrochanteric fractures with PFN. 10 commandments to get good outcome in intertrochanteric fractures with PFN. B. Shiva Shankar sir, I'm inviting you to present your speech.
Dr. Shamal, probably he has not joined. Probably he has not joined. Go to the next speaker, please.
Can you hear me, sir? B. Shiv Shankar, sir, of India. Dr. B. Shiv Shankar, sir, I'm inviting you to present your paper. I think we can pass on to the next topic. Next topic will be a video presentation by Professor R. Koiri, sir. Due to unwanted incidents, he could not present physically because sudden demise of his father-in-law last night. He is busy with that rituals. I am inviting Koiri sir, his video presentation. His topic is on management of carpal tunnel syndrome. Management of carpal tunnel syndrome. by Professor R.R. Koiri sir. Please play the video now.
Nine tendons, scientific presentation. I will discuss the carpal tunnel syndrome. We must remember the anatomy of the carpal tunnel and the nerves and tendons that goes under it. 9 tendons and 1 median nerve. The another name of the carpal tunnel syndrome is tardy median nerve palsy. This results from the compression of the median nerve within the carpal tunnel. And history. Carpal tunnel syndrome was first described by Sir James Paget in 1854, and first carpal tunnel release was performed by Learmonth in 1933. And the syndrome is popularized by Phelan in 1950s with a series of articles, and first endoscopic release was done in 1985 by Dr. H. Gee, then in 1987 by Dr. Choi and Okatsu. Regarding the epidemiology, incidence is about 99 to 148 per 100,000 population. Occupational prevalence is about 17 to 61% in some literature. Male-female ratio is 3:1, female is 3 and male is 1. And it is more common on the 4th and 5th decade of life, and 50% has bilateral symptom. Other risk factors are obesity, hypothyroidism, diabetes, pregnancy, renal disease, arthritis, acromegaly, mucopolysaccharidosis, and age more than 50. Smoking is one of the prevalent causes. Symptoms and signs. Common presentation is intermittent pain and paresthesia in the median nerve distribution. Nocturnal paresthesia is the cardinal symptom. And with time, there will be thinner atrophy and grip weakness, clumsiness of the hands. Sensory changes, loss of sensation in the lateral 3.5 digits, including the nail bed and distal phalanx. An important point to remember is that there is no sensory loss over the thinner eminence. This is due to the branch of the median nerve that innervates the thinner eminence comes outside the carpal tunnel. Median nerve is compressed at the wrist, resulting in numbness of the skin and thinner muscles atrophy. Motor changes is a plaque deformity, loss of opposition of the thumb, the index and middle finger lag behind when making the fist. Atrophy of the thinner muscle. There are vasomotor changes, skin will be dry, and trophic changes, scaly skin, nail crack easily, and atrophy of the pulp of the fingers, thinner muscle. In diagnosis, motor examination, wasting and weakness of the media innervated muscles. Phelan test is a very important test that flexion of the wrist, finger pointing down, and when the flexed wrist pressed together, there is symptom within a minute. This is a sign of carpal tunnel. Tinnial sign test, tapping over the median nerve can produce the tingling and numbness of the along the distribution of the median nerve. Darken test is a carpal compression test. Pressure over the carpal tunnel for 30 seconds produces the tingling and shock in the median nerve, and then the wrist should be kept in neutral position and forearm supinated. In summary, the compression test is 87% sensitivity and 90% specificity. Differential diagnosis is C6-7 radiculopathy, thoracic outlet syndrome, proximal median nerve entrapment, peripheral neuropathy, and traumatic injury at the level of the wrist. Electrodiagnostic studies, nerve conduction studies is 30%, 90% sensitive and 60% specificity. Management, conservative management, weight loss helps, and some splints, short wave diathermy, stretching exercises that helps. NSAID, vitamin B6 that helps sometimes. Steroid injection has got value, and 80% relief in short term and 20% maybe a long term relief. Surgical management is the management of choice. Whose improve the symptoms does not improve with the conservative treatment, and who has the severe carpal tunnel syndrome should be considered for surgery. Two types of surgery are there: open carpal tunnel release and minimally invasive endoscopic release. Open release, let us show a short video. The line of incision, distal part of the incision is a line drawn along the base of the thumb, abducted thumb, and another line that goes through the radial side of the ring finger, and this is the line of incision. When you cross the wrist, then the crossing should be slightly oblique so that there is less scarring at the wrist crease. Inside the deep fossa and underneath the deep fossa is the deep carpal ligament, which is the true carpal tunnel. Then proximally we make a small incision by number 15 blade and introduce a hemostat underneath the tunnel, and over the hemostat we incise the tunnel so that there is no chance of injury to the median nerve or its branches. And this line of incision should be on the ulnar side so that the recurrent branch is not injured. Distally, we should take care that no branches of the median nerve should be injured. And proximally, we must release the tunnel fully underneath the skin. That can be done by a seizure. Then there will be neurolysis of the median nerve should be done. This is the median nerve. You can see that proximally and distally it is released completely. We always do the release under tourniquet. And tourniquet can be given even in the forearm and using this Beer's block. The skin and deep fossa should be stitched, not the sheath of the tunnel. Only the skin and subcutaneous tissue. And after a stitch, I usually give a short arm back slap for 2 weeks, and after removal of the stitch, we remove the slab and allow the hand for every work. Surgical release of the carpal tunnel. We should carefully divide the transverse carpal ligament along the ulnar border to avoid damage to the median nerve and its branches. You can see the anatomically, there are about 40 to 50% cases, the branch may be distal to the branch to the thinner muscles, comes distal to the sheath, and it can be come from the middle of the sheath, or it can come from the median nerve itself or from its branches. So we must take care of the recurrent branch. Why is carpal tunnel release phase? This may be due to the wrong diagnosis and other causes like peripheral neuropathy, cervical radiculopathy, or more proximal compression like pronator syndrome or incomplete surgery. Recurrent carpal tunnel release, average 10 years after the CTS release. It may be in cases in patients of diabetes or hypothyroidism. There will be symptoms of carpal tunnel again, and treatment is repeat the release plus Guillaume's canal release. Persistent carpal tunnel syndrome nearly always due to the incomplete release, like many release, endoscopic release, etc. Treatment is open release, complete release of the flexor retinaculum, use larger incision, and decompress the median nerve proximally and distally adequately, and decompress the Guillaume's canal as well. At the time of revision, the incision should extend proximally and release the nerve completely. Thank you all. Thank you all once again.
On most common problem, carpal tunnel syndrome. Thank you once again. I'm now inviting our Professor MD Shahalom sir of Bangladesh. His topic is on results of occipito-cervical fusion in post-traumatic upper cervical spinal instability and odontoid fracture. Results of occipito-cervical fusion in post-traumatic upper cervical spinal instability and odontoid fracture. Professor Shalom sir, please start your lecture. Thank you, sir.
Shamal, shunte pao?
Yes, sir. Audible.
Okay. Thank you very much.
Thank you.
First of all, thanks to organizer in this COVID association. They have organized this hybrid conference. So first of all, I'm expressing my gratitude to all organizers and also those who have participated both nationally and internationally. I'm Dr. Shalom, as I was working as a professor and head Dhaka Medical College. Now I am on PRL. Right now I am working in my own center, that is Bangladesh Spine and Orthopedic Hospital. So first of all, I am expressing my respect and salute in this Independence Month, those who have sacrificed their life for our country, for our nation. So the background is the Atlantic axial instability when there is excessive or abnormal movement at the junction between the Atlas C1 and C2, and maybe due to any abnormality either in the ligamentous structure or in the bony structure, and which compresses the neural elements, especially the spinal cord and the roots, and that produces symptoms. So my talk on top, the mostly trauma, but maybe this instability is congenital, or in adult acute trauma, the very rare type 1 odontoid fracture, also maybe sometimes the fracture atlas or the transversal ligament injuries. There may be associated also few cases with the degenerative and also the very common, the rheumatoid arthritis and sometimes infection and tumor. The traumatic atlantoaxial dislocation, as I mentioned, is not very common. So an infrequent entity in adults, especially with an outstanding threat to, the health services, because if it occurs, it's really dangerous. So till today, the up-to-date data is not very much. So the few cases have been published only that occur due to the ligamentous injuries, as I have mentioned, maybe bony or maybe the combined. So according to this, the pathology, this may be the three types. First of all, the type 1, only the rotatory dislocation due to injury to the LI ligament. If you can see only the LI ligament, that associated with the rotatory dislocation or symptoms, that is type 1. Type 2, when LI ligament along with the transversal ligament that produces the horizontal dislocation due to injury to the transverse, ligament. And third type, when excessive ligamentous injury, it means that LI ligament, transverse ligament, and tectorial membranes all are destroyed, and that complex, the dissociation resulting to compression of the spinal cord and roots. So the treatment option, yes, maybe the conservative treatment done safely when only the rotatory, only one ligament is injured, patient can be treated conservatively. But when the complex, the all ligaments and bony structures are involved, that injury requires, that means the horizontal and vertical instability are existing. This complex injury that requires internal fixation of atlas and axis. So the goal of surgery is the stabilization and correction of the deformity or displacement and decompression of the compromised or compressed neural structures. And goal of instrumentation is to provide the immediate stability, improve the fusion rate, and reduce need for post-operative external immobilization and decrease the rehabilitation time. So there are some pre-operative evaluations, especially by doing the radiogram, anteroposterior, lateral, flexion and extension views, CT scan, CT angiogram, and MRI. These are few important points that leads how to diagnose and when we'll go for surgery. That means the WCB line and the CCA line, that is clevius canal angle, and ADT, atlantoaxial distance and power ratio. Here is a little bit complex, but if we consider that is the opening of the foramen magnum, and this is basin, and this is the posterior arch of the atlas, and this is opistheon. There's a posterior aspect of the foramen magnum that is in occipital bone, and this margin and other the anterior arch of your atlas. So these are the lines. I'll go in details. So this is the WCB line, and this is CCA angle. The one line drawn from the superior surface of the clevius, and other line from the posterior aspect of the body of axis. And this angle, it is called the CCA line. And here the ratio, that is the power ratio we mentioned, that is 1 PB line, that is the Bayesian to posterior arcs of, the atlas, and other line that is anterior arcs to ostium. And these two, there is the summation, or if ratio goes more than 1, that signifies that is indication for surgery. I'm going in detail the transient line that I have shown the previous slide and the angle that I have mentioned. And there are some, the normal ratio. It means the normally if you go this CCA angle in normal extension, the normal adult in extension 180 degree and in flexion that is 150 degree. But it is abnormal when it is less than 150 degree. It signifies that the ventral spinal cord compression. Again, I have mentioned the ADD. Normally it is less than 3 millimeter, but it varies during this injurious condition. If in adult is more than 3, that is indication that is the abnormal. And in children, when it is 4.5 mm, that signifies atlantoaxial subluxation. And PR normally is less than 1. If it is more than 1, it signifies that atlanto-occipital dissociation. So these are very important, the lines and canal that signifies that when we'll go for surgical intervention. So there are a lot of options, but commonly the fusions, the dural wearing techniques, here the Loxley and intersegmental divert technique, many of us, we are oriented and we do in few cases. And the screw fixation, the most popular is the Magarel transarticular screw fixation. These two, the procedure mostly adopted in India subcontinent. So consideration this, when it gives the high degree of cervico-occipital junctional mobility and angling, the most rigid fixation devices must be used that promotes arthrodesis, because our main motto is to decompression, stabilization, and fusion. So arthrodesis is the key point. So fixation techniques C1 and C2 transarticular, as I have mentioned, and C2 transpedicular screw were significantly more stable than sublaminar wearing or laminar hooks and pedicular screw fixation that displays the highest construct stiffness. So this is the, the AP and lateral view, the transarticular, little bit complex. This is C2, if you see the lateral view, and this is a AP view starting from C2 to C1. It increases the rotational stability, but not require the stable posterior arcs. And high fusion rate and immediate stabilization is possible, but only problem that because here is the vertebral artery, that's the most dangerous, we can injure that. So we keep in mind that we can injure the vertebral artery. C1, C2 rod fixation and laminar wearing, if you see here, it needs that the posterior arch should be intact. So this is the laminar screw in C2, and this is the lateral mass screw in the L1. But here, the one important point, this posterior arch should be intact. If we go some case illustration, then it will be easier. So this is a 22 years old boy having with the tilting due to C1, C2 dissociation and having with the Asia D, but it looks very ugly and patient cannot move his neck properly. So this patient, if you see, this is the normal, this is normal, but here ADD, as I have mentioned, is a complex little bit. It is a more than 3 that signifies instability at the junction C and C2 that requires surgical intervention. So the steps of surgery is the prone position. This is a paraoperative scenario. And this is the exposure posterior midline. And the C2, that is the C2, the lamina and spinous process. And this is confirmed by the fluoroscopy in the lateral view. And this is the location in the occiput where we fix, that is the location, external occipital protuberance and supranuchal line. This is the anatomical landmark. Here we locate by paraoperatively. And this is the morbid anatomy, is the location where we put the screw. So this is a paraoperative fixation. This, the screw, it is the rod and plate. So this plate is a fixed in the occipital bone. And here is the lateral mass screw fixation in C2. C2 in the pedicle and the C3 is the lateral muscle screw fixation. And if you see perioperative, this is your, the C arm lateral view. We can see pedicular screw in the C2 and the lateral muscle screw other, and occipital bone was fixed by stool. And if you compare this boy, the before surgery, you can see this the tilting, and this is the after surgery, the photograph. And if you compare the radiology, here is the instability and junctional, and it is after correction, so good looking. So this angle. And if you compare this boy, the before surgery, if you see the video, how he was walking, and immediately post-operative period is a good range of movement, but 4 years after post-operative follow-up is a total range that is satisfactory flexion, extension, and lateral rotation is possible when C1, C2 along with occipital bone is fixed. The other patient is a multiple trauma along with the fracture in C1, C2, having the ACS-C, the neurology, and patient had also fracture in the forearm bone. The same procedure we adopted. This is a perioperative, the C-arm location is the final fixation. And if we compare this boy, the before surgery he was bedridden, he couldn't walk, but ACS-C. And immediately after surgery, you can compare, the patient can stand and can walk, as because his C1, C2, along with the occipital bone is stabilized. So instability is the most dangerous, patient cannot walk. And if we compare this a few months after surgery, the satisfactory range of extension and flexion and lateral rotation. Many of us, we think that if we fix the occipital bone C1 and C2, maybe totally disruption, but not that. Another, the C1 that is type 2 odontoid fracture, the young girl of 23 years, university student, was treated initially by conservative treatment, putting the skeletal fraction, but not improved. Subsequently, we adopted C1, C2 Megal technique. Here, just immediately, first POD patient could stand and work is because her spine, C1, C2 was totally unstable. This instability couldn't allow her to stand and walk. And few years after, you can see we have fused it C1, C2, and also there is a good range of movement here. You can photograph, and patient having with a normal range of movement can walk and can stand and can sit. The same type of procedure here, you can see the C1 and C2 dissociated and basilar, the invagination. The same procedure adapted, occipital cervical fusion done, and few months after surgery, yeah, the satisfactory range of movement. Here, the old man, little bit osteoporotic, but you can see the how much the C1, C2 fracture has compressed. And if you see this, the CT scan, the basilar and invagination and compressing the cord, and patient having with neurological deficit couldn't walk. Here you can see that how much displaced the C1 and C2. We adopted the same procedure, and this patient subsequently, immediately before surgery, patient can move but cannot stand. And 8 postoperative period, patient, yes, it's possible. You can see here video, and 6 months after surgery with satisfactory range of movement that was fixed. That means C1, C2, and occipital fixation. So, I'm sorry. Shamal, can you hear me? Shamal. Hello.
Yes, sir, clear.
Okay. So in
go
my series, we have done the 15 cases, and mean age was 37 years, and the follow-up period was 5 years, starting from July 2015 to December 2020. And fixation was done by pedicle screw and lateral muscle screw or occipital cervical plate rod system, and autogenous chunk of bone graft taken from the iliac crest. I have shown it for adequate fusion. So the outcome was evaluated by the 4 main criteria. One is the arthrodesis, number 2 is the neurological improvement, number 3 is the pain scales and the complications. The follow-up and results, the satisfactory deformity correction and neurological improvement were noticed in our series. Post-operative flexion decrease on an average the 28 degree, along with the lack of rotation in few cases, and no implant failure or wound infection was noted till today. And malalignment or misalignment of the occipitocervical junction during fusion may lead to serious complication. That's because head position is most important. If you flex or extend, both are not accepted, because fixation in exaggerated extension may result in limiting one's views of the ground and cause difficulty in walking. And use of halo or Gardner wells or may feel the tongue promote the neutral position maintains the reduction. It means the neutral position should be maintained during surgical procedure. And my take-home message is that the proper selection of this type of case is very important, most important, and expertise is needed. Adequate fixation and rigid fusion should be achieved, even not considering the fusion range of movement. And the ultimate goal is to provide the patient with a better and risk-free life. Thank you for your patient hearing.
A difficult area of spine, that is cervical and occipital junction. We have seen a lot of good pictures and presentation is so nice. Thank you once again. We will move to next speaker, our guest speaker from Singapore. He is Denny Lai Jiao-Joen. His topic is on novel therapeutic options for the arthritic young, the acellular scaffold patch and subchondroplasty. The acellular scaffold patch and subchondroplasty. Dr. Denny Lai Jiao-Joen of Singapore, I'm inviting you to present your paper. Thank you.
Hello, good morning. From Singapore to all our friends in Bangladesh. I see quite a few familiar faces in Nidor, Sylhet, and even Chittagong. Thank you very much for your kind invitation. So this morning, I'd like to share with you some therapeutic options for the arthritis in the young patients. In particular, I want to focus on the acellular scaffold patch and subchondroplasty. Can I check, is my audio okay? And can you see my screen?
Yes.
Great. So thank you once again for your kind invitation to this wonderful meeting. It's quite revolutionary. We are doing this all on Zoom. Yeah, we're so far away and yet very much closer over Zoom. So I bring you greetings from my society and from our friends who have been and frequently go to Bangladesh. So many of you have been to Singapore, and I hope to welcome you back one day. I work at the Singapore General Hospital, and some of you might be familiar with it. So once again, we extend a warm welcome and thank you very much. So this lecture, I wanted to share with you some of what are the options for the arthritis in the young. In particular, I'll share with you the hyalofast, the way we do it, our surgical techniques, our outcomes. Then this phenomenon, this rise in bone marrow lesions. How do we deal with it, the subchondroplasty, and what are our outcomes? So let's consider the factors. This is our typical patient, an athlete, young chap, 17-year-old, right knee pain for about 2 years, atraumatic. Examination is quite unremarkable, full ROM, joint line not painful, very stable. On the X-ray, you would have brushed it aside and you said probably normal. But when you really look at the MRI, you begin to see a huge cartilage defect over the lateral femoral trochlea, measuring that. So this causes his pain. And so the question is, what are our treatment options and what would we offer for the patient? I'll share with you my algorithm and the criteria. So in selecting the options for cartilage lesions, I am dictated by the size of the lesion, the containment of the defect, and the state of the subchondral bone. Yeah. So of the many options that are familiar to us, These are the non-surgical options, supplements, physiotherapy, and even injections. Of course, just a cleanup, debridement, and chondroplasty. Microfracture has been very commonly done and is the mainstay of most of our arthroscopic work. Then the rise of subchondroplasty, which we will share with you in a while. Oats as another option, all right? Cartilage transplant, which we've been doing using this gel matrix, and the new thing that we're excited about, acellular scaffolds, which are more cost-effective. So these are options for today. And my algorithm, driven by the size, a contained defect, which is small, I'll just do microfracture. Any bone edema, we do subchondroplasty. And for large uncontained defects, we just do microfracture. So the focus for today, patch repair and subchondroplasty. So let's begin with the first one, the acellular patch. What is Hyalofast and how do I use it? Hyalofast is actually a biodegradable scaffold. We see it as a one-step cartilage repair. We do it for pure chondral lesions as well as osteochondral lesions. It looks really like a patch of cotton wool, albeit a very expensive one. So why this material? Hyaluron is one of the critical molecules in the maintenance of the cartilage extracellular matrix. It is the building block of the matrix. So it has both chondroprotective activities as well as chondrogenesis. So it helps to build up cartilage. It has been in use for more than 25 years with good results. So from the liquid form, it's now crystalline into this kind of scaffold. It's quite thin, but it is biocompatible and bioresorbable. And over time, as it degrades, it becomes hyaluronic acid, which is great. How do I do this? Our technique published last year. So this is another example, 57-year-old, right knee pain. Again, physical examination, rather unremarkable. And MRI shows meniscus tear with full thickness trichome arthritis. If we see the MRI, we see a huge area of bone, of cartilage loss. Initial conservative or non-surgical treatment was good for a while, but his pain came back. So an MRI confirmed that area of a huge area of cartilage loss. So this is what we will do. And this is the scope findings. You see this huge area of cartilage loss. Yeah, right over the medial femoral condyle. I use these malleable retractors to push aside the soft tissue, exposing the cartilage loss. Then I curate the edges to create a nice border, and then I do microfracture. Microfracture is not done with the awl. It is done micro drilling. I use small KY and I drill about 1 cm or so. This really brings the fluid, the fats, and the blood out. So then I size the ulcer and I use a simple Terumo syringe, 3 mm syringe. Yeah, I size it and I roughly gauge based on the diameter how many more times it will be. I then dry the entire knee to create this. And as the bleeding starts, I prepare the scaffold, I cut it to size, and I fold it into the syringe like that. Okay? And then it goes in. And by that time, the blood from the marrow would have come out, which is as good as a BMAC. And then using the syringe, I deliver the patches slowly. And as it soaks up the blood, it forms a nice layer. Even if you do in patches, it coalesces to form a one uniform layer. So we've been quite happy. Yeah, it's red because it's the blood from the marrow. So it's very nicely covered over the whole thing. So this is how we use the Hyalofast scaffold. And so we see, how do we maneuver placing it in the various parts of the femur. So we describe different types of lesions. A type 1 lesion is right on the condyle where the syringe is cut flat. Yeah, so this delivers the hyalofast very, very easily. In type 2, it's right over the edges of the condyle. So we cut the syringe to about 30 degrees, and this allows us on medial or lateral side, peripheral, central edges. And finally, type 3 are the femoral trochlear lesions, where we bevel the syringe to 45 degrees to fit right at the femoral trochlea. Very easily done. What are our outcomes, our results? We published this last year where we followed up 22 of these for at least 2 years. They're mostly males. Then the average age is in their 40s. And yeah, so most of them are on the medial femoral condyle, some on the lateral condyle, and some on the trochlea. At 6 months, the IKDC scores improved from 33 pre-op to about 54, which is significantly much better. At 2 years, it goes up further to 66. And really, the patients are quite happy. So we found this to be an alternative to cartilage transplant in our young patients. Transplants are quite expensive. So rather than using cells, we use acellular scaffolds. And we found this to be really good results. This good result is independent of the BMI and age. So even in older patients, we can expect fairly good results. When we compare this to the original people in Italy who come up with the hyalofast, they too studied their initial series for 2 years, and they too found an improvement, except they use BMAC, bone marrow aspirate, which we don't. We just do micro drilling. The biopsy shows more like hyaline-like cartilage, which is very exciting, and that gives us a lot of hope and promise. So from one end, the cartilage lesion, we move to the basement of the bone, the subchondroplasty. What are bone marrow lesions? And what is this subchondroplasty all about? We know that the subchondral bone provides support for the articular cartilage. In osteoarthritis, these marrow lesions have shown to have changes in the histology and hence the mechanical support. It is related to an accelerated joint deterioration. So bone marrow lesions are not as innocent, not as innocuous as we think. They form part of the pathogenesis of arthritis. It's a part of the progression, and you do cause pain. So that's what we recognize. That's what we want to get early. So strong association with pain and decreased knee function. Patients with bone marrow lesions are 9 times more likely to progress to total knee arthroplasty. And they've been shown to represent a healing response surrounding the insufficiency fractures. So what is subchondroplasty? Essentially, it is modified calcium phosphate injection. It comes in a putty-like form, as shown in the picture. How does it work? It fills up all the bony defects and edema with this material, and it mimics the composition of subchondral bone. The key thing is that over time, it becomes replaced by new bone in the healing process. So animal studies have shown how it not only fills up, becomes replaced with bone over time, and critically, the bone pores, the porosity, is then reproduced at 24 weeks. So porosity of the bone is important, and this study seems to suggest that such injections can do that. So there are many benefits to this. In injectable form, 15 minutes working time, it's done in the operating theater, but very fast, sits within 10 minutes, and it can withstand 7 to 9 megapascals of compression pressure, which is good. It's almost like bone. So subchondroplasty was first done by Cohen, who did this on patients with subchondral insufficiency fractures. So he found that they had improvement in their pain scores and knee outcome scores. So since then, it has taken off. Now I'll share with you how I do such injection. So we'll take you step by step. from on table to the injection to the preparation. So patients are placed with the C-arm and the lesion located. Yeah? So the trajectory is then planned. The set comes in such prepared set, and essentially the powder is then mixed in, yeah, and assembled. Water is then injected in, and what is critical is to mix it up very well. It looks very simple, but what is important is that we need to really mix it in the sterile container. So fluid is going in. I'll just speed up the video. So this one shows us mixing the fluid and the calcium phosphate. So once ready, it becomes a putty-like form, and then we start injecting them, assembling them into small syringes. So once that's done, we go back to the patient. This drill is mounted on a standard drill bit. We locate where the lesion is, and we slowly inject, yeah, to fill up the entire bone edema lesions. In the beginning, I've always been worried whether we can adequately fill up that space. And we tend to do more. Actually, if you fill up too much, it may cause pain. So it's not necessary to overfill the whole lesion. Yeah. After that, I do a scope to make sure that none of the putty comes out to the knee joint. So that's the cartilage lesion that we are trying to correct. Yeah. So this approach is an subchondroplasty approach. So what are our outcomes? So this is our initial cohort of patients, published just 2 years ago, where we looked at the VAS, KOOS, and WOMAC scores. But this is a 1-year follow-up. So VAS pain scores improved dramatically from 7.5 to 2.1. KOOS scores also improved from 38 to 73, as did WOMAC, improved from 47 to 14. So very encouraging. But this is a short 1-year follow-up. So this is our current study where we looked at 2-year follow-up. We see the X-ray changes at 3 months, 1 year, and 2 years. So it's really becoming more and more like bone. And our scores have improved. Pain scores did go up slightly at 2 years, but still much better compared to pre-op. KOOS scores, WOMAC scores, very nice, maintained at 2 years. So we're very encouraged with this. When we look at other papers, Steve Cohen's paper also showed good pain improvement with no conversion to total knee. That's important, our endpoint. This was the Brazilians' experience with 5 cases. Again, they showed similar improvement in KOOS VAS scores. This was the latest in July last year, a huge meta-analysis of all those people who have tried subchondroplasty. 13 studies in all. What is significant? Good resolution of pain from 7.8 to 3.4, improvement in IKDC 31 to 54, and KOOS score from 38 to 70. 87% were happy with the results, only 7 complications, so about 1%, and conversion to TKR is quite low. So overall, subchondroplasty is very promising. And here we share with you these 2 extreme thoughts: acellular patches, subchondroplasty, in a bid to really stop the arthritis among the young patients, our young athletes early. So in this short talk, what I've shared with you, that I think more and more we recognize that arthritis in the young or the pre-replacement age does exist, and it is a painful problem. Most of the time we use microfracture, and cartilage transplant, I think it's just too expensive. And therefore I pose you 2 options: the acellular scaffold, easy to do, very good results. Bone marrow lesions is an upcoming problem that we want to address. So subchondroplasty, again, equally easy with good results. So with this, I thank you very much for your kind invitation and for permitting me to share these 2 techniques that we've been doing. This year, I'm hosting the Asian Shoulder and Elbow Association meeting, later part of the year in November. And I hope to welcome all of you in person to our country very soon. So thank you very much for your kind invitation, and I'll be happy to take any questions at this point in time. Thank you very much.
Thank you, Dr. Danny Lai from Singapore. Such a new thing, subchondroplasty, making us familiar with the subject and so elaborate and nice discussion. For your information, you have been honored by being a chairman of our next session. It will session 2. It will be session 2. We'll announce you and be with us. I'm now feel honored to invite once again our honored speaker of India, Dr. B. Shivashankar. If he is orthopedic association, president of Indian Orthopedic Association, Dr. B. Shivashankar, if he is available, I will offer him to present his paper and if he's not available, I'll go for closure of the session. I beg apology to everyone, those who have asked question. I see there are 6 questions in chat box. I will thank once again all those speakers, learned speakers, for their enriched deliberation and nice information. Before leaving, I will hand my mic to our chairman of scientific committee to thank once again our speakers and guests.
Excuse me. Thank you for attending all participants for a beautiful sessions, and there are beautiful paper presentations and newer things here. Now we will move on to our most prestigious lectures, Boscon oration. So, with the kind permission of the President of Bangladesh Orthopedic Society, can we move forward to the Boscon oration lecture, sir? Okay. I would like to request Secretary General of Bangladesh Orthopedic Society and President invite our President of APOA for the Boscon oration.
Thank you, sir. This is a very prestigious lecture in Bangladesh Orthopedic Society conference for consecutive 3 years. Boscon oration. Today, the Boscon oration will be deliberated by Professor Dr. Mahmood Nedim Doral, the President of APOA, Asia Pacific Orthopedic Association, and the topics included ethics, diplomacy, friendship, and communication for the sustainable development of international orthopedics. I would kindly request Professor Dr. Mahmood Nedim Doral, please connect with us and deliberate your Boscon oration lecture. I would hand over the mic, the President of Bangladesh Orthopedic Society, Professor Dr. Muhammad Abdul Ghani Mullah.
Professor Mahmood Doral, he is our good friend. He is a good orthopedic surgeon in Turkey and all over the world actually. He is a very good organizer. He is a very good organizer in the field of orthopedics in all the events, particularly in the Asia Pacific Orthopedic Association, EFORT and SIGOLD also. And he's a very good friend to our Asian countries, particularly in Bangladesh, good friend to Professor Shahid also, and good friend to us also. And I would like to, this is the time, we invite you, always our seniors could do the things. The Boscon oration for last few years, it was given by the foreign faculties, those who have a very good contribution in the respective subjects. And this subject is consists of ethics, diplomacy, friendship, communication, particularly in the EC, this is disciplined, and the future doctors' recommendation. So Dr. Mahmood, Professor Mahmood Nadim Doral is the honorable man in this time So I would also invite you to come to the dais and blessings your valuable speech. Professor Nadim Doral. Professor Nadim Doral, please.
Thank you. Do you hear me?
Yes, sir. Yes, please.
Okay, you see my presentation too?
Yes, sir.
Okay, thank you so much. Dear President, Professor Molla, the General Secretary of Boscon, my friend Said Shaul Islam, and the Minister of Health, Professor Alal. I want to express my gratitude on behalf of APOA, Asia Pacific Orthopedic Association. I am a little bit far from your country now, 5,400 kilometers. I'm in Ankara. It's my honor to be with you. This is the technology, and I'm very happy. Many thanks indeed for your kind invitation. A little bit, we have to talk about the philosophy because the life starts by the philosophy, completed by the philosophy too. Ethics, diplomacy, friendship, and communication all are the main topics, major topics in philosophy. First, I want absolutely to come to Bangladesh one day because Cox's Bazar Beach is the longest natural sea beach in the world, running 150 kilometers. It will be very nice to walk on this border, promise. And after that, I want to say thanks to our friend's scientific secretary, Professor Uzaman too. As you know, the pandemics, COVID-19 is a big enemy nowadays of our planet. We have two major ethical convictions because ethics in this kind of bad events, we need the ethics. Utilitarianism is very important, ethically doctrine that determines right from wrong by focusing on outcomes. The most ethical choice is the one that will produce the greatest good for the greatest number and negative liberty. There is a difference between the profits and utilitarianism. With respect to Jeremy Bentham, he said the sad truth is that it is the greatest happiness of the greatest number that is the measure of right and wrong. Alternative approach about ethics of virtues, Aristotle, Anscombe, McIntyre, do not forget these big three names. Full realization of every individual human life. Happiness is independent of age or relative weakness. Virtues, generosity, prudence, courage, and freedom. Look at the global health ethics. Global health ethics encompasses issues and relationship depth from micro level interactions to supranational structural level. There are some differences between global health and international health. Look at the cooperation, for example. Solutions often require global cooperation. Solutions require by a national cooperation. Objectivity, health equity for all pupils, regardless of nationality. Six, to help those in other countries in international health, particularly through aid going from high income country to low income country. Look at the virtue ethics in a value driving world. Bias in orthopedics, great value to our patients, very real risk to us. Careful selection of higher risk of patient for surgery, attention to risk of biases, misdiagnosis, mistreatments. And on the other hand, medicine is a state of art, as you know well. Clinicians, ethicists, community should come all together always. Mostly in this kind of pandemic. As surgeon, we all worry now, internal, external risk, but good judgment and do the right thing honestly in the face of this time's uncertainty. To be a friendship, to be a leadership. Leadership to be should be a friendship is not so simple. If the leader said, "Follow me," he should say something right, not wrong, and the follower should know where they will go. Boss says go, but real friend like a leader says let's go. Look at the PubMed, the friendship, keywords, friendship and orthopedics, traumatology, sports medicine. There is zero, impossible to find any publication. But we know in the philosophy that a true friend sees the pain in your eyes, even when you have a big smile on your face. Friendship is not about whom you know the longest, it is about who came and never left, said Paulo Coelho. Amigo is a close friend. He shares your secrets. A camarado, co-workers. He is your colleague. If your comrade is at the same time is your friend, amigo, friend, it will be really better. A leader is one who knows the way, goes the way, and shows the way at the same time, said John Maxwell, like a good friend. Don't fear the enemy who attacks you. Fear the fake friend who hugs you. Very important. Do not forget this too. Look at Francis Crick. He said, a good scientist values criticism almost higher than friendship. No science criticism in no hate and measure of friendship. Look at the aspect of this boxer. There is no friendship in this kind of sports. And we said Olympic. There is no place of, from my side, this kind of high level of energy and contact and the Olympic idea. Look at the eyes of the boxer. This is not good. There is no friendship in this kind of sports. True friendship, there are some in fidelity, respect, sincerity, transparency, cooperation, veracity, supportivity, conscience, common sense, and some out. Hypocrisy, sordidness, limitless, jealousy, betray. Negotiation is the diplomacy, one part of diplomacy. In negotiation, we should talk. Agreement, skills, communication, tactic, contract, collaboration, goal. This is the strategy. There is a strategy in the negotiation. And in diplomacy, the different kind of diplomacy can be seen in the slide. There are a lot of diplomacy. The main topic is to talk, to negotiate. If there is no diplomacy, if there is no negotiation, no peace, war comes easily. Look at the British soldiers in Dardanelles, in Turkey, in 1940, between 1940 1916. Sustainable development. There are some goals, 70s, maybe 107, but no poverty, zero hunger, good health, life on land, partnership for the goals, etc. And I have a big respect to Confucius. If there is a discrimination in the world, the work comes easily. Among truly educated persons, there is no discrimination. For this, education is number one, health and education. For this APOA, our big family, 24 countries in this territory. Don't forget, 3 billions, more than 3 billions live in this big territory. And the discrimination, we should be careful from the discrimination. For this, we need the education. And APOA give every month, every 2 months, some virtual courses, instructional courses, education, and we have a big respect to education in APOA. The other point, Alliance of International Organization of Orthopedics and Traumatology. We have 5 society association, APOA, IFORT, Pan-Arab Orthopedic Association, SICOT, SLOUT. This is the joint statement of human rights. For this, I want to thank to my friend Önder Aydingöz from Turkey. He was one of the past president of IFORT. He is the starter of IoT, and I know that this group will continue. This is not a society. This is not an association. This is a family. This is only joint statement will be more successful in the future. Connectivity is very important. Human artificial intelligence, online virtual reality, augmented virtual reality, web technology, limitless. Sometimes we should be very careful with, for example, 5G connectivity wars, the hackers. There is a very big problem with the connectivity war. Do not forget this. For this, we should protect always the ethics. Beginning of a new digital era after COVID-19, I wrote the editorial folder with my friend Professor Bilge for APOA meeting, APOA journal, and for the future we should be again careful, because this pandemic will continue from my side, from my view, more than 4 years, 5 years, and another pandemic will come. For this, we should be very careful. We should negotiate communication, respect to the communication, ethics, and friendship. This photo is very enthusiastic from my side. Again, what will we do without them, said the young generation, in this kind of pandemic? At the same time, the big war, atomic bomb, that's always the same. Tsunami is the same. Earthquake is the same. John Lucena said this. This is one of my favorite photo in my lab nowadays, of course. Science, silence, existence. Big respect to Mevlana. He said, be silent. Silence is not a shame, it's an honor. The other hand, silence is the language of God. All else is poor translation. In Spanish, tranquilo, mas puedes escuchar. And the take-home message, look at the amigo, is not the same of camarado. Close friend, sharing your secret. Camarado is a co-worker. As I said before, if you are a camarade, you should be at the same time amigo, because you should protect all the secrets, all your co-workers. The ethics is a big topic in this kind of strategy of life. There is a big difference between patronage and diplomacy. Again, I said before, current global need for strong physicians, friendship and connectivity, integrity and fairness. Of course, do not forget good social relationship, teamworks, and hobbies. For example, I play drum. I am a jazz drummer. I play guitar. I played basketball. And nowadays, I continue to be a horseback rider. And do the right thing with right data at the right time, at the right situation, position, for the right reason, goal according to science always. And we, for the sustainable development of the world orthopedics family. Look at the books. I was editor in 4 books. This kind of approach of science is the connectivity, friendship. You should be ethics, and you should be diplomat, because you accumulate all friends from this planet for writing some new books in different topics. And do not forget to participate to our next meeting, which will be held in Kuala Lumpur, end of July 2021 this year. Let's meet in July 2021 in KL. Thank you very much again. Regards from my clinic, regards from APOA family, and thanks to my friend Onur Bilge for his collaboration always. And thanks to all of you, and see you for the next time. Regards.
Thank you very much. Thank you, Professor Dr. Mahmoud Nadim Dural. Probably we have met you 2 years back. Professor Iqbal Kavi, Professor Shahidul Islam and me attended in Malaysia, Kuala Lumpur. And we are eagerly waiting to meet again. But the pandemic COVID make us apart. Hopefully, we will be again close. The scenario will change. The Creator will look after us so that we can meet again in July 2021 at KLM. Thank you, Donald, for fantastic presentation.
Thank you so much.
It's a topic that make us many changes. What is leadership? What is friendship? What is colleague? What is patronizer? Thank you very much. And you are cordially invited in Bangladesh when the situation permit. Thank you from the sides of Bangladesh Orthopedic Society to be a part of Boscon 2021. Thank you again. We are grateful to you. Thank you very much.
Thank you.
Professor Doral, thank you for your fantastic presentation regarding ethics, leadership, spiritual. My Secretary General has said already everything. I only want to give an invitation that you come to Bangladesh, very friendly country. As we are the APOA member, we have the APOA active member. You, Pakistan, India, Bangladesh, Kuala Lumpur, and others, Korea, Singapore, Japan, all are the very much enthusiastic and interested person of, and also Australia, TEDMA. So you are
Pacific Island,
grateful to us. When you talk with us regarding this speech, then and there Professor Shoaib said that Doral is the nice man, because Doral is the president of APOA. So then and there we agreed, and Professor Shoaib invited you, and thank you, Professor Shoaib, that because Professor Shoaib was now a member, but he was the Secretary General just 2 years back. So Shoaib is not only the member of the Bangladesh Orthopedic Society, he will be the part and parcel of the Bangladesh Orthopedic Society. So we cannot give you the crest, and we cannot give you any blessings or shall or like any presentation, but we have given our wholehearted blessings to you so that you can alive for a long time and give your contribution for the world and give your contribution APOA and also in the world. Thank you very much. Thank you very much. Again, invite to come to Bangladesh. Thank you very much.
Thank you. Thank you so much.
Okay, my dear friends and colleagues from home and abroad, after the very encourageous lecture, Boscon oration lecture from Professor Mahmoud Nadim Dural, the President of Asia Pacific Orthopedic Association, we will move to our next session, session 2. Thank you, Dural. Please, if possible, you enjoy or you can go for your other activities. Thank you for coming with us. So our next session, the chairpersons of the sessions are Professor Ramdev Ram Kairi, I am Professor Dr. Syed Shahidul Islam, and Dr. Danny Lee. Please connect Dr. Danny Lee from Singapore. Administrator, please connect Danny Lee from Singapore. So before his connection, I want to invite Dr. Bijendra Singh. Bijendra Singh from India, and his talk will be terrible trade injuries. Very important topic. Dr. Bijendra Singh, are you connected with us? Okay. Please enjoy the lecture from our friends from India, terrible trade injuries. And I will request Mr. Saidul Islam, please get ready from Bangladesh for his presentation, second presentation. So we are running short of time. Try to complete your lecture within time. Okay. Okay, we can see you and your presentation.
Hello, greetings from the UK. My name is PJ Singh. I'd like to express my sincere gratitude to the organizers of the meeting for giving me this opportunity to talk on use of strut graft in fractured proximal humerus fixation. There's no conflict of interest related to the talk. The reason why I'm talking about this is to avoid failure. Failure of fixation in the proximal humerus fracture can be related to surgeon, patient, or the fracture factors, but generally it's a combination of one or more. Certainly the patient and the fracture factors are difficult to manage, but we can use techniques by where we can reduce the incidence. Patient personalities, if you've got an alcoholic, a smoker, elderly age group patients, then there's a higher incidence of failure following fixation. And this is an example to show that in a sort of patient with early 60s, displaced fracture, two-part fracture, which I often find quite very unstable. Had a fixation by a colleague of mine. I agree that it's not the best fixation, but it was reasonable. Unfortunately, the patient kept picking on the wound and did not let it settle, and in 2 weeks this got infected and the fracture fell apart. Surgeon personality is an important factor. So is an example of a 30-year-old male who fell whilst drunk, sustaining this fracture dislocation of his shoulder. This was attempted to be manipulated in the A&E department, but unfortunately the humeral head was left behind. The surgeon who did this, this was a few years ago when MIPA was in vogue, thought they could do a minimally invasive technique, but unfortunately they did not reduce the fracture very well. And one could say that this was a day one failure or on-table failure, which can be seen later on. This patient went on to develop avascular necrosis. a third example of a slightly older age patient with a fairly complex fracture. Unfortunately, the surgeon operating on this did not pick this up and fixed with the position in varus, and I can anticipate that there was lack of medial continuity, which the surgeon did not appreciate. And this was what the outcome was. Eventually, the screws cut through and the patient needed a reverse polarity shoulder replacement. The number of proximal humerus fractures that we see that are being operated upon is on the rise, so is the complication rate. The epidemiological study shows that it's about 75 to 80 per 100,000 population, and about 20% of these will present as a challenge for management, whilst majority are managed non-operatively. If we look at the anatomy of the proximal humerus, this is conceptualized on the three growth plates, has a greater tuberosity, lesser tuberosity, and the head. The head shaft angle is about 135 to 140 degrees, and the humeral head is in retroversion of 0, neutral, to about 20 degrees. The blood supply is quite vital, and this is one of the papers that is commonly quoted by one of my previous bosses, who showed the posterior circumflex humeral artery and the anterior circumflex humeral artery, which forms the arcuate artery, have an anastomosis which supplies the humeral head. And they found that if the head fragment extends distally below the articular surface, then the medial perfusion may persist. If not, then there is a greater risk of avascular necrosis. A study in 2010 looked at the blood supply again, and this showed that the posterior circumflex humeral artery actually contributes 2/3 of the blood supply to the humeral head, and the anterior circumflex provides only 1/3. And they also found that the posterior circumflex humeral artery is more flexible and has more branches, and hence less likely to disrupt the blood supply to the humeral head, which may explain the not so many numbers of AVN that one would expect based on the first study. So how do we know which patients will have a poorer outcome? Various surgeons have used different methodologies to predict this, and the common one is the reduction, osteoporosis, and restoration of the medial cortical continuity. These two papers highlight what there's a number of papers highlighting the same. Now, unfortunately, osteoporosis is beyond our control, but certainly the reduction and the establishing of the medial continuity and medial support is something that we can help with. This study by Chow et al. Shows what I'm going to talk about. So they looked at fresh frozen paired humeri and used the humerus, used a fibula as an intramedullary graft. They removed a centimeter wedge from the surgical neck and performed the osteotomy, and then loaded the fixation after the fixing with a locked plate, and they undertook 25,000 cyclical loading. And you can see the specimens which had the augment, except one, all of them sustained the 25,000 cycles, while in the non-augmented one, only 2 out of the 8 sustained. In fact, none of them got over 10,000 cycles. And they concluded that fibular allograft augmentation increased the ability of the locking plate to withstand repetitive varus loading, and they hope that this may help clinically as well. Based on that, there was this study published in 2018 by Kim et al., looking at 164 patients, although it was retrospective, quite a large study, with over looking at 3- and 4-part fractures in the age group of 65 and more. These 2 years follow-up, and the two groups had nearly half with fibular allograft, and half of them had a medial calcar screw. The patients were well matched for age, sex, dominance, interval to the operation, and the mechanism of injuries. However, they found, interestingly, that there was a significantly better VAS and constant score in the four-part fracture in patients who had the fibular allograft. And in the image post-op radiographs, they found improvement, which is maintained up to 12 months and the 2-year mark in both the 3-part and the 4-part fracture, more pronounced in the 4-part fracture. And they concluded that use of a fibular allograft technique is considered a primary additional procedure for medial support in patients with 4-part fractures involving medial metaphyseal comminution. A smaller study looking at 50 patients with a fairly wide age range with a minimum of 12-month follow-up, and they found similar results, that the neck shaft angle was better maintained, so was the humeral height, and was better with the strut graft. I generally tend to use a deltoid split approach, but equally deltopectoral approach could be used. I always identify my landmarks, especially the axillary nerve, and isolate during the procedure. Let's just show you a couple of examples. So this is a young 45-year-old male who on first view looks like a fairly innocuous looking fracture. But if you look closely, there is a double shadowing of the humeral head, which raises suspicion. And a CT scan does show a head split fracture, although most of the articular surface is intact. Is a fairly large chunk going into the lesser tuberosity, and further splits across into the humeral head. So this patient, when taken, you can see the split further into the humeral head, which was fixed with headless compression screws, and you can see there is no varus continuity, and once you put an allograft, that continuity gets established quite nicely. Although we started with a better position, the final fixation, the reduction did go into slight varus, and at 1 year, the fractures healed well, and the patient had a reasonable outcome functionally. Second example is that of a slightly older age group patient, 55, with a fracture dislocation of the shoulder and multifragmentary at least 4 parts. And this again, on the first view, looks that it's has no medial continuity, and there is medial comminution. In this one, in fact, the medullary canal was fairly wide. I ended up using 2 allografts, and this was to a point where one could argue about doing something replacement-wise, but given the younger age group patient and demand, decided to proceed with the fixation. And we did get a reasonable fixation, although it went in slight varus. Overall, it healed well with a reasonable outcome. An example of a 52-year-old female who fell from a height, 3-foot height. And again, these looks quite innocuous, but I suggest that if you want to treat them non-operatively in these kind of injuries, always get a CT to look at the fracture more closely. Again, despite this going into varus, we thought maybe give it a bit of time to see if this gets better. And at 2 weeks, the fragment had in fact gone into more varus, and hence we decided to take her for surgery. And again, you can see that the medial calcar is broken, and this was an unstable fracture. And applying this wedge allograft, we managed to reduce and make the fragment quite stable and get a good reduction and fixation. Just going to show you a short video of the technique that I use. So this is showing the 2 positions where the reduction is possible, but because of the medial comminution, it's very unstable. So we decide to proceed with introducing the allograft. In my hospital, we have the allograft on shelf, which is a freeze-dried one, and we can use that. I mark out about 8 to 10 centimeters of the length we generally have a split femur or a split tibia and do a blunted oval shape or half an oval shape graft. I always mark them, draw them on the bone first. And then I keep slightly longer taper, which goes into the medullary canal, and it makes it easier. Mark it out with some K-wires, so there's less chance of slipping off the saw. And then using an oscillating thin saw, use a wider one, then it's likely to rattle around and cause split of the graft. So once I have the graft, I will insert that into the medullary canal and attempt the reduction. So what this does, it sort of wedges in between the shaft and the humeral head. And because it's wedged in the shaft, it cannot collapse and stops the humeral head from collapsing into varus. And you can see that's the new position. On the left, in my hospital, we have the allograft. May have to adjust it to get the adequate position. Then you cover the tuberosity on top, and you can see I can manage to get a decent reduction. Have a split femur or a split tibia, and do a blunted oval shape or half an oval shape. Once the reduction is achieved, I always mark them, draw them on the bone first. Then you can either tie the sutures on top, as I will be going to do here. Mark it out with some K-wires, so there's less chance of slipping off the saw. Or you can pass the sutures through the plate. But on this one, I'm going to suture this, which makes the upper end, fractured upper end, back into a normal looking humerus. And then it's almost akin to putting a neutralization plate at the end, or once this has been reduced. Sometimes, because of the anesthetic, the greater tuberosity can be quite mobile, and care needs to be taken that you don't distalize the greater tuberosity too much. So here I'm tying the sutures to close the hook, so to say, or the tuberosities. Once I've done this and I'm happy with the position, I will take a locking plate and gently put it under the axillary nerve. Now, if there are less numbers of sutures, you can always pass more sutures through the cuff, as I feel these are vital in the stability and fixation of the proximal humerus fractures. Once the reduction, this is the suture on the top. So now I've got 3 sutures, one at the back, one at the top, and one at the front. Then you can either tie the sutures on top, and then this is one of the locking plates. You can use a block that comes with the device, or I generally tend to put a locking chimney, which gives me enough support to manipulate the plate, as well as avoid, makes it difficult to drop. The upper end, fractured upper end, back into a normal looking. So I'm passing the sutures through the holes on the plate. A neutralization plate at the end. Once I've done that, I will start to tie this together and then proceed to a standard fixation of the proximal humerus. Generally start with the oval hole, which allows me to adjust the height of the plate. Close the hook, so to say, or the tuberosities. Once I've done that's the check on the plain radiograph to see what it looks like. Gently put it under the axillary. And then this is what it looks at the end after the plate goes on and after the plate. And a year down the line, this has healed very well indeed. So in summary, it's key to identify the cases preoperatively. Beware of the very simple looking three-part fractures. Look out for the medial hinge or the medial combination, and I certainly have very low threshold to use an allograft. At first it sounds quite daunting, but as you practice, it becomes easier. Thank you very much for your attention.
Thank you, Dr. Bejanandra Singh, for your beautiful presentations. I want to move forward. I want to call Dr. MD Saidul Islam from Bangladesh.
Okay.
This topic is minimally invasive treatment for anterior pelvic ring disruption with pedicle screw rod fixation, an initial case series. Please welcome Dr. MD Saidul Islam from Bangladesh. Dr. Saidul.
Yeah. Can you
you
see
hear
the
me?
screen? Yeah, yeah.
Okay,
Can you,
please try to finish within time, please.
okay. Can you see the screen?
No, no, we are not seeing your screen. It's still now. Yes, yes. Okay, continue, please. Direct.
First, I want to express my gratitude to organizers, especially President of Bangladesh Orthopedic Society and Director NITOR, Professor Abdul Ghani Mullah, and Secretary General Waidur Rahman. Dear audience, my topic is minimally invasive treatment for anterior pelvic ring disruption with pedicle screw rod fixation in fixed technique and initial case series. They are my teammates in Dhaka Medical College Hospital. A 35-year-old male road traffic accident, open book fracture type 2 with rectal and urethral injuries. Colostomy and suprapubic catheterization done by casualty department. Then they referred the case to our department for definitive management of pelvic fracture. Now, in this scenario, what are the options? First option is conservative, but its morbidity is very high. Second option is application of external fixator, but they have more disadvantages like loss of reduction, pin tract infection, loosening, and morbidity. Next option is internal fixation with plate and screw. But in this scenario, the rate of infection is very high. So these are the conditions that are contraindicated for internal fixation with plate and screw. Now, what is the alternative? Alternative is infix, that is internal fixator. Now, what is infix? Infix is subcutaneous placement of pedicle screw rod fixation, which avoid pin tract infection, loosening of the pin. It is a new technique, employs the principles of external fixation and use substitute for internal fixation in managing unstable anterior ring fractures. Biomechanically, it is more stable than external fixator, but less stable than internal fixation with plate and screws. 9-year-old boy, road traffic accident with rectal injury with open book fracture type 2 injuries. At first, colostomy was done in casualty department. After 3 months, they closed the colostomy. We do the application of infix. At 6-month follow-up, the boy is walking normally. Another patient, 35-year-old male, road traffic accident with urethral injury with open book fracture type 3. The X-ray shows posterior ring injuries and anterior ring injuries with open book type 3 injuries, with urethral injuries leading to suprapubic catheterization. Perioperative CM views, application of percutaneous cannulated screw for posterior fixation, posterior fractures, and follow-up X-rays. Follow-up at 7 months. This shows the at 7 months the patient is well, walking well, and they complete no problem. Patients and method. This was a prospective study done in Dhaka Medical College Hospital during July 20 to February 21. Inclusion criteria: unstable pelvic injury, recurring anterior fixation in all ages, and exclusion criteria was acetabular fracture. All patients evaluated and treated according to ATLS protocol. Fracture was evaluated by AP inlet outlet pelvic radiogram and CT scan. Patients are followed over phone or in clinic and assessed for functional outcome score using Majid score. Method: these are the pictures of instrument needed for setting in fix. Pedicle screw needed 60 to 120 millimeter with at least 6 millimeter diameter. Rod at least 6 millimeter diameter. Placement of the screw identified by C-arm, obturator oblique view by keeping a metal object to see the location over the supraacetabular region in anterior inferior iliac spine. This is the surface marking. This is the anterior superior iliac spine. This is the anterior border of tensor fascia lata, and this is the sartorius. So incision vertical 1 to 2 centimeter over the anterior inferior iliac spine in between the two muscles. That is, the incision is intermuscular. Skin and subcutaneous fascia is cut in same line. Then peeling of anterior inferior iliac spine and deep fascia was cut. For wide exposure, use woman's forceps, and obturator oblique view was done to identify the tear duct, which is the safe zone of placement of the screws. This is the safe zone. Then iliac oblique view is done and obturator inlet view is done to see the passage of drill bit in safe corridor. The screw is applied, inserted, and then plate rod is bended by plate bender. And rod is placed along the bikini line. This is the bikini line. And this is the diagrammatic picture to show the position of the rod subcutaneously, but superficial to deep fascia and superficial to rectus sartorius muscles. This is the short video. After application of the screw on both sides, application of the bended rod subcutaneously. Then one end of the rod is fixed with cap screw. Then reduction of fracture is done by applying pressure on both sides of the ilium. Then second cap screw is applied to fix the rod. This is after stabilization of fracture and stabilization of the rod with cap screw. Result in our series, 20 patients are operated. Mean age was 35 years. Among the injuries, ABC type 2 was in most of the cases. Urethral injury was most associated injuries. All patients are involved in motor vehicle accident. Mean severity score was 20 plus minus 5. 15% of the pelvic injury was unilateral and 5 were bilateral. 8% only anterior subcutaneous pedicle screw rod fixator was done. And in 12 patients, infix was combined with posterior fixation. In one patient, implants were removed at an average 5 months postoperatively. All patients were followed up for at least 4 months on average. 2 patients feel numbness over the lateral femoral cutaneous nerve. In one patient, implants reduction was lost due to implant loosening. Quality of reduction was excellent in 5 patients, good in 9 patients, and fair in 6 patients. Mean age of Maji's functional score was 75.65. That is his good score. Discussion. Rahul Bodha studied 91 cases and they concluded that heterotopic ossification in irritation of the lateral femoral cutaneous nerve was most common in their series. Another study done by Reed, Wikan and Lee, they concluded Infix produces excellent outcome in pelvis fracture with risks of infection where anterior plating is contraindicated. Take home message, it is a minimal invasive, good alternative to external fixator and internal fixator with plate and screw where it is contraindicated, need CM and need some expertise. Thank you very much.
MD Saidul Islam for your beautiful presentation of Infix. So we learn new things from you and please continue your great works. Now, I would like to request the most vibrant leadership in future APWA, the Secretary General of Asia Pacific Orthopedic Association, Dr. Jamal Ashraf, please join with us with your presentation. We heard your presentation in the morning, a beautiful presentations. Now we want to learn more from you about the calcaneal fracture, why fix. Welcome, Dr. Jamal Ashraf.
Thank you, Dr. Shahid. I'm just going to share my screen now.
Yes,
we
can see your presentation.
Okay. Thank you again for the invitation. Now, the major controversy surrounding calcaneal fractures is always whether to operate or not to operate. Why is it not changing? Yeah. Now, this is an article that was published in the British Medical Journal that looked at this controversy. And the article concluded by saying the operative treatment was equal to non-operative treatment, but was associated with more complications, and went further on to say that operative treatment is not recommended for these fractures. So I suppose the controversy is settled, my talk is over, and I should finish now. Or is it? There are always dangers to a one-sided story. Don't take one opinion too seriously. Look at facts for yourself. Now, this is a medical student who was studying in China. Her family belonged to Lucknow. She sustained a fracture of both the heels in Guangzhou, flew over to our city. When she presented to us, she had displaced intra-articular fractures of both her calcaneum. As you can see, on the right side, the Bowler's angle is 0, and on the left side, it is negative. And if you further see, the posterior facets are in fact facing posteriorly. And if all that wasn't enough, there is marked comminution of the body of both the sides. Now, what should I tell her? Look, doctor, the BMJ says that there is no point operating on you. So what I'll do is I'll just put you on cast and let you be. Or should I actually be providing her with something better? What is my plan of action for both her sides? Now, when we look at the international literature, we find that the Iowa calcaneal score for conservatively treated patients is as low as 60 to 70. Patients often continue to experience pain with activity limitations. They often require special shoes or insoles. And should I be telling her this? Or being a medical student of dermatology, she wished to fare better than this. And therefore, we decided to proceed with internal fixation of both the sides. On the right side, after an extensile approach, we did an open reduction internal fixation and applied a calcaneal plate. On the left side, After turning down the lateral wall, we visualized the posterior facet, which was actually facing towards the TA. It was elevated and repositioned, temporarily maintained with K-wires. The defect was filled with bone graft. The anterior facet was also repositioned. The remaining defect was packed with chronos, artificial bone grafts. In addition to filling of the gap, this also provides a conducive environment for fracture healing. And finally, the lateral wall was repositioned. Now, once we are satisfied with our positioning on AP and lateral views, and we placed a positional screw to fix the facet, and finally contoured 1/3 semitubular LCP and extended it up to the cuboid as she had a fracture running into the calcaneocuboid joint. This is the follow-up at 1 month. Follow-up at 1 year. She has near normal range of movement, though okay, and can occasionally wear heels also, but not for long durations. At follow-up of 18 months, she's very comfortable, though there is a little bit of pain on extremes of inversion and eversion. At 2 years, I receive an email from her saying that she's able to jog a little, sends me this photograph where she has graduated from Guangzhou Medical School and got a degree in dermatology. Now, coming back to the BMJ paper, what are we to make of it? Well, it was contradicted point by point by an article published by the renowned foot and ankle surgeon, Dr. Richard Buckley. He had actually presented a multicentric trial of more than 1,400 patients where he had looked at the operative versus non-operative treatment. His conclusions were that operative treatment is better for younger patients, especially for females as compared to males, especially in less community patients, though if you exclude diabetics and smokers. And these patients will have a much better score after surgery. So he stated that non-operative care for displaced intra-articular calcaneal fractures leads to subtalar fusion, which is difficult to treat. Internal fixation is only way to provide the good shape to the patient's foot, and therefore he recommended internal fixation. Now let's look at other literature. This is a paper that was published in the Journal of Trauma, which said that patients who have no subtalar arthritis maintain good results with conservative treatment. But patients with subtalar arthritis deteriorated significantly between 10 and 20 years. Another paper published in the JBJS, which is a multi-centric controlled randomized trial consisting of more than 7,000 patients. They said that surgery is not actually superior at 1 year, but the benefits of surgery are actually visible 8 to 12 years down the line, at which time the conservatively treated patients tend to deteriorate rapidly. So the aim of the surgery is to actually avoid the sequelae of conservative treatment, which would be subtalar arthritis, peroneal impingement, and a widened valgoid heel. So you can get good results with surgery if you can avoid skin problems, hardware problems, and you know how to do surgery. So the indications of surgery would be briefly, all displaced intra-articular fractures should be fixed. Now, what are the factors that are responsible for a successful surgery? You should know the patient well. You should fully explain the prognosis to the patient and always avoid operating on smokers, diabetics, and the elderly. You should have adequately waited for the soft tissue swelling to have subsided and the wrinkle sign to appear. You don't want to have soft tissue complications. You should know the anatomy well. You should have proper imaging, CT scans, 3D reconstruction, and most importantly, you should not be knife crazy wanting to operate every patient. Ideally, for a person who's starting fixing the calcaneum, should start it with an extensile approach. Over a period of time, when your mental faculties and your hand-eye coordination improves, you can proceed with minimally invasive treatment also. Most importantly, please treat the soft tissues like your girlfriend. Tender, loving care. have a three-dimensional reduction of fracture. You'll only have it if you have the mental picture of the reduction in your mind. So the goals of surgery would be restore the calcanean height, length, and the width, anatomic restoration of the joint surface, decompression of the fibular space, and realignment of the tuberosity in a slightly valgus position. Now, these are the two common fracture configurations. One in which the lateral wall, shown by the yellow, is fractured, and the one in which the lateral wall is not fractured. Now, you have to visualize the posterior facet by turning down the lateral wall and looking inside. A sham screw at this point should be inserted to get down the tuberosity, get it down and out and into position. At this point of time, a thin K-wire should be passed from the tuberosity fragment to the sustentacular piece. The posterior facet is to be elevated and the gap is to be filled up. The articular surface is lifted up with a chunk of cancellous bone. In comminuted fractures, the posterior facet should be reconstructed part by part, starting medially. Now, here is the point. Should you be using bone substitutes to fill the void or not? It's a personal opinion. There are controversy of whether it should be used, it should not be used. Personally, I rarely use it. Thereafter, the lateral wall should be repositioned and a K-wire should be passed, holding onto the lateral wall to the sustentacular piece. At this point of time, alternatively, you may want to hold the posterior facet and the sustentacular fragment by a headless compression screw first, and then put the lateral wall in place. That's your choice. Once you have checked the reduction both on an AP and lateral view, you can proceed to applying your final plate of your choice. So this is an example of a calcaneal fracture that was fixed with a calcaneal plate. Now, minimally invasive internal fixation is also an acceptable option, but not at the cost of proper articular reduction. Now, if you ask me, this technique is not as simple as it may appear, but once mastered can give good and excellent results. Indications would be less comminuted fractures, the elderly and the diabetics. But an absolute contraindication is joint depression fractures. In such cases, you need to open it, you need to elevate it, you need to protect it, and then fix it. If you are going to use minimally invasive technique, make sure that you have the correct positioning of the screws. That is to say, the screws should provide you with a three-dimensional fixation. One in one plane, the other, and the third in different planes. Finally, the take-home message would be, understand the 3D anatomy of the fracture to be able to choose the correct treatment. Choose the correct patient to operate, and always place the implant intelligently. Albert Einstein has said that clever people know that only half of what they hear is the truth, but brilliant people know which half is the truth. So my recommendation would be, say yes to operative treatment of displaced intra-articular fractures in selected cases. Thank you for your patient hearing.
We are trying to say yes for calcaneal surgery. Thank you for being with us. You always support us in your, especially for scientific activities, and especially you are giving emphasis on the young surgeons of the upper territory. Thank you again for being with us.
Pleasure
now,
being
I want to request another vibrant presenters from Bangladesh. He is also the president of he is also the president of the Assami International Bangladesh chapter, honored Professor Dr. M.M. Bari. His topic is foot osteotomies in different foot deformities. Foot osteotomies in different foot deformities. Probably he is sick and his presentation will be on video. Please
now
start the video.
I am okay.
Yes, sir, you are okay?
Yes, yes, okay. I am okay. No problem. Thank you.
Do you want to present directly?
Yes, yes. I would like to talk
Thank you,
now.
sir. Welcome, Professor M.M. Bari. Please.
First of all, I'd like to give my special thanks to the organizer of the Boscon 2021. And today I'm going to talk on the different osteotomies that is needed for foot deformities. Next. Okay. 1 minute only. A few seconds. Give me a few seconds. Now, can you see me? Yes. So, dear friends, these are the places that I had the opportunity to walk to different places of the world. This is my institute where I worked more than 10 years. Now I am working here. This is a very big hospital in Southeast Asia, my center. And this is the man, myth, and the method, and the magician, and orthopedic inspiration and miracle of the nature. The Elizar method differs from traditional method, the surgical treatment of the concept of deformity correction over the time. The technical and biological opportunities to achieve deformity correction goal in traditional are frequently limited, but the Elizar method possesses great opportunities and advantages. The gradual and continued coordination distraction of the foot, bone, soft tissues permit to obtain lengthening of the foot. The influence of external force developed by the Elizar device can help in desired form and size with the deformed foot can be created. During deformity correction, we can change the configuration of the device, and that can eliminate possible errors of correction. If you look at these foot deformities, osteotomy of the calcaneum, calcaneal osteotomy, and talocalcaneal osteotomy at the mid part of the foot, and the metatarsal osteotomy. You can do it by closed and half closed. And if you think about the classification of the foot osteotomy, you should think about the osteotomy of the calcaneus, that is body of the calcaneus of the posterior epiphysis, and osteotomy of the subtalar area. Astragal calcaneal osteotomy, anterior astragal calcaneal osteotomy, dome or crescent osteotomy, V-shaped osteotomy, and Y-shaped osteotomy. Osteotomy of the middle part of the foot, when you are correcting the deformity of the cuboid and navicular bone, and osteotomy of the cuboid and the cuneiform bones. Osteotomy of the anterior part of the foot, you shall have to go for the metatarsal osteotomy and osteotomy of the toe phalanges. Now let us see the osteotomy of the heel, calcaneal osteotomy. What are the indications? Calcaneal deformity in the frontal plane, varus or valgus. Calcaneal deformity in the horizontal plane, adduction or abduction. Calcaneal deformity in sagittal plane, equinus or vertical heel. Hyperplasia of heel in complex congenital and post-traumatic deformities. Now here you can see, dear friend, the rectilinear osteotomy correct the equinus with the increase in the height of the heel. Correction of the vertical position of the heel with lengthening. Now you can see here, subtalar osteotomy in the oblique plane is performed distal to the side of the Achilles tendon fixation. These both correction of the flatness and increase the height of the level. A subtalar L-shaped you can do osteotomy is also for the correction of the height of the foot and flat foot. Now you can see the horizontal subtalar osteotomy in combination with the triple joint fusion is used in the treatment of post-traumatic flat heel and hemiplegic foot. Look at this here, how we can go for the lengthening of the calcaneum. Now you can see the rectilinear osteotomy of the anterior appendix of the foot and neck of the talus is used to eliminate cavus foot. If you want to correct the cavus foot, you have to do in this way the talar, neck, and the calcaneum. Performing a crescent osteotomy, you can do a rectilinear chisel and a small lateral incision under the external malleolus. Dome-shaped astragalo-calcaneal osteotomy is also doing for the equinus correction for the mobility of the talocranial joint. And simultaneously, you can correct the supination and pronation with the foot. And you can go for V-shaped osteotomy of the calcaneum and the talus and the part of the calcaneum for the simultaneous correction of the complex deformation of the anterior and posterior part of the foot. Here, treatment of the flat valgus deformity formation is shown. You can see here, Y-shaped osteotomy also can be done for correction of the deformity of the foot. So this is the configuration, how you can gradually correct the deformity of the calcaneum and deformity in the mid part of the foot. Now, rectilinear osteotomy of the cuboid and navicular bone to correct the deformity of the anterior cavus. You can go for distraction, and as a result, you can go for rectilinear osteotomy of the cuboid and the cuneiform bone. This is the correct position of the supination of the foot. Half-ring vertical should be perpendicular to the longitudinal axis of the anterior part of the foot. Now you can see open wide fusion between the internal cuneiform bone and the base of the first metatarsal bone, correcting the flexion and abduction of the foot. You can go for dome osteotomy of the base of the first metatarsal bone. Now, if you want to correct the rectilinear transverse percutaneous osteotomy of the distal part of the first metatarsal, the distal fragment should be displaced outward to remote protrusion at the head of the bone, and is simultaneous turn together with the first toe. Now let us see some cases. 26-year-old man, post-traumatic left ankle deformity, fixed equinus with 4 centimeter LLD with 2 centimeter raised heel. You can see here what we have done. We have done the smiling patient with correction of the LLD, and we have done the lengthening of the radiographic view. You can see lengthening is seen. And this is the healing is touching the heel. And big widening of the calcaneus is clearly seen in radiography of the ankle and the foot. You can see here before treatment, this is clinical appearance of the patient and the full correction of the front and the back view. Now you can see a 6-year-old girl, post-traumatic right ankle and foot deformity with fixed equinus and no heel pad, very bad scar. So you see back of the heel. Now patient is walking in this way. So this is the patient when after application of the Elizarov, the correction of the deformity and ankle foot. Patient can walk with the support of the Elizarov apparatus. So this is after the treatment. You can see clinical appearance of the patient of the ankle and the foot. So this is before, this is after treatment. Full correction is achieved. 35-year-old man with subtalar arthrosis. You can see here ABN of the right talar dome with 2 screws in situ with ankle joint, varus ankle, OA of the right ankle and osteoporosis with claw tools. At the same time, you can gradually correct with the fantastic tool, the Elizarov technique. No claw of the toes, no ankle virus after the surgery, front and back view you can see here. This is before, this is after. So these are the post-traumatic left ankle fixed equinus with deformed foot. You can correct it gradually, and 18-year-old girl, 2 centimeter shortening of the left foot is sequelae of polio. You can see here, we have lengthened the calcaneum and short foot. We have during treatment, before and after. So these are the brachymetatarsia, how you can correct just after application of mini Elizarov metatarsal corticotomy. You can see here. So this is after treatment, and this is the clawing of the clinical view before treatment. You see hallux varus deformity. You can see the X-ray during treatment. This is before treatment. This is the clinical view before treatment. This is after correction. This is the before, and this is after. The man who made it possible, great scientist, talented doctor, gifted innovator, creator of the apparatus and method of transfusious osteosynthesis, academician, Russian Academy of Medical Science. I always try to do the difficult cases. Those who take the easy way have a safe and boring life. Those who difficult way have a tough but satisfying. Those who impossible way are remembered forever. So these are the clinical, animal clinic. You can see how they are doing the destruction in transverse line, destruction in widening process, and this is how we can get the peace by doing the different varieties. This is in pandemic in my center. Thank you so much for your kind attention.
So we love your presentation, so we want to learn from you. Thank you again. Now I want to move from Bangladesh to United Kingdom. The presenter is Dr. Okay, our president of Bangladesh Orthopedic Society want to speak something about Professor M.M. Bari.
Sir, how are you? Assalamu alaikum.
Thank you very much.
Professor Bari, sir.
Yes, sir.
How are you, sir? Assalamu alaikum.
I'm fine. I'm fine.
You are okay.
Okay. Inshallah.
You are now in the home or you in the hospital?
No, I am in the home, my house.
Oh, you are in the home.
I'm in
So
home.
your COVID test is negative now?
Now,
So
inshallah.
physically and mentally you are okay?
Mentally, now I'm fit.
No other symptoms you have?
No. Thank you very much for your kindness.
Okay. Thank you very much. Pray to Almighty.
Inshallah.
Okay, for your early recovery. Okay, sir. Assalamu alaikum.
Hello. Now the presenter is Dr. Shiraj Haq. Shiraj, can you hear me?
Yes, I can hear you. Can you hear me?
This is Qazi Shamimud-Jaman, Scientific Secretary, Bangladesh Orthopedic Society. And frequently you have contacted with me. And
yes.
You are evaluating a young surgeon and originally born from Bangladesh and brought up in England. And he is relative of Dr. Moinuddin Chowdhury. Several times we had connections. So now this is the time. We are waiting for your presentation. Thank you, Shiraz.
Can you see my screen?
Yes, we are hearing.
Okay, excellent. So good afternoon. I hope you're all well and safe. Thank you for inviting me to speak today. My name is Siraj and I'm calling in from Dundee, Scotland. I will be presenting my project, an audit rate of removal of distal volar locking plates in a busy trauma unit. So first of all, an introduction of who I am. My name is Siraj Haq and I'm a junior doctor from Scotland. I studied medicine at the University of Dundee and I've worked in Dundee as a doctor for 2 years. I have an interest in trauma and orthopedic surgery and I'm applying to train in this specialty. So a little background on the project. Distal radius fractures are a common injury in the UK with numbers anticipated to rise over the next 20 years. These fractures are commonly managed with open reduction and internal fixation using a volar plate and locking screws. This treatment modality has the benefit of providing biomechanical stability as well as allowing for early rehabilitation and return to function. Removal of these plates is an area of controversy. There are some surgeons who would never remove a plate if the patient is asymptomatic, whereas there are others who routinely remove all their plates after a certain period of time. The rationale for routine removal is the avoidance of future complications of leaving the plate in situ. So certain European countries, as well as Japan, have been noted to have relatively high rates of plate removal of around 20% or more, whereas countries such as the USA have quite low rates of removal at around 3%. Overall, the global reported removal rate is around 9% from the literature, and in the UK, it's 6%. Most of the data is from a systematic review published in 2017 by Yamamoto et al., who reviewed 52 studies on volar locking plates removal. They found that when plates are removed, that routine operations were the most common cause, followed by tendon irritation, hardware issues, and patient requests. Interestingly, they noted that there was a strong statistical correlation between removal rates and complication rates, and overall concluded that plate removal does not lead to an improved clinical outcome. The aim of the present study was to investigate the rate of distal radius plate removal in our trauma unit and find out the reasons of why this was done. So our methodology, this was a retrospective audit. Data was collected on patients who had undergone fixation of a distal radius fracture with a volar locking plate in Nine Walls Hospital, Dundee, which is a major trauma center. Patients were identified from historic trauma lists and cross-checked with online records. Data was collected from an 18-month period between the start of January 2016 and the end of June 2017. The following pieces of information were collected: whether the implant was removed, patient demographic information, fracture characteristics, radiological outcomes, and complication rates. Data was collected through our online record system called Clinical Portal and radiological data from our X-ray system called PACS. So moving on to results, a total of 223 patients were identified. The average patient age was 55, but this included an age range from 15 through to 100 years old. As would be expected for kind of trauma fractures, there was a significant preponderance for female patients compared to male. Overall, 228 wrists were operated on, mostly on the left-hand side with 5 bilateral fractures. The same implant brand of Zimmer Biomet was used for all patients involved. Of the 223 patients, complete follow-up data existed for 211, and 205 patients had a recorded clinic follow-up. Unfortunately, 12 patients moved away from Dundee area, so were lost to follow-up. On average, patients in this study have 43 months of follow-up data with a minimum of 35 months. So moving on to the results, the main finding of this study was regarding plate removal. Of the 211 patients with follow-up data, only 2 had their distal volar locking plates removed. For one patient, this was due to multiple infections of their operation wound, and the other had issues with pain and irritation at their plate site. This resulted in an overall plate removal rate of 0.95%. So overall, out of 211 patients with follow-up data, 17 had recorded complications. Beyond the 2 patients already mentioned, we had 6 patients presenting with complex regional pain syndrome, 4 with a nerve injury such as carpal tunnel, 3 had an extensor pollicis longus rupture, and we also had 1 compartment syndrome and 1 non-union. This overall gave us an 8% complication rate. Moving on to fracture characteristics, the majority of patients had ulnar involvement in their fractures, as well as being comminuted with articular involvement. A very small proportion had open fractures in the cohort, so only 1.8% were open fractures. So we further classified our cohort using radiological data. For this, we used the Frickman and LaFontaine classifications. So Frickman classification assesses the pattern of the fracture. So type 1 here is a metaphyseal fracture. Type 3 involves the radiocarpal joint. In type 5, we've injured the distal radioulnar joint. And in type 7, we've affected the radiocarpal and distal radioulnar joint. The even numbered fractures, so 2, 4, 6, and 8, have ulnar involvement with the respective radius fracture. As you can see from the table, over half of our cohort had type 8 fractures, overall suggesting a more severe comminuted fracture pattern. For the LaFontaine classification, this pertains to stability of the fracture, with these listed factors here leading to an increased risk of loss of reduction. Around 66% of our patients had a score of 3 or greater, and overall this data suggests that internal fixation with a plate has been a sensible management choice, given the comminuted and unstable fractures that most of the patients have presented with. So we've also measured the following radiological factors of volar tilt, radial inclination, radial height, and ulnar variance. Overall, these results were kind of acceptable numbers for post-op fixation. So overall, the plate removal rate in our center was less than 1%, and the complication rate was around 8%. Both of these are less than the global average reported by Yamamoto et al. Thinking of why this might be the case, first of all, our unit has a firm policy of avoiding unnecessary plate removal, as well as having a kind of significant senior input for patients, both during decision-making and the procedure itself. Having the guiding hand of experienced surgeons has undoubtedly led to better outcomes. So in conclusion, our study reports very low removal rates of distal radius locking plates, and this is a practice which is supported by the existing literature. Thank you for listening. I'm welcome to taking any questions, and I'm just going to leave you with this picture of the beautiful Tay Bridge in Dundee. Thank you for listening.
Thank you, Shiraj. Thank you very much for your nice presentations. Our next topics. Shiraj, so our president, Professor Abdul Ghani Mullah, want to say something about your presentations. Professor Abdul Ghani Mullah.
How are you, Dr. Juriala? Your name was uttered by Dr. Amitabh Naran Mukherjee from Kolkata. So you are very much well known to us, and you are the famous doctor in Dundee, I think. So Dr. Amitabh Mukherjee, he's a very good friend to us and a good friend to you also. When we are talking about anything, then he talked about your name, Jariwala. So thank you very much once again. And your presentation is very nice. We learn many things, and our junior colleagues learn many things from you. So you are invited to come to Bangladesh when the corona pandemic is over all over the world. Thank you very much.
Thank you very much for having me.
Now our presenter is Dr. Deven Taneja. He's from India. Topic is surgical site infection. Dr. Deven, hopefully is, sir, you are connected.
Professor Deven Taneja.
Yeah, I am coming.
You are hearing?
Yeah, I'm hearing.
Okay. Professor Deven Taneja was a good friend of Bangladesh, particularly the OSAC conference. OSAC conference is no more now. Last year it was a date of October, November in Bangladesh. Bangladesh is the president now. So I think you have a very good contribution in the development of this orthopedic surgery in the OSAC countries, that is the SAARC countries. So you are very much well known to all Bangladeshi orthopedic surgeons. So you are invited to come to Bangladesh again and again. So you please.
Okay, right. Thank you, Dr. Ganimullah, for your excellent words and for inviting me to this very important meeting, which is a hybrid meeting. And the subject that I have chosen is a very common problem in our developing world. So therefore this topic, and I always feel that if you have a surgical site infection, it is always a big quagmire and one doesn't know how to come out of this thing. So you have done a beautiful operation like this, then you come after a few days, take a round, and you see a person whose wound is like this thing, your heart starts beating very fast. Oh God, what has happened? So we did some study in Indore, in my town, and we picked up 4 different levels of hospitals. You can see that starting from a small nursing home to a corporate hospital. To our utter surprise, we found the infection rate was from 2% to 50% and high. I couldn't believe that there can be infection rate so high. So when we analyzed the data, we found there were 2 important factors which emerged. One, very poor OT discipline who had a very high infection rate, and 2, that most of them were not using any prophylactic antibiotic. So we said, okay, in one of the hospitals we took up as a challenge. I said, okay, if your infection rate is so high, we must try to bring it down. And we went into and started improving the OT discipline, sterility, prophylactic antibiotic. It almost took us 1 year to have bring the infection rate from 50% down to almost 2%. Okay, the surgical site infection, what is an ideal? If we go by international standard, it is less than 1%, and if you have between 2 and 3%, it is acceptable. But if your infection rate goes more than 3%, it is a matter of concern and inquiry. The impact of surgical site infection is tremendous. There are almost more than 3 lakhs cases in America. We do not know in India. We don't get proper statistics. The mortality is high. There's a high risk of death and long-term disability with these patients. And therefore, in low and middle income group countries, this infection rate is still very high, and it leads to a lot of prolonged stay in the hospital and increase in the cost. Professor B. Mukhopadhyay, an eminent orthopedic surgeon in this country, classified this infection into 4 groups: the imminent, early, intermediate, and late. We all know this. The most important thing that we must try to understand is the imminent infection, which we must try to diagnose and take this thing. Now, this patient who had undergone a surgery, and within a few days, we found his wound was giving way. These are the cases of a very early infection. So how do you diagnose a person who has got an imminent infection? That's the important thing. That is, if a person has got a tense, painful wound after your surgery, his fever after 48 hours is persisting more than 100 degrees, he has got an increased sedimentation rate and CRP, has got an increased count, and fever is a very important criteria for making a diagnosis. So this is all the case of an impending infection and requires your immediate attention. So this is a normal healthy wound. Here is a patient who has got an angry wound and you discharge. So the discharge from the wound is a clear indication of a surgical site infection, which used to be called as a post-op infection. And this nomenclature was coined in 1992 because most of the infection take place from the operation theater. Now, so prevention is better than cure. We all know that. Prevention only is possible if we try to achieve the international standards in the later infection. So the monitoring of a surgical site infection is of paramount importance, and evidence-based preventive measures are most important are your hand preparation, prophylactic antibiotic, postponing the elective surgery in presence of remote infection, and surgeon expertise and technique. So in our hospital, where my infection rate is between 1 to 2%, we are very, very strict and we keep monitoring our this thing. It is written on the main gate that infection rate is being monitored. Your cooperation is solicited. Every day in the morning, we touch what is the operation theater temperature, what is the humidity, whether the black zone, red zone, yellow zone, red zone, all zones are being taken care of, and then we do this thing. People talk a lot about the modular theater and talk about the laminar airflow. This is a beautiful study in which they say that Lidwell et al., when they studied 8,000 patients who had a total hip and a knee replacement, a pure ultra clean air, they found that infection rate got reduced from 3.4% to 1.6%. But when they use an antimicrobial prophylactic antibiotic, the infection rate reduced from 3.4% to 0.8%. And in another group where the infection rate was with ultra clean air and a prophylactic antibiotic, the infection rate got reduced from 3.4% to 0.7%. These are the three groups we made. So that proves that simply an ultra clean air is not that important, which is what is more important is your OT discipline, giving a prophylactic antibiotic. Okay, so if you find a patient who is likely to get an imminent infection and post-op infection, don't delay the diagnosis, start the treatment immediately. If you delay in the diagnosis, in a simple procedure like this thing, you can get in a wound like this thing and you can know how difficult it will be to this thing. So the prophylactic antibiotic became a very important tool in prevention of the infection, which started in the Western world in 1960. In Indore, I was the first person to start prophylactic antibiotic from 1983, and my patients don't get antibiotic for more than 24 hours. A meta-analysis supporting a single dose of regime for prophylaxis has been well established, and don't unnecessarily load the patient with antibiotics. What antibiotics you can give it depending upon what is the report from your microbiology department, but a cephalosporin injection or as per the hospital guideline, single shot given 30 to 60 minutes before the anesthesia, that is the important thing, and repeat only in a prosthetic or where you have done a lot of implant surgery, or you have the excessive blood loss, or you have taken a longer time, then you can repeat this injection. Otherwise, there is no not to repeat this injection and continue the therapy if there is an unexpected contamination. So what do I do about this thing? Open the wound, drain the pus, debride, suture, and staple removal. Wound should be left open, moist dressing, wound agent, and antibiotic if need be. So there is a beautiful study in which they have found it out that if you such a patient, you open the wound and do the closure at once, the chances of recurrence are in about 50% cases. You do the opening and closure after 2 days, chances are 20%. But if you open the wound and had been cleaning and dressing them and do the closure after 4 days, the chances of recurrence are only in 5% cases. Beautiful study. So the early management is the first discharge for culture and sensitivity, and start broad spectrum antibiotics to cover both the gram-positive and gram-negative organism, and open the wound and do the debridement and leave the wound open. Can you, somebody can stop talking? And coverage to Coverage to include the gram-positive and gram-negative antibiotics and anaerobe. And for gram-positive cefazolin, 1 to 2 gram, and it's more than enough for this patient. For gram-negative, you have to include aminoglycoside and vancomycin if the resistant gram-positive infections are present. So the beta-lactamase inhibitor combination, for example, piperacillin, tazobactam, or cefazolin with metronidazole or clindamycin and gentamicin antibiotics are there. I'll give you some examples. There was a girl, Sonal, who was 30 years, had a beautiful operation done for the fixation of the acetabular fracture, and we found there was a little discharge from there. Immediately we opened it up. There was a big collection of the clots and little hematoma. It was clean. It went on to heal. This gentleman, Harish Mehta, 70 years, had an TKR done, and one day he came to us with a redness, pain, fever. Obviously, this patient had an infection. We put in a needle. There was a lot of collection of hematoma inside, and we did not take any chances. Opened it up, did a thorough cleaning, thorough debridement, and we closed the wound. And 21 days postoperatively, we could save this limb. Otherwise, you know that if these patients get an infection with the implant in, what a problem it is. The late management of these cases is the most common cause is an implant. And if the fracture is united, do not delay and remove this implant. Do a good debridement and irrigation, discharge the area. This gentleman, Ramesh, who had this operation done with the implant, came to us with a multiple discharging sinuses, and he was getting antibiotic after antibiotic. All we did was to remove this implant, clean this whole area, and the wound went to, and it healed. Now here is I'm giving you the real quagmire, and how do you come out of this quagmire is really a great escape for any surgeon. This is an example which will tell you everything, the story. This young man of about 27 years had a fracture lower end of the femur. The plating was done, developed infection, went to second surgeon. Second surgeon put an external fixator. The infection persisted. He went to third surgeon, probably not as expert as Dr. Bari, and they did an elizarov. His infection persisted, multiple discharging sinuses, and then he went to the fourth surgeon, and who said, look, now I cannot do anything but do an amputation. At this stage, the patient came to us. I said, okay, we went in and opened up the whole bone, and we found this whole bone was very bad and sequestrated. Removed this bone, left a big gap, and went on to a McQuaid technique, and we put an antibiotic spacer. After having put the spacer was removed, biomembrane formation was there, and there we again put in the bone graft, both the fibular graft as well as a lot of the cancellous bone graft, and left it open for some time, the Papuni technique, and then you can see that the grafts were there in position, and we went on. Because the patient was by this time was fed up of the elizarov, and he wanted us to get rid of the elizarov. So we removed the elizarov and left the two pin above and below, because they were acting like an Anderson technique, where you can prevent the collapse of the two fragments and allow it to the healing to go on. And he was very happy to have his limb in plaster. And we continued. We found that one of the pin was broken. This pin was removed at that time. And then we found that one of the fibula was also getting infected, and that fibula was also removed. And now the patient went on, the grafts were getting incorporated, fracture started union. Although the first discharge was there, it went on gradually. The bone grafts were getting incorporated, fracture started uniting, pus became less and less. And you can see that how beautifully the fracture is united. There is no pain, no elizarov, no external fixator, no plate, but there is, and the patient after many years could stand himself and could walk. That was the happiness it gave. There was still a small sequestrum which was removed, and then again after removal, his pus also became much less and started walking. So this is a 4 years follow-up, and you can see how beautifully nature helps you to remodel the bone, and it becomes so beautifully. Now he's very happy. Only problem is this, he has got a stiffness of the joint. So this is a real quagmire from which you have to come out. It is not easy. The patient has spent about 27 lakhs rupees, Indian this thing, but of course, when patient came to us, a poor person I did not charge a single pie and did all operation free of cost for these gentlemen. So my dear friend, prophylactic antibiotics are very important. You must use it. Which antibiotic to use? First generation cephalosporin is extremely good. How long? Not more than 3 shots of antibiotic post-operatively. Wound irrigation is very important. Do put a drain, and that is how you can overcome this infection. Although what John Charnley said, although the zero surgical site infection is impossible, but understanding the biology of the infection at a surgical site will help decrease the incidence, cost, and morbidity. It is mandatory for every hospital to have an infection control committee, know the nosocomial infection incidence, do find it out and monitor your surgical site infection. Very important. Your operational theater supervisor should tell you if any patient gets infected, you must go into this thing, know what organisms are coming up and know what is their cultural sensitivity, and OT discipline is of paramount importance, and prophylactic antibiotic, it must be used by all of you this day. So the message is that avoid getting into swamp. Very, very difficult to come out of this thing. Preventive measures are the best. Follow the all WHO guidelines, whatever you want to do it. Diagnose at once and treat without delay, and use everything which is available in your armamentarium. The infection, post-operative infection has to be treated on a war footing. Okay, with these words, I again thank the Bangladesh Orthopedic Association for giving me this opportunity to share my thoughts on this very important subject. Thank you.
Disseminate it to the orthopedic surgeons all over the world, especially in Bangladesh. Thank you for joining with us. Wish you stay safe, stay fine. Thank you.
Thank you.
ঠিক আছে? So we want to move on because we are running short of time. Now I want to request the President of Bangladesh Orthopedic Society, our leader, Professor Dr. Muhammad Abdul Ghani Mullah, and he will talk about medical ethics in orthopedics. So let us welcome Professor Dr. Muhammad Abdul Ghani Mullah, please.
Bismillahirrahmanirrahim. Can you hear me, Professor Shahid?
Can hear me, you?
Yes, sir.
See you
Yes,
also.
yes. The president of the session, the co-chairman, convener of the session, all the dignitaries, all the faculties of the home and abroad, and our senior doctors, professors, and our resident doctors of NITOR, outside NITOR, in Dhaka Medical College, in Bangabandhu, in other division headquarters. Assalamu alaikum, and very good afternoon. So my topic is ethics in medical practice. So this is our national institute. It was previously 500 bedded. It is 1,000 bedded now. So 1,000 bedded government hospital in the world, it is unparalleled. We are going to celebrate and establish 1,000 bed day by day. And by this time in 17 March, in the birth anniversary of Bangabandhu Sheikh Mujibur Rahman, we have transferred our GH ward, that is the female ward, to the 9th floor. And one cabin block, half of the cabin block was also inaugurated on that day. So I think from the 1st April or the mid-April, we have established 1,000 bedded hospital in the world, in our campus. So what is ethics? Ethics, medical ethics, that Professor Doral said, it has already been said by him. Fantastic words we learned about him. But I touch something for the doctors. Core value and principle of the medical ethics. You must have a sincerity, honesty, humanity, and integrity. These are the 4 principles of the ethics: honesty, sincerity, integrity, and humanity. You are going to meet your creator one day. It is 100% positive. Kullu nafsin jaikatul maut. You have to go there. You have gone to your highest perfection in the life. So you are going to meet with him. Your account will be settled. You are a part of the nature. You will reap what you will show. And Newton's laws of motion, you know, 3rd law, every action has an equal and opposite reaction. You give many rewards for the good actions, and you have the curse for unethical existence. You will either settle in during your lifetime, or it will get carried over to the next birth and get the settled. There is no escaping the fruits of your action. Hence, it has become the very, very important in our lives. Ethics you need to discover the qualities of your soul. For ethical living, you need to know who you are and what is the body and the soul. The body and the soul, you know, body has many demands: ego, prideness, anger, jealousy, and ignorance. Soul, love, purity, power, happiness, and knowledge. These are the very important things that we have to follow in our daily life. Please. Thousands of knee replacement in the surgeries. Next. What is your contribution to the orthopedics? As orthopedic surgeons, you are not a simple guy. You are orthopedic surgeons. You made by the Creator. You are educated by your family and your teachers, and you are the creation of the Creator. So you have many contributions for the orthopedics. Thousands of knee replacement that you have done, thousands of trauma and spine surgeries that you have done, and hundreds of Elizara arthroscopy surgery and other branches of surgeries are done by you in your life. Yes, all of us wants to be successful in life. It always seems impossible until it is done. The Nelson Mandela, the African leader who has been arrested for 27 years in his youth life in the Arabian Karagar, and he was released and only 6-year president of South Africa. Now he died. Everyone wants to be famous. You see the two pictures. One is our great Kurgan magician, Russian magician, Mr. Elizarov. We know Elizarov, but Elizarov is the name of a man that we do not know. But that is the man who is the, and another man is the Posse. The Posse by this time is very much well known and well famous in the world due to COVID vaccine discovered in the United States. So everyone wants to be famous. In the different form, in the different stage, you have to be famous. The next man, Bill Gates, everybody you know, we all wants to be rich. Bill Gates is a rich man, Jacob Jobs is a rich man, Jacob Jobs is a rich man, and Mr. Donald Trump was also a rich man. Mr. Donald Trump, you know, that he was a president of the United States, the immediate past president. But the value you think in your mind that Bill Gates, everything he has donated and he has made a trusted all his wealth for the sake of the humanity. Perhaps Jacob Jobs and Jacob Jobs, all that they have dedicated. So everybody is famous, everybody is rich, but in the different way. Our father of the nation said, everyone wants to be immortal. You know that man is mortal, but everyone in our side, with that everyone wants to be mortal. My greatest extent, it is the greatest, is good quotation for the nation, for the distant people of the world. My greatest strength is the love of my people, and my greatest weakness is that I love them too much. Sheikh Mujibur Rahman, it is the greatest and nice quotation of the father of the nation. What is success according to you? One is the spiritual and another the materialistics. You will be success in the materialistics, but you are not success in spiritual. You are the success of spiritual, but you have no materialistic thinking. So money, fame, bank balance, power, position, these are all the materialistics. And it need also, but not like the Donald Trump like, or not like the other people. But you have to be spirited, spiritual thinking, you have to be spiritual success, inner peace, happiness, satisfaction, contentment, and gratitude. Let us look of some of our ethical practice. What is the role of a student, role of a consultant, and role of a teacher? That we must know. A student, a consultant, and a teacher, they are not in the same position. As a postgraduate student, you have some things. You should not have the pride, shortcut measure, arrogance, corruption, and manipulation. You don't have. You never believe that you should be bright, you should be corrupted, you should be manipulated, and arrogant also. As a teacher, everybody in front side, our honorable teachers are there, and all over the country, in the orthopedic sides, we have ego. We are the man, we have ego, but we do not have. We have casteism, we have groupism, we have nepotism, we have corruption and favoritism and exploitation. But these 7 components, as a teacher, you should not have. You should not have. But you are not a superman. You have something, you have belong. I think as a teacher, as a doctor, we should not have. As a consultant, you have to be accountability, unfair practice you don't have, and unethical measures, unethical exercises, unethical practice should be prohibited by a consultant. As a surgeon, these are in a summary, no unnecessary indication, Where there is no indication, you do not do the operation. The correct information that you must give to the patient, and that is your satisfaction, and that is the indication of your soul also, heart also. And dismissive attitude should not be dismissive, arrogancy, prideness, aggressive, and grading indication, and overcharging. As a surgeon, you try to make your charge less, make your charge less, make your charge less, because every patient, they are not the least people, they are the middle class people, they are the poor people. So, as an administrator, no groupinism. As an administrator, when you will be a director, you will be a civil surgeon, you will be a professor, you will be the minister of the country, you will be the state minister, or you will be the you will be the parliamentary member of the country. Then, well, some points you have to be thinking that no groupinism. You have to be fair. You are the out of group, and cheating, fraudness, categorized, politicization, same group, manipulation, and favorism. Not the same group, but the quality and quantity. Quality should be maintained in that position. Without quality, you cannot be a good administrator. How do you assess your ward? See, name, fame, wealth, success, position, bank balance, and luxury card like Porsche, like hybrid card, like BMDC, BMW, and like that. These are the assets that we have to assess our ward. But this should not be. Our stay in the mortal world, in the world, is only for a brief period of time, like a candle that you have seen in the screen. It is a temporary living. We are very much mortal. 20 years, 30 years, 50 years, 40, 80 years, we have to get majority. Is Mr. Mahatma Gandhi, the father of the nation of India? We need to make our life meaningful and accountable on. Good quotation. This quotation is for the doctors. The patient is the most important person to our campus, to our hospital. He is not dependent on us, we are dependent on him. Always try to, he is doing us a favor by giving us an opportunity to do so. So this is in a nutshell, I would like to say that the patient is the most important person to our campus. Everybody as a surgeon, we must follow it, and we just own it in our heart, in our brain also. We need to leave your imprints in the sands of time. You will be dying by your footprint, like the sands of the ocean, like the sands of the Bay of Bengal, like the sands of your Indian Ocean will be persist for a long time. And we are living in the earth, we are living in the world. পৃথিবী নামক একটা স্থানে আমরা বসবাস করি, বাট এটাকে ফুলফিল করার জন্য ফর দিস ইউ নিড টু চেঞ্জ ইউর কোর বিলিফ সিস্টেম. ইউ বিলংস টু দি ইউনিভার্স, ইউ বিলংস টু দি ওয়ার্ল্ড, ইউ বিলংস টু দি ইউনিভার্স অলসো, and you are not only to yourself, not only your family, not only your state or the country, you are the part of the big world as well as the universe. You will go to the moon, you try to go to Mongol Graha, so that's why you are the big part of the universe. So here is the quotation of Mr. Mother Teresa: make it meaningful to others. If you judge people, you have no time and to love them. And another, the Gautam Buddha, if you light a lamp for somebody, it will also brighten your path also. ethical practice towards your colleagues. If your colleague is doing well, Bhagavad Gita, principle, if your colleague is doing well, do not feel jealous, but enjoy his success. Always, you never be jealous. Always, you inspire him and inspire him to go through the more and more and contribute the subject, the nation, the institution, and the world. Do not feel happy, be compensate. If your colleagues is not doing well with you, do not feel happy, but be compensated to him. Be ethical towards your patients. Be honest towards your parents, towards your patient. Look upon your patients as your extended family. Do we do this for our family members without proper indications? If an old lady came to you with osteoarthritis knee, think she's your mother or your grandmother. Would you operate on her? If your answer is yes, then offer surgery to the patient. The best from the worst. The best from the worst. You see, very catastrophic infective wound over the tibia. The tibial bone was dead also. There is a huge gap. And what do you do? Try to do it like that. You just change your iliac shell, and there will be a hybrid iliac shell, and deprive all the bony fragments, and then the second, and there will be as an orthopedic surgeon, not only a plastic surgeon, but also a orthopedic surgeon, I request you that you have known some flap coverage, that you do something for the patient as the plastic surgery like. So mucocutaneous, myocutaneous flap is given by the orthopedic surgeon and also the plastic surgeons. You have to know it, and then you have applied the Elizarov session, and corticotomy is done, either proximal corticotomy or distal corticotomy, and the patient will be happy. The bone will be long, low limb LLB is there. So there is you see, there is a 8 centimeter gap of the tibia. Our Miraz Mullah is there. He has a very good option, a very good interest to the transportation of the fibula to the tibial side. But here is a gap. You see, there is a block of the fibula also. And that's why we have like that. Then you apply your Elizarov. There is a 8 centimeter already have been increased, and the leg, in course of time, the leg will be okay. So there is a big wound, infected wound, 20 days old, infected wound. Is this a good wound? As the orthopedic surgeons, this patient, when he went to our Nidor or Dhaka Medical College or Bangabandhu or your private chamber, then what we do? We have very good options. Please be patient. That we say. Just in the first instance, surgical debridement and some K-wires and external fixation, uniaxial external fixation, L fixation was done. And the wound is like that. And the anterior portion, there will be a sural island flap. That I always request you that all the orthopedic surgeons should note some common flaps of the leg that you can cover. And that is the very benefit of the patient. So do not be a naive, hungry surgeon, but a naive, sparing surgeon. Always thinking. A doctor is a student till he dies. When he considers himself not a student anymore, the doctor inside him dies. That means in online we can say a doctor is a student till our dies, but when we are failed to be a student, we dies. Always we think as a doctor, as a surgeon, as the orthopedic surgeons, I request you. Who is a good surgeon? Who will be a good surgeon? One who without his knife, without the knife, one without the knife. A good surgeon must have an eagle's eye, a lion's heart, and a lady's hand. Be a visionary, like the Bill Gates. Go beyond, do beyond, and reach beyond. Go ahead, always ahead, like our Bill Gates, like Zuckerberg, like Jacob Jobs, and like our great orthopedic surgeons in our country also. Always do some charity. You go to the weekend, you go to the Sadarpur, you go to Kabashia, you go to Khulna, you go to Chowhali, you go to Tangail. That you have to you have do some charity. You have many takas, many dollars. You have give away 10% of your earning for the charity every year. You still have a 90% of yearly and income for your use. So charity begins at home. The materialistic things do not bring peace. You know that the house of the residence of Mukesh Ambani in Mumbai, the Porsche cars, and the village is a palace like the Donald Trump Palace. It is a materialistic. So you need to be conquered. Your desire to be ethical. Either you have to be materialistic 100% or conquer your desire to be ethical. So contribute to the society and leave a legacy behind. Thomson Edison, Thomas Alva Edison, you know, he's a very, আমরা জানি যে উনি লাইট আবিষ্কার করেছিলেন. He will ever remembered by us, all the students, doctors, and all the peoples of the world, Thomas Alva Edison. And Mr. Abraham Lincoln, he is a very lean and thin man, tall man, but in one time he was the president of America. Still now, he left the legacy behind, the government by the people, of the people, and for the people. So these are not outdated principles, but it still holds good events to this day. Honesty, integrity, and sincerity. These are the three things. I think all about doctors, we follow it, and in course of time, in your future life, please be maintain, try to honesty. Without integrity, you do not do anything. একলা সবকিছু করা যাবে না. একটা গ্রুপ অফ পিপল পলিট ব্যুরোর সদস্য হতে হবে। এই যে পলিট ব্যুরোতে অনেক ভালো লোক থাকতে হবে। এই পলিট ব্যুরো যেমন সুন্দর নাম মস্কোতে ছিল, তেমনি একটা নাম আমাদের খারাপ নামে অবশ্য অভিহিত হয়েছে। কিন্তু স্টিল আমি মনে করি ইন্টিগ্রিটি is like the পলিট ব্যুরো. So I think this integrity will reach our fantastic destination. Our hypocrites, everything we know, Susuto and Jaraka. No medical degrees, no post-graduation, no books they have, no computers, no internet, no libraries, but still Socrates is ever remembered by us, Tolstoy ever remembered by us, Aristotle ever remembered, Xenophon ever remembered by us, and Socrates says that I to die, you to live, which is better and correct only God knows before his death. Leave our legacy behind. Our father of the nation, Bangabandhu Sheikh Mujibur Rahman, said in the 7th March in 1971, আমরা যখন মরতে শিখেছি তখন কেউ আমাদের দাবিয়ে রাখতে পারবে না. If we learn the going to be died, মানে কি বলে drinking of the hemlock poison, so nobody resist me, nobody resist us. That is Bangabandhu Sheikh Mujibur Rahman. And last of all, our mother of the humanity, our honorable Prime Minister, Sheikh Hasina, leave your legacy behind. She said, I always think about the deprived people. Our effort will be continued to lift up the neglected people of the society. Her Excellency, Sheikh Hasina. So thank you very much. Thank you very much for your patient hearing. Thank you very much. Long live Bangladesh.
Hello. Thank you. Thank you, Mr. President of Bangladesh Orthopedic Society, for your time-demanding, fantastic, reminding lectures on medical ethics in orthopedics. We all orthopedic surgeons of Bangladesh always will remember you for your beautiful presentations, and we will try to follow you as our leader or as our forefather in future. So you are a mentor and your lecture is like a mentor. So we enjoyed your lectures, and I think the orthopedic surgeons. So somebody wants to give you thanks or ask a question. He is Dr. Moyam Hossein, your Vice President.
Okay.
Thank you, sir, for your nice presentation. Nice. I think it's a great oration. It's a guide for the orthopedic surgeon. Really, we enjoyed this. It's a fantastic presentation for the teacher, for the consultant, for the young surgeons, and for the resident. Thank you, sir, for your nice presentation again.
Thank you. Thank you very much.
Thank you for your guardianship and your mentorship.
Thank you very much.
We want to move forward. If you give permission, we want to move forward for the next presentations. There is another presentations from one of the senior surgeons in this subcontinent. And his topic is my 50 years journey in orthopedics and listen to be shared. I think this will be a very important lecture by Dr. Shamir Kumar Mukherjee from India. Let us welcome Shamir Kumar Mukherjee from India. Dear admin, please connect Mr. Shamir Kumar Mukherjee. So probably we are unable to connect Shamir Kumar Mukherjee. Sorry for this technical error. I want to request another Dr. Krishna Priya Das from Bangladesh, and his topic is distal radius fractures. Let us welcome Mr. Krishna Priya Das from Bangladesh.
Hello.
Okay.
Can you hear me?
Yes, so we are hearing you and we can see your presentations also. Please go on.
Okay. Good afternoon. It is very difficult to tell something or presenting any paper after that so much presenting of our president, Professor Abdul Ngoli Mullah. But I am presenting my paper in shortly. My topic is the outcome of delayed presenting distal radial fracture. Before we go to the original presentation, we must learn something regarding the osseous anatomy of the distal radius. Distal radius contribute 80% of the axial load of the hand, and it has two important fossa, that is the scaphoid fossa and lunate fossa. This lunate fossa forms the intermediate zone of the radius, and the distal ulna with TFCC contribute 20% of the axial load. The distal radius has the sigmoid nose that forms the distal radioulnar joint, as well as the contribute of the complex of DRUG. If we analyze the anatomy, we see this shaded line is the most important for the fixation of the distal radius by polar plate. We know the disc and the distal radius has 3 columns. The radius has 2 columns. The radial column, intermediate column, and ulna also forms the ulnar column. The water-shaded line of the distal radius is the most important, and also the complete line. It is the margin for the extreme part of the pronator quadratus. This distance between the 3 to 5 millimeter is also very important for fixation of the blade. Distal radial fracture forms the 2, 3, A, B, and C. What are the risk factor for loss of reduction of the close treatment of distal radius? If the dorsal angulation is more than 20 degrees, dorsal comminution, interarticular fracture associated with ulnar fracture is more than 60 years, that means the severely osteoporotic bones, and if there is the more than 5 millimeter radial shortening. What are the options of treatment of distal radial fracture management? There is a lots of option. Most of the distal radial fracture is treated by conservatively with casting. Other than this, the external fixation, percutaneous pinning, and internal fixation. Out of the internal fixation, volar plating is the most common approach. If we go for the epidemiology, we also know in USA, almost 11 million of the distal radial fracture reported from the 2011. Previously, before the 10 years, most of the distal radius fracture was treated by conservatively. But last 10 years, the operative treatment rate is 8.75 to 20%. The overall complication was 8.3%. What is our scenario? We have treated from January 2018 to December 2020, total of 350% of the distal radial fracture. Early presented cases, we are treated with the conservative treatment, almost 75%. But late presented cases, those who are presented more than 2 weeks, we are treated surgically for 43% of the patients. Our operated cases are 43.42%. Volar approaches, we follow 145 cases, that means 95%, and dorsal approaches, only 5% cases. Overall complication rate in our experience is 7.23%. Satisfactory outcome according to Mayo risk score is 94.74%, and unsatisfactory result is 5.26%. What are the surgical indication of distal radial fracture? This is a high energy injury, secondary loss of reduction, articular comminution or gap more than 2 millimeter, radial shortening more than 3 millimeter, dorsal tilt more than 10 degree from the neutral, metaphyseal comminution, loss of volar buttress with displacement, DRG incongruity, as well as those patients who are wants to early motion. Treatment goal is to preserve the hand and wrist function, realign normal osseous anatomy, promotes bone healing, and allow early finger and elbow range of motion. Plate position. This water shaded line indicator is the extreme position of the distally of the volar plate. And we previously mentioned the two column of the radius, the radial column and intermediate column. We fix the screw with the intermediate column. That gives the good stability. What are the complications? Early complications are circulatory problem, carpal tunnel syndrome, TFCC injury, subluxation of the inferior radial joint, and reflex sympathetic dystrophy. And late complication of the malunion, delayed non-union, stiffness, and tendon rupture. When distal radial fracture operated lately, the failure of reduction with plaster immobilization, undiagnosed or missed volar or dorsal Barton fracture, improper or inadequate reduction, and open fracture or polytrauma patient. We, most of the cases, 95% of the cases, we go through the volar approach. It is the volar approach. We give the incision by modified Henry approaches. And after giving the incision, we pass goes beneath in between the FCR tendon and sheath. So we avoid the radial artery. It is the steps of operation of the bipolar approach. After giving the skin incision, we go through the radial sheath and FCR tendon, and then expose the fracture fragment. After debridement of the fracture margin, we reduce the fracture and then place the plate temporarily by giving the metaphyseal screw first, so that we can go distally and proximally according to our desired length. Then we fixed the ulnar hole first. That means we give the more stability in the subchondral bones of the lunate fossa as well as the sigmoid nerves. Then we put the central screw and then go to the radial screw. And finally, we fixed the diaphyseal screw. Mazhar, hey Mazhar, computer key holo dekhen to. So, yes, Then we repaired the pronator quadratus tendon and covered the plate. Close the skin over the drain, and we also fix the dorsal fragment by the volar approach. Sometimes we need go for the dorsal approach because this is the 3 months old, 4 months old fracture, and there is no volar bones in the volar aspects. So in that, but there is a good bony bar in the dorsal approach, dorsal aspect. So we go first osteotomy of the ulna and exercise the portion of the ulna and assess how much the ulna will be excised. Then go for the radial approaches and fixed it with, and then gives the bone graft taken from the osteotomy of the ulna. A 38 years old male presented with the interarticular fracture after 6 weeks. A patient was given the external fixator about the displacement in the volar aspects. So we go for the open reduction and internal fixation by volar approaches, then follow up at 4 months. Another patient, but remove the patient plate early after 4 months because the patient getting pain in the thumb as well as the weakness of the thumb. So after removing the plate, we saw there is the attrition of the FPL tendon, but debridement of the FPL tendon and the postoperative period was good. This is the comminuted distal radial fracture treated with the volar buttress locking plate. Another patient of distal radial fracture with the volar buttress locking plate presented 3 weeks after the injury. We treated with the volar buttress locking plate and follow up at 4 months. Almost, we also use the dynamometer for measuring the strength of the wrist and hand function. Almost 90% of the wrist strength we are getting. It is another patient of comminuted distal radial fracture presented 2 weeks after the injury. We treated it with the volar buttress locking plate and follow up at 2 months. Good range of wrist function as well as the hand function. It is a 6 weeks old malunited distal radial fracture treated with the volar buttress locking plate. Another patient, the 5 months old malunited distal radial fracture of a 16 years old girl. This is the malunited distal radial fracture, but there is the wrist deformity. So we go for the osteotomy of the radius as well as the fixed of the radius with the volar buttress locking plate and the follow up at 6 months. Very good range of wrist flexion, extension, as well as the pronation, supination movement, as well as the hand function. Another patient, 3 weeks old distal radial fracture, follow up at 6 months. A 15 days old intra-articular distal radial fracture treated with a 5 months old maltilted distal radial fracture, as well as the extensor tendon injury. We treat first with the open reduction and internal fixation of the distal radius by volar buttress locking plate, and at the same sitting, we also reconstruct the extensor tendon. Just 10 weeks follow-up and follow-up at 5 months, good wrist function as well as the finger flexion, extension, and hand function. Another patient, 6 weeks old, distal radial fracture with the follow-up at 6 months. A 6 weeks old distal radial fracture, 2 attempts of plastering was failed because due to the osteoporosis, gross osteoporosis of the distal radius. We open it and treat it with the volar buttress locking plate and give the vitamin D, calcium, and alendronate. The follow-up at 2 months. Very good pronation, supination, Another patient presented 2 months after the injury, male united distal radial fracture, treated with the volar vertex locking plate after osteotomy and reduction. Good range of finger flexion, extension, as well as MCP flexion and wrist function. It is a very neglected, maltreated cases of non-functioning hand with the distal radial comminuted fracture. It was the open fracture. So treated again by osteotomy of the ulna as well as the fixation of the radius and bone graft. This is the postoperative X-ray and follow-up at 6 months. It was the maltreated, non-functioning hand, and after good fixation, with a very functioning. Still, conclusion is still most of the early presented distal radial fracture are treated conservatively, that is 75%, with satisfactory outcome. Surgical treatment seems to be more effective for the distal radial fracture compared with conservative treatment. Volar plating is a good option in late presenting interarticular fracture and even dorsal fracture also. When the radiographic outcome are analyzed, there are significant differences between the conservative and operative group. Thanks for patient hearing.
Beautiful presentations. We want to move forward because we are running short of time. The next topic is valgus knee replacement. When I use posterolateral pie casting or lateral approach for valgus knee. Dr. Sharat K. Ramanath from India. Is he with us? Yes, probably he had. And the next session will be chaired by Professor Shahid Jaman. I can see him. Please, sir, get ready for the next session. After probably you have completed your lunch here.
Good afternoon, everyone. I thank Professor Abdul Ghanimullah.
See your screen.
Am I audible? Am I audible, sir?
In view.
Yes.
Yes,
can I start?
You are audible.
Yes. So, good afternoon, everyone. I thank Professor Abdul Ghanimullah for having me here, President of Bangladesh Orthopedic Association, and Professor M.M. Bari and Dr. Qazi, Professor Ghazi Usman, and all the office bearers. I am Dr. Sharat, working as a joint surgeon in MS Ramaya Hospital, Bangalore. So I'll be sharing regarding valgus knee replacement. As you all know, soft tissue balancing is difficult to achieve in valgus knees. So the bony deformities, that is hyperplastic lateral condyle, tibial bone loss, malaligned, malpositioned patella, and rotational alignment of the limbs. So these are the things which are different compared to varus knees. So it is classified classically as a medial soft tissue stabilizers are intact in type 1 and soft tissue stabilizers are lax and deformities are not passively correctable in type 2. So both types have lateral bony deficiency and soft tissue contractures. So the procedure as the regular distal femur valgus cut standard 5 degree, resection of femoral resection less than 8 mm from the medial condyle, proximal tibia resection less than 8 mm, and contained defect of the lateral tibial plateau. So the distal femoral cut, this is the commonest controversy where very different articles give a different valgus angle. The most important is whenever we cut 4 or 5 degree, sometimes we may not be able to touch the lateral condyle, which is hyperplastic. So in that case, if it is fixed valgus, we can make it into 3 degree valgus. And for that, we have to have the long film axis and measure the anatomic and mechanical axis beforehand, before the surgery. In short, as you can see in this case, we are not touching the lateral femoral condyle. This is the classical valgus case, and we have the contained defect of the tibia. And unlike the classic teaching, we don't cut more of the lateral medial tibial plateau compared to lateral. So we cut less of the medial and more of the lateral in the AP film, in the long axis film, again in the valgus also. And here you can see for hypoplastic posterolateral condyle, we have to adjust the rotation, and sclerotic femoral condyle after the preparation. This is the classic valgus knee. So appropriate rotational alignment of the femoral component is most important. External rotation of up to 5 to 6 degrees in relation to posterior condyle, because hypoplastic posterior condyle and patellar tracking can be an issue. Aligning intercondylar eminence with the tibial crest in the tibial component, because there will be bungee shaped or S-shaped deformity of the tibia. So lateral release technique, removal of the lateral osteophyte and extraction of the knee with the laminar spreader, palpation of the posterior cruciate ligament and posterolateral corner, and ITB, release of the posterior cruciate ligament, preservation of the popliteus if possible, and pike resting multiple transverse stab incision. So this is classical pike resting. So I am just sharing this classical pike resting technique, which is commonly practiced with the medial parapatellar approach whenever we are dealing with the fixed valgus knee. You can see with the laminar spreader, the assistant will be spreading the posterolateral aspect to lengthen or to open up the space of the posterolateral with a 11 number knife, gently up to 5 mm. We can go deep, and we should not go deep more than 6 to 7 mm, because you may damage the lateral poplite common peroneal nerve. So after the pike resting is done, the trapezoid gap will become rectangular gap, and then we can check the alignment and confirm the axis correction. So this is the example of the trapezoid gap. Review of literature. There are so many different techniques have been explained. One of that is a lateral approach to total knee arthroplasty instead of medial parapatellar approach. So lateral approach has given different perspective for the valgus knees. If valgus knee is a fixed and severe deformity, and with if in case there is a lot of osteophytes in the proximal lateral tibial plateau. So in such case, lateral approach can be very good, because we are not disturbing the medial collateral ligament, and the balancing of the knee becomes even more comfortable. So what are the advantages? Directly release the lateral soft tissues, contracture, decrease subcutaneous undermining, improved access to the posterolateral corner, allows better sequential release, centralizes the deep quadriceps tendon, preserves more vascularity to the patella, and early postoperative rehabilitation, because the blood supply to the patella is also not hampered, which comes from the medial. So disadvantage is it's not our regular approach, and direct capsule is not possible because of high tension. So for that, we should not damage the fat pad of the infrapatellar fat pad during the lateral approach, as we remove during the medial approach. So to prevent usage of the constrained or semi-constrained implant, lateral approach is advantageous compared to medial approach. So modified approach, and there are so many modifications of lateral approach, like Z-plasty of the lateral retinaculum, quadriceps snip, and tibial tubercle osteotomy can be used, or epicondylar osteotomy can be used if the deformity is very severe. So with these a few examples, these are the valgus knees which are treated with the medial parapatellar approach. We can see most of the valgus knees can be corrected with the medial parapatellar approach if it is a mobile varus, type 1 mobile valgus, type 1 valgus. And if valgus is a type 2 valgus, severe opening of the medial side is present, then we have to go to lateral parapatellar arthrotomy. And the stem of the primary femur. Here, one more thing I would like to share, that if whenever we are planning the preoperatively, if lateral condyle is severely hypoplastic, keep the primary implant with the stem option of the distal femur if you are not using the semi-constrained implant. And another surgical technique is to constrain liner for the primary implant. In case if you are expecting severe laxity of the medial side, and our liner is is less than 16 to 17 mm in the primary, keep the constrained liner for the primary implant. So this is lateral parapatellar arthrotomy, where it shows how to release the ITB from the Gerdy's tubercle. That itself will clear most of the lateral side contracture. This is the classical severe valgus knee with the dealing with the lateral parapatellar arthrotomy. You can see release of the ITB. And you can see that whenever we approach the knee from the lateral side, although it is not familiar to us, we can directly see the osteophytes of the proximal lateral tibial condyle, go to the posterior lateral most corner and remove all the osteophytes, releasing the ITB. Itself can correct the contracted lateral structure. With that, I would like to share this particular case, which is severe varus valgus with a lateral contracture and corrected with the primary knee without usage of any semi-constrained or any of the special implant. Only thing is that we should not undersize the femoral component. Here you can see the femoral component is not undersized. Usage of the tibial side stem to give the stability and lateral parapatellar arthrotomy. Again, another case, similarly, again, another case, similarly, treated with the lateral parapatellar arthrotomy. You can see this patient walking with the excessive valgus, with a fixed excessive valgus. So, the deformity is completely corrected and he is able to walk without any support, without any knee brace, within 1 week after surgery, with usage of the normal knee replacement, without any semi-constraint. So, the valgus knee is, so after examination under anesthesia, if it is a rigid valgus, you can go to, this is the flow chart given from the Dr. Arun Mullaji's deformity correction textbook. Most of this we can be followed with using this flow chart. If it is a rigid valgus, you can go to lateral approach if we are suspecting any severe tight lateral structures, we cannot be corrected by the medial parapatellar assessment parameters. So all type 1 and most of the type 2 can be managed with the regular posterior stabilized knee. Varus valgus constrained design is not always required, but backup has to be kept. Adequate lateral release is absolutely essential for balancing, and popliteal sparing technique is well accepted. Stem extender helps in alignment, stability, and stretching of the lateral structure. Possibility of the femoral stem usage should be used in doubt. Up to 18 mm of the tibial inserts are to be arranged even in the primary knee. Adequate lateral release of soft tissues is a key. Use of lateral approach for a fixed valgus more than 20 dg. Popliteal tendon release is not absolutely required. Extensile approaches like TTO, lateral epicondylar osteotomy, Z-plasty can be avoided with the proper preoperative planning. Thank you for kind attention.
Please welcome Dr. Arif Hussain. So the President of Bangladesh Orthopedic Society wants to give thanks to Sharod. Please.
Thank you, sir. Thank you very much, sir, for having me here. Professor,
you are from Ramaya Medical College.
Yes, sir. Yes, sir. Doctor
Medical College in our like our own institution.
Yes, sir.
And Professor Farshad M. Shaha.
Yes, sir. Sir,
and we
yes,
went
sir.
there during the IOCON in Bangalore.
Yes, sir.
Okay.
Yes,
and
sir.
Your hospitality, your
Thank you, sir.
management is very, very, very nice. Ramaya
Thank you,
Hospital.
sir.
So,
Thank you, sir.
So you are cordially invited to come to Bangladesh.
Thank you very much, sir. Thank you, sir.
You think Bangladesh as your like your Bangalore, like
Thank
your
you, sir. Thank you very much, sir.
Actually, Bangalore is the city of garden. Okay.
Thank you, sir.
So
Yes, sir.
Dhaka will be in course of time. Dhaka will be a city of garden. Thank you very
Yes.
much. Take care.
Thank you, sir. Thank you.
Take care.
Thank you very much, sir. My regards to sir. Thank you, sir.
Thank you.
Thank you.
Okay, Dr. Ari, please start your presentations, and I would like to request Professor Dr. Shahiduzzaman sir for the next presentations. After ending of the presentation of Dr. Muhammad Arif Hossain, you start your session, please.
Okay. Can you hear me, sir?
Yeah, we can see and hear
see
you.
my screen, sir?
Okay, okay, fine.
Okay. Respected chairperson, dear colleagues in Bangladesh and abroad, Assalamu alaikum and very good afternoon. I am Dr. Muhammad Arif Hossain, orthopedics consultant working at Sarkari Community Hospital, Dhaka, Bangladesh. Today, I am going to talk about the techniques of bucket handle meniscus tear repair, and my technique is combined inside out and outside in technique. We all know we have two menisci, lateral meniscus and medial meniscus. And what is the function of meniscus? Acts as a spacer that prevents contact between two articular surfaces, and it has a vital role in load bearing. It increases the contact area and reduce the contact stress. So if there is a partial meniscectomy is done, then there is a chance of increased contact pressure by 350 percentages that causes secondary degenerative changes or osteoarthritis of knee joint. It also maintains the joint stability and shock absorption during walking, running, jumping, etc. So the blood supply of meniscus. Meniscus is relatively a vascular structure, but it gets blood supply from medial, from superior and inferior geniculate artery. And on the basis of this vascularity, this meniscus has three zones: zone 1, zone 2, and zone 3. Zone 1 is called red zone, and zone 2 is red-white zone, and zone 3 is white zone. Zone 1 and zone 2 has these two zones have a high vascularity and has a greatest chance of healing potentiality. So the classification system, according to Issaco's classification, according to pattern of tear, the meniscus tear are horizontal, radial, longitudinal, flap tear, and some are complex tear. So bucket handle tear actually is a vertical tear when it becomes larger and convert to a bucket handle. And this is a handle of bucket. And by definition, bucket handle tear is a longitudinal tear of the meniscus with an attached fragment displaced away from the meniscus, most commonly into the intercondylar notch. And it is more common in medial meniscus and represents about 10 to 26% of all meniscus tear. So this is a graphical representation of a bucket with bucket handle. The important thing is that the bucket handle tear, the location of the tear is at zone 1 or zone 2, that is highly vascular. So if we succeed to repair it properly, there is a chance of healing of this tear. So the MRI signs, there are 3 MRI signs of bucket handle tear. One is double PCL sign in sagittal proton density images. There is a low intensity meniscal fragments, just anterior and inferior to PCL attachment, which corresponds like a PCL and paralleling the PCL, that is called double PCL sign. And this is the MRI of double PCL sign. And another is flipped meniscal sign. Normally, the anterior horn is smaller than posterior horn, but in flipped sign, the anterior horn is larger, and there is a defect in the posterior horn of meniscus. And this is a intersegmental fragment between medial tibial eminence and the PCL attachment. So I am trying to focusing on the techniques of meniscal repairs. And we all know that there are three arthroscopic approaches for repair of this meniscus. One is inside out technique, when the tear is located in posterior or medial portion. Then another is outside in technique, when tear is located anteriorly or middle. And the last one is all inside technique. But my topic is inside out and outside in technique combinedly to repair the bucket handle tear of meniscus. These are my tools or instruments for repair of this bucket handle tear. I use some zone-specific cannula and reusable flexible needle and non-absorbable ultrabreed sutures. So there is a video. First of all, the most important thing is the assessment of bucket handle tear and its anatomical reduction. And this is a video of a bucket handle tear. This is the handle of bucket. I am assessing the tear, the location of the tears, and the quality of the meniscus tissue, and try to anatomically reduce it. This is the most vital part of the surgery. Then the important thing is that preparing the tear and biological augmentation. Here I use punch forceps to debride the margins and also use motorized shaver. This is a bucket handle tear. This is the margins of tear. I shaved with motorized shaver the capsular site and then also the meniscal site. That would help biologically augment for healing of the tear. Then this is the steps of my inside out technique. I use zone-specific cannula. First, I placed this zone-specific cannula on the meniscal site of the tear, and then introduce a needle that is loaded with proline and passed it through the meniscal tear. And then my assistant loaded this loop with these non-absorbed ultrabreed sutures, and then passed these ultrabreed sutures by pulling this proline loop. And then again, I placed this cannula on the capsular site and then introduce the ends of the ultrabreed sutures through the loop of the proline and pull it from outside, and the tear is repaired with a very nice vertical mattress fashion. And then outside the joint, I knot it, either sliding knot or non-sliding knot over the joint capsule. This is a vertical mattress suture on the tear, and this is outside in technique. So this is a inside out technique video. The proline loop is there, and then the ultrabreed suture, the vertical mattress fashion knot is placed over the chairs. And then this is my inside out technique. I use epidural needle, and then I introduce this proline by pushing it from outside, and then I take it outside the joint with the help of a grasper, and then loaded these Prolin loop with this suture, ultrabed suture, and then another epidural needle is passed through the capsule, and same procedure is done, and then the Prolin loop is loaded with this suture, and the vertical mattress suture is secured this chair. So this is an article. The author concluded that surgeon should attempt meniscal repair using whichever surgical technique, either inside out, outside in, or all inside technique, they are most comfortable with when presented with a bucket handle chair. And this is another article, and they concluded the outcome of this bucket handle chair that for larger bucket handle chair, meniscus chair involving red or red-white zones, an arthroscopic hybrid suture technique with ACL reconstruction achieves high anatomical healing results with an overall meniscal healing rate is 89.6%. That is very high healing rate. And these are my cases. 27 years old male, have a history of giving away and locked knee, pain with flexion, unable to squat, physical examination, gait is limping gait, no effusion, range of movement, medial joint tendon is present, anterior door test positive, Lachman test positive, and McMahon test positive for medial joint line. The second case, 24 years old male from abroad. He has also history of locking history, and I repaired with inside or outside in technique. And take home message is surgeons should attempt meniscal repair, focus on preserving as much as meniscal tissue as possible to retain its biomechanical properties. Thank you for patience hearing. Save the meniscus, save the knee joint. Thank you.
This is the end of this session 2 of Boscon 2021 Congress scientific session. I would like to request Professor Shohiduzzaman, Professor Dr. Monayam Hussain, and Dr. B. Shivashankar from India. Please join us and start your session, session 3. Thank you very much. Professor Shohiduzzaman, sir, please.
Okay, thank you very much. Can you hear me? Am I audible?
Yes, sir. Audible and visible. You look nice, sir.
Do I? Thank you. Let me welcome all the participants to the third scientific session of Boscon 2021. And I'd like to thank the organizers and the scientific committee to give me the privilege to become one of the chair of this session on the spine. I just want to recollect when we started in 2000. In early days, we started crawling with our spinal surgery in early 2000. Since then, our young orthopedic surgeons that had training, they developed experience, and I must admit that the spinal surgery is at its own foot in Bangladesh. So our young orthopedic surgeons, those who are practicing on spine operation, on spinal surgery, I must give a big hand to them. So let's begin with our third session. We have 6. Do the other chairmen are here with me? Is Dr. Monayam is here? Dr. P. Shiv Shankar is here. Okay, I don't know whether they're here or not.
Yes, sir. Dr. Monayam is here.
So Dr. Monayam, I cannot see him. He is not. I don't see him.
Yes, sir.
So yes, okay, nice. Let's welcome Dr. Monayam. So let me start the session first, then nextly I'll ask Dr. Munaim to continue. So we have 6 presentations in this session, and I see all the speakers are from the Bangladesh. That is really a good thing that our Bangladeshi surgeons are presenting on very good important topics on spinal surgery. So let's start with Dr. Jivendra Haldar. He is going to present on training on triaging spinal surgery in COVID-19. I know we have been doing this for last 1 year, but as the COVID is very much on, we cannot forget the triage. So let us have some update from Dr. Jivan Haldar. Thank you.
Good year and dear audience from home and abroad, and welcome to my presentation. Before presentation, I want to convey my thanks to God, and secondly, Bangladesh government and scientists who have discovered vaccine, so that I am still alive and can speak in front of you. Today, my topic is triaging spine surgery in COVID-19 pandemic. Next. There is upheaval of world. For the last 16 months, the whole world has undergone an upheaval, and the whole world is slept regarding virus as well as mask. The person that on is mattered more than the virus. Next.
So, Dr. Munaim, I cannot see him.
There was a work and balance. Suddenly, everything became different and was opposite. Lot of work, no free time, less family time, no leisure activities, no time for academics, nil research time. Next. What happiness cannot teach, adversity will, for it is a great teacher. How we are handling adversity in our life. Next. In introduction, severe acute respiratory syndrome coronavirus 2 is a virus currently affecting the majority of the world in a global pandemic fashion, more commonly known as COVID-19. The virus was recognized as a potential danger in December of 2019, when there were a series of pneumonia cases reported in Wuhan, China. Next.
But as the COVID is very much on,
G et al. Elucidated that the SARS-CoV-2 virus was a chimeric version of a known bad coronavirus. Benvenuto et al. Recognized that this virus was similar to a strain that had been isolated in 2015 from Chinese chrysanthemum headed. That is we call Chandramallika bats. Next. Regardless of the efforts by nations to initiate isolation techniques to flatten the curve of coronavirus cases, the virus was continued to spread and overwhelm hospital systems around the world. Next. As a result, multiple institutes have issued executive orders prohibiting elective surgery in order to conserve resources for the growing pandemic. Next. Spinal surgery is unique in that even elective procedures are typically done for neurological symptoms and deficits, compression of neural elements. Next. The purpose of this article is to review the literature for varying indications for spine surgery and help categorize elective, urgent, and emergent nature of surgery. Next. Emergent spinal surgery. Progressive or severe neurological deficits due to neurological compression from any cause, infection, tumor, fracture, disc herniation warrants surgical intervention without postponing treatment. Next. Roland et al. Recommends that early surgical intervention, when safe and feasible, can improve clinical outcomes and reduce overall health care costs. Next. Multiple large series have noted that if spinal epidural abscess patients have progressed to complete paralysis for more than 24 to 48 hours. Finally, post-operative wound infections warrant an emergent surgical intervention. Next. If left untreated, these injuries would likely further tax the currently strained healthcare system, particularly during COVID-19 pandemic. Next. Urgent spinal surgery. Cervical or thoracic myelopathy with recent progression should be treated on an urgent basis. The natural history of cervical spondylotic myelopathy is extremely variable, with some patients deteriorating and needing surgery. Next. Intractable pain from cervical or lumbar radiculopathy or progressive fracture-related deformity. Donali et al. Described that acute instrumentation failures such as screw loosening, pull-out, rod fracture, or case migration should be operated on urgently as well. Spinal infections such as discitis, osteomyelitis, and that fail to respond to medical management should be considered for surgery. Next. Decisions for surgery. Every problem has a solution. Now, what is the solution of this? The purpose of this article is to review the hospital management of the operative patients in COVID-19 pandemic. Prolonged bed rest may exacerbate many of their underlying medical comorbidities, urinary tract infections, deep vein thrombosis, and pneumonia. Next. Providers who care for spine patients should adhere to the strict guidelines proposed and updated in use of personal protective equipment for the safety of themselves and the patient. If a COVID-19 negative patient, intervention at an ambulatory surgery center or facility with minimal COVID census is recommended. If the patient with COVID-19 infection, they should be tested and transferred to a separate ward, more pertinent to patients with COVID-19 infection for further workup. Zhu et al. Recommends some criteria: the use of minimally invasive surgery and reduced operative time, prone positioning when able to reduce viral transition by respiratory droplets, minimize intraoperative body fluid splatter, utilize suction device intraoperatively with caution to reduce aerosol diffusion, no extra staff in operating room. Decision-making algorithm: if the patient's individual COVID-19 risk is greater than the risk of delaying surgery, then the procedure should be delayed. In contrast, if the patient's surgical pathology outweighs the risk of COVID-19 exposure, then surgery should proceed cautiously. Case example, case 1, a case of 30 years old man, farmer, had a history of fall from height. He was Asia grade C. Now, after operation, he is able and converting to Asia grade D. Another patient, a case of 20 years old boy, student, history of fall from height, Asia grade B, and now he is improving after operation. He is in wheelchair but improving day by day. In conclusion, next slide. This is an unprecedented time for healthcare and spinal surgery across the world. We recommend that those decisions are best made at a local hospital level in coordination with a committee of one's surgical peers that utilizes a multidisciplinary panel. Surgeons need to remain consensus about local hospital sources, divert surgeries to an outpatient setting whenever feasible. Next. We want to break. Next. Successful people push through adversity. And lastly, there is a end of tunnel, light at the end of tunnel. No hurry, no train, no business, only a little hope. Little lamp with a bright man. And lastly, vaccine is the lamp in a dark hole. And these are some references. And thank you very much for.
So thank you, Dr. Haldar. And I must request all our surgeons to strictly follow the guidelines of during this COVID, for precaution, for safety during this COVID-19 pandemic. Now we have a second paper that is kyphosis in spinal tuberculosis. So we'll be hearing from Dr. Shah Alam, one of our established orthopedic surgeon who is practicing spinal surgery in Bangladesh. So I'd request Dr. Shah Alam to present his paper on kyphosis in spinal tuberculosis and its management strategy. Dr. Shah Alam.
Thank you, sir. Sir, can you hear me?
Sure, I am clear, loud and clear.
Thank you very much. Good afternoon, ladies and gentlemen, honorable chairperson and distinguished gathering. You are welcome to our this afternoon session. I am Dr. Shah Alam. I was working as a professor and head of orthopedic and spine surgery in Dhaka Medical College, and recently I have started my PRN, and right now I am working in Bangladesh Spine and Orthopedic Hospital, Dhaka, Bangladesh. And before going to my talk, I want to salute and want to show the respect to our people who sacrificed their life for the independence of our Bangladesh and our nation. So my talk is on the tuberculosis. It is the chronic and consumptive disease, and currently it is the world's leading cause of death. and tubercular spondylitis is the most dangerous form of skeletal tuberculosis. The recent emergence of mycobacterium tuberculosis that hints at the resurgence of the TB in coming years is because in the developed country, almost it is controlled or eradicated, but unfortunately in our country and developing country, this secondary tuberculosis, this is the incidence are becoming more and more. That's really a dangerous sign. So complications is the most dreaded, and neurological complication and deformity, mainly kyphosis. These two affect the quality of life as the life expectancy is increased globally, and persistent deformity affects biomechanics of all segments of the spine. That's a problem. So the post-tubercular kyphosis in genuine, the more than 80% patients with spinal tuberculosis have a certain degree of detectable kyphosis at the time of presentation or diagnosis. That's because it takes 3 to 4 months in pathogenesis before kyphosis starts to appear. One vertebral body height losses that gives rise to about 30 to 35 degree kyphosis. If we see the basic pathology of the kyphotic deformity, how it starts, we know the tubercular lesion is mostly about 90% paradiscal, and gradually after that, the vertebral end plate becomes structurally weak, and herniation of intervertebral disc into the diseased vertebral body, and this vertebral body loses more anterior height than posterior, that leads to finally angular kyphosis. And objectives of our treatment with effective chemotherapy and better operating theater facilities, ICU, and spinal instrumentation, and the diagnostics. And our expectation is the healed status of the disease with minimum or no spinal deformity. That is our present or recent goal. In thoracic spine, the line of weight transmission is in the anterior half of the vertebral body, so the kyphosis appears very early. In cervical, since the lumbar and cervical anatomically is the lordotic, and in cervical lesion, the weight transmission is the posterior half of the vertebral body, so the kyphotic deformity appears later. The severity of the kyphosis depends on the number of vertebral bodies affected and the severity of the loss of the anterior vertebral body height and the segment of the spine affected. The spine at risk, there are signs that is subluxation or dislocation of the facet joints at the apex of the kyphus and the presence of retroversion, translation of the vertebral column in coronal plane and posterior toppling side. The sequelae of the severe kyphosis, the compensatory reverse deformity, spinal canal stenosis, reduced capacity of the chest cavity and vital capacity, and painful costopelvic impingement. And if the dorsal kyphosis is more than 60, the repeated stressing of the spinal cord over the internal bulbus and upper motor neuron deficit starts early onset, and finally that leads to complete paraplegia or paraplegia, the flaccid time deformity develops. In treatment options, the development of the severe kyphosis and its sequelae can be prevented if the early diagnosis before development of the kyphosis, and identifying the patients at risk, and correcting the angular kyphosis in active stage of disease is easier than when it is healed. So indication of surgery in kyphosis when 3 or 4 vertebral body are affected, and initial loss is 1.5 vertebral body height in a dorsal or dorsal lumbar spine. But in children, it is different because the younger than 7 years, we must do surgery. 3 or more vertebral body affection in the dorsal or dorsal lumbar spine is the indication of surgery, and 2 or more spine at risk segment. When these 2 segments are involved, we must go for surgery. It's because moderate to severe kyphosis 50 or more than 50, the first presentation may need to correct. So kyphosis correction in tuberculosis may involve the anterior corpectomy, shortening of the posterior column or posterior instrumentation, and anterior and posterior bone grafting, the combined procedure sometimes we adopt. Ideally, both steps should be undertaken in the same sitting and sequentially. For an example, is heat, the weight tuberculosis in the lumbar region. As we know, many of us believe that no need to go for any correction of this deformity, as because if it heals nicely, patient it will be workable. But thing is that our biomechanics, the lumbar region, it is lordotic curvature. For that reason, we must maintain the lordotic curvature. It is a kyphotic. So though it is 16.5-degree kyphosis, we corrected it as because it needs to correct. This is a paraoperative radiology and is a paraoperative, the stabilization by pedicular screw and in their cases. And after that correction, if you see that initially the kyphosis is 16.3, but we corrected 23, and ultimately the lordosis we achieved about 7.2, 7.1 degrees, because 7 to 10 degree our normal working lordotic curvature needs to maintain in lumbar region. So it is the corrected position and acceptable position. The other one is atypical tuberculosis, just upper lumbar region. It looks at 45-degree kyphosis at the lumbar region. But one can say there's no need to go for any intervention and no need to correct, but no, it is biomechanically unacceptable. That's why we need to correct by posterior approach, by pedicular screw and rod and cases. And that leads that before that is a 45-degree kyphosis, now it's almost normal lordotic curvature that has maintained at the lumbar region. Another is the lower lumbar region. Huge kyphotic deformity, never it is accepted because mechanically, biomechanics doesn't allow. So this 45-degree we corrected. It was a healed state. This is a paraoperative, how much is angulation you can see. And this is corrected by transmitting screw and rod. And after correction, we maintain the height. Though posterior instrumentation was sufficient because the height has maintained and 5-degree, the lordosis have been achieved. That is acceptable normal lordotic curvature. And sequentially, when it is maintained, and finally, if you say after 24 months, those somebody cases entirely and reconstruction of anterior middle column, but without reconstruction, it has healed. And that is the beauty of it, because it heals very nicely. Sometimes it is also, we have to face in the children, you can see the give birth, use angulation. Clinically, it is not possible to maintain to, especially the lying condition. We corrected it by here you can see the 60-degree kyphotic angle was existing before surgery, and we corrected it posteriorly. And till now, there is some kyphosis, but since it's a children, you will wait and see, and subsequently it improved. 70-degree healed kyphosis. This type of surgery is very much dangerous because it is a junctional, the lower dorsal or upper lumbar where the, the spinal cord terminates. In the healed condition, sometimes that the catastrophe appears, the complete neurological deficit. We corrected it posteriorly. This is a before surgery. You can see this sort of gibbous was there, and we corrected by transpedicular screw and rod, and also we removed some part of the bones. So this is before surgery and this is after surgery. In discussion, I like to say that any deformity in healed tuberculosis is very risky. So implant with high corrective forces must be applied over a long period. And the correction of severe tubercular kyphosis is a difficult and dangerous procedure, especially when it is healed. For that reason, higher distraction forces are necessary to achieve full correction. And these patients have poorer pulmonary functional than normal. That's why we require the expert surgeon, expert anesthetist, and postoperative facilities should be available. Before surgery, we have to plan and ensure it. So in conclusion, I like to say the prevention of deformity should be the primary aim, and long-standing severe kyphosis produces painful, the osteopelvic impingement and reduce the vital capacity and lumbar canal stenosis and late onset of paraplegia. That's why with improved surgical technique and rigid spinal instrumentation involving 3-column posterior is the only approach for prevention and correction of the kyphosis. Thank you for your patient hearing.
So thank you, Dr. Shahalom, for an elaborate presentation on the kyphosis, its complications, and the management strategy. So that's wonderful presentations. Previously, when we didn't have this sort of surgery, our patient used to suffer a lot with this sort of bad deformity, with a lot of late complications. But fortunately, we could develop this sort of surgery in Bangladesh, and our people are getting the right treatment to gain a better life, still from suffering from tuberculosis kyphosis. Anyway, thank you. Thank you very much.
Thank you, sir.
So may I request Dr. Monaim, my co-chairman, another chairman of this session, to please conduct the next continue the session. Dr. Monaim.
তাহলে কিভাবে হবে? তাহলে কিভাবে শেয়ার করব আমি?
Dr. Monaim, can you hear me?
Excuse me, sir. I am a professor, Dr. Gulam Somani. There is Monaim sir no present here in this.
Acha. So should I continue?
Yes, sir. Yes, sir.
Okay. Okay. Thank you. Thank you. So we are in the middle of our presentations, and now we'll have another presentations, and another one is very interesting one. That is axial translation technique with pedicle screw and rod in a standard method for correction of idiopathic typhus scoliosis. Previously, before few years, treatment of scoliosis was not done in Bangladesh, and all the patients had to go outside for getting a treatment. So our surgeons has developed the technique and expertise for doing this surgery, and we'll have a presentations from one of our colleague, that is Dr. Muhammad Anwarul Islam, on this topic.
Sir, can you hear me, sir?
Sure, loud and clear.
Sir, but unfortunately I cannot share my screen.
Oh God.
There is no option. There is no option for sharing the screen. Probably admin should allow me to share the screen.
Host can allow. Host.
Yes, admin. That is host can allow.
Right.
Can allow you.
Host can allow to share my screen.
So can the host hear us?
Please.
Yes,
please
sir.
allow me to share.
Please allow.
Please allow me to share.
Sir, it's already on.
So please help him with the expertise so that he can share his screen.
No.
আনোয়ার
জি স্যার
শোনো
জি স্যার
তুমি পারবে না সকালে আমার এই প্রবলেম ছিল বুঝছো এই পোস্টের ওখান থেকে কি হয়েছিল পরে আমি কিন্তু অন্য আরেকজনের ইয়েতে শেয়ার করে তারপরে ঢুকছি আমারটাও ঠিক এরকম হয়েছে তুমি দেখো তুমি আমার মনে হয় যে রেজ আবার কেউ প্রেজেন্ট করো তুমি সময় নাও হ্যাঁ এই সময় পারবে না কারণ আমি এই প্রবলেম আমার আধা ঘন্টা লাগছে প্রবাস ওখান দিয়ে চেষ্টা করছি আমি পারি না পরে কিন্তু অন্য আইডি দিয়ে আমি ঢুকছি
কিন্তু স্যার আমরা যে করলাম স্পাইন সোসাইটির সময় আমরা তো সবাইকে অ্যালাউ করছি যে
অ্যালাউ করছি কিন্তু আমাকে এখানে ওই সকালে তোমার ইনঅগ্রাল সেশন ওয়াজ ফাইন আমি ভালোভাবে শুনছি আমি রিটার্নে গেছি আর হয় না আমি এজন্য বলছি মেবি ইট ক্যান টেক টাইম তুমি বসে থাকবা তো
I think we better proceed. Let Anwar fix his computer for the presentations.
দেখো হয় কিনা না no option dear host no option for sharing my screen
next speaker ke then Anwar
right okay now we'll be proceeding with our presentations so may I request Dr. Rizaul Karim to present his presentation on L4 L5 segmental instability and the management strategy with our thinkings. So may I request Dr. Muhammad Rizaul Karim for his presentations.
So can you hear me, sir?
Sure. I can hear you,
Okay,
and
sir.
also your presentation.
Good afternoon and Assalamu alaikum. Welcome everybody to our Boscon 2021. It is a new era, new dimension of Boscon because of COVID-19 pandemic. I am grateful to organizer giving me the opportunity for presentation. Mr. Chairman sir and moderator, learned faculties from home and abroad, and dear participants. I am Dr. M.D. Rajal Karim, working as associate professor in NITUR, working my presentation. Going to my presentation, number 4-5 segmental instability, management strategy, and our thinking. A 33 years young lady, good general health, present with severe back pain and leg pain, neurological claudication only a few meters. The patient has ODI score of 64, NRS back pain score of 8, and NRS leg pain score of 7. Severe worsening of symptom in the last 12 months. No motor weakness, no bowel and bladder involvement. Sorry. We see her X-ray and MRI shows that there is segmental L4-5 instability, and also there is compression in the dural sac. So now come to what is spinal segmental instability. Segmental instability of the spine is an abnormal amount of motion or hypermobility across two vertebral bodies. This hypermobility can be when one vertebral body shifts forward, shifts backwards, or sideways, causing an abnormal spinal alignment. Spinal instability occurs when the intervertebral disc begins to degenerate. The bulge of the disc gradually decreases and begin to lose its height. This causes the vertebra to displace from their anatomical position and override the disc. There are various types of instability: translational instability, rotational instability, and angular instability. We see here the X-ray and MRI show the translational instability, angular instability, and also there is compression in the severe compression or canal stenosis in the MRI finding. What are the natural history of the spinal instability? The Canadian author Kirkcaldy, Willis, and Farfan, they proposed that biomechanically the instability passes through 3 stages: stage of dysfunction, that is hypermobile spine; stage of instability; and stage of re-stabilization. When this stage is failed, the pain will increases and patient needs surgery. Some influencing factor for development of spinal instability, this included external trauma or fracture of the spine, metastasis in the spine, degenerative disc disease, congenital defect, spondylolisthesis, and in our country, more commonly we found that poor lifting techniques. What are the complaints of the patient? The most commonly presenting complaints of the patient is pain. The pain is initially confined to the back, then it gradually radiates down to the buttocks and legs. Patient may present with the numbness in the lower extremities. The symptom may get aggravated after prolonged sitting or prolonged standing. Laughing, coughing, or sneezing may also induce the pain. Patient may present with weakness of the lower limb, may present with the bowel and bladder involvement. How can we diagnose this? Diagnosis can be made by both clinically and radiologically. Clinically, patient may present with painful arc inflection. We see here the photograph. Painful arc on return. Patient may present with Gower sign. Patient present with reversal of lumbopelvic rhythm. Radiologically, the commonly done radiology is X-ray. We see lot of findings in the X-ray. One is common and earlier sign of segmental instability is the vacuum phenomenon. That is gas in the disk space is one of the earliest reported sign of segmental instability. End-plate sclerosis, traction osteophyte, flow osteophyte, these are all seen by X-ray. These are the signs of segmental instability. Also, we can see the facetal osteoarthritis by X-ray and spondylotic listhesis. These are also the sign of segmental instability. There are some special view for diagnosis of the spinal segmental instability, that the flexion, extension, and lateral rotation views in the X-ray, traction compression view, and lateral bending or side bending views. MRI, the gold standard radiograph for the correlation of instability and disc degeneration. We see here the MRI, there is degeneration of the disc and also translation of the vertebral bodies. A case illustration, a 55-year-old female with no significant pathologies, present with chronic low back pain and both leg pain that has severely worsened in the last 1 year. ODI score of 44, NRS back score of 8, and NRS leg score of 6. No motor weakness in the lower limbs. Radiological finding indicate L4 grade 1 degenerative spondylolisthesis and severe segmental stenosis. We see the preoperative static X-ray, the PA and lateral view. There is, we see here the segmental instability. We also did the dynamic X-ray, that is extension and flexion view. There is, we see here there is segmental instability. And we also see here the preoperative MRI, the sagittal MRI and axial MRI. We show there is a severe canal stenosis. What is thinking about management of this patient? A relatively young individual at 55 years who has been suffering since she was 54 years with almost equal back and leg pain in the absence of any neurological deficit, has fullness of facet, reasonable disc height, and a grade 1 listhesis with overall good balance. I would have a long discussion with the patient and patient party focus on shared decision making. I would offer a surgical strategies, surgical approach and technique. I would suggest performing L4-5 decompression as a first step, interbody fusion with bone and titanium case, and stabilization done by pedicle screws and rod. I would perform all by posterior approach. We see here the post-op X-ray. I did all in the by posterior approach. There is a publication which is present in the Spine journal. They suggest surgical management of L4-5 instability consists of segmental fusion. Segmental fusion. The emphasis on segmental fusion, which can be achieved through different techniques and approaches depending on the surgeon preference and the patient condition. Fusion strategy, there are a lot of technique for fusion. Anterior lumbar interbody fusion, that is ELIF, lateral lumbar interbody fusion, the posterior lumbar interbody fusion, and transforaminal lumbar interbody fusion. Overall management option of the L4-5 instability, the treatment option that could be proposed are non-surgical and surgical management. Non-surgical included physical therapy. It is only effective in treating mild spinal instability by strengthening of the muscle in the spine. Pain management by anti-inflammatory medication and foraminal and facet blocks. Surgical option are decompression, posterolateral fusion plus minus decompression, PLIF plus minus decompression, TLIF plus minus decompression, LLIF plus minus decompression, ALIF plus minus decompression. When we go for surgical management, when non-surgical treatment is failed, patient develop progressive neurological deficit, severe spinal instability, or intractable pain, not respond to any anti-inflammatory drugs or rest or any other measure. Then we go for surgical management. So in my conclusion, I would like to say the choice of the most appropriate approach depend on several factors. Anterior approach may be considered in cases involving previous posterior surgery to avoid scar tissue and potential dural tear, to prevent soft tissue injury, and to promote faster recovery. The choice of posterior approach and instrumentation allow for direct decompression of spinal canal, of course, necessary when there is no safe corridor for anterior and lateral approaches. So thank you. Thank you for question hearing.
So thank you, Dr. Rizal Karim, for discussion on a relatively common cause. Actually, common cause of backache, L4-5 instability, relatively common cause of backache. So you have given us a discussion. You have told us about the conservative management and the indications for operation. Thank you very much. So let's come back to Dr. Muhammad Anwar Islam. He is going to talk about the standard method of correction of idiopathic kyphoid scoliosis. Dr. Anwar, please.
Sir, please unmute.
Sir, can you see my screen?
I can. I think everybody can.
Okay, thank you, sir. My respected person, Professor Shahiduzzaman sir, who is one of my best and favorite and respected teacher. Thank you, everybody in this August gathering. Good afternoon, everybody. I am Professor Dr. M.D. Anwarul Islam, working as a professor and unit head of spine surgery, Bangabandhu Sheikh Mujib Medical University. And my today's talk is on adolescent idiopathic kyphoid scoliosis. What will be the solution for that diseases? Actually, I will emphasis on the axial translation technique, which is better than other method. I want to say here. So if you see this boy, 17 years old, he presented to me with the complaints of deformity of the spine and occasional dorsolateral pain with paraparesis, and his Cope's angle was 65 degrees. And he presented to me with the respiratory distress. So what can be the diagnosis of this after seeing this scenario? You just think, now the diagnosis is adolescent idiopathic kyphoid scoliosis. Now what is scoliosis? How can we define? This produces the scoliosis is the three-dimensional deformity of the spine that occurs in the sagittal, coronal, and transverse plane. How can we classify scoliosis? There are several methods. There is Snell classification, in which non-structural scoliosis and structural scoliosis as well. I do not emphasize on the non-structural scoliosis. You know all. The structural scoliosis, this is our concern. It can be the idiopathic scoliosis, can be congenital scoliosis, can be neuromuscular scoliosis, and other as well. In older ages, it can be the degenerative scoliosis. Idiopathic scoliosis is the most common type, and absence of any unknown etiology. The younger the age of diagnosis, the most likely to be progress the deformity and require treatment. It divides into three subtypes, that is infantile, juvenile, and adolescent. Infantile idiopathic scoliosis, and the person involved, the age will be less than 3 years and more common in boys than girls, and primary usually in the thoracic curve and who is convexing towards the left. There may be other associated problems, that is mental deficiency, or CDH and even other congenital heart defects, etc. Juvenile idiopathic scoliosis, the age will be 4 to 10 years, and it is more common in girls. Usually curve is on the right side, and 12 to 21% of idiopathic. Prognosis is usually worse in juvenile idiopathic scoliosis. Adolescent idiopathic scoliosis, this is our concern today. And child older than 10 years of age, before skeletal maturity, and proposed etiological factors, you know, many factors can be come into consideration. Now, what occurs in scoliosis? This is non-correctable deformity of affected spinal segments. Vertebral rotation is an essential component. Spinous process swing rounds towards the concavity of the curve, and transverse process on the convexity rotates posteriorly. These are the deformities. How can we evaluate the scoliosis? Evaluation by history, clinical findings, and radiological evidence. There are several histories, that is chronological age, age of onset, gender, deformity, back pain, menarche, neurological status, family history, and self-perception, many things. The clinical findings are usually the boys are presented or girls are presented with the deformity is the presenting symptoms. Other than this, there can be the raised shoulder, there can be the scapular deformity, there can be the rib horns, and there can be the tilting of the pelvis, and leg discrepancy sometimes we consider consideration. And we just differentiate the functional from the structural scoliosis by the Adams forward bending test. You know all what is Adams forward bending test. In scoliosis usually measured by scoliometry in human body. The patient bends over, arms dangling, and palms pressed together until a curve is observed in the back. The scoliometer is placed on the back and measures the apex, the highest point of the upper back curve. Ideally, the scoliosis is measured on X-ray radiologically. The X-ray whole spine extending from C2 to S2 anterior posterior view in a standing position, and X-ray same view in a lying position shows the kyphosis, and X-ray whole spine right and left bending film, X-ray whole spine push and pull film, and some stagnara view. That can be consideration for diagnosis of scoliosis. The other studies definitely should be done to see the CT scan whole spine to diagnose the diastematomyelia, because if there is diastematomyelia and we want to correct the curves, there will be the paraparesis or paraplegia even, and magnetic resonance imaging to see the neurological status and cord status. And definitely we go for the pulmonary function, because without pulmonary function, if we correct it, the patients may need to be respiratory distress. Patient may be developed to be respiratory distress. What see in X-rays? There are various parameters, that is simple curve, compound curve, primary curve, secondary or compensatory curve, that can be seen in X-rays. There are some parameters, that is which is end vertebra, apical vertebra, and CSPL line, that is central sacral vertical line, is a vertical line bisecting the sacrum, stable vertebra, neutral vertebra, and plumb line, that all should be considered to diagnose the scoliosis before surgical correction. Definitely Cope's angle is a parameter which should be cautiously measured. And what is this? How can we measure? There are several methods to measure the Cope's angle. You know, Reiser's-Ferguson's method, and this is rib vertebral angle of Mehta's method, and scoliotic, a vertical spinal line is first drawn, whose endpoints are at the center of the upper and lower ends vertebra of the curve, and lines are then drawn from the center of each vertebral body perpendicular to the vertical line, and sum of the vertebral body lines divided by the length of the vertical line gives the scoliotic index. This is the scoliotic index that should be measured before giving the surgical management. How can you evaluate the rotation? There is move pedicle method and Cope's finance process method for rotation measuring. This is move pedicle method, and this is the Cope's finance process method for measuring the scoliosis. How can we evaluate the maturation? Evaluation of maturation by secondary sex characteristics, bone age, excursion of the iliac apophysis, that is riser status, and ossification of the vertebral ring apophysis. This is the riser signs for maturation, type 0 to type 5, that is no ossification to fusion of total ilium. That is vertebral ring apophysis, closely parallel to the maturation of the spinal growth. And after radiological evaluation, how can we classify radiologically? There are different classifications, but for the surgical purposes, we considered King's classification, Lenke's classification, and Lippmann-Cope's classification. This is King's classification, 5 types, you know. This is Lenke's classification with its modifiers, we know it well. And Lippmann-Cope's classification, this is also important for before correction of scoliosis. Prediction of progression of scoliosis, that is scoliotic curve. Progression before skeletal maturity, female sex, there is more chance to be progression. Curve pattern, if there is double curve, progress more frequently than single curve. Curve magnitude, immature patient, that is pre-menarchal, risers grade 0 with curve greater than 20 degree are substantial risk for the progression of the spinal deformity further. Rate of progression in adulthood is slower. That is after skeletal maturity, that can be consideration. Curves of less than 30 degree in mature individuals are unlikely to progress. Curves that exceed 50 degree or sense, lumbar curves also tend to progress in adulthood. Treatment. There are several options based on skeletal maturity, curve magnitude, and curve progression. What are the treatment options? This is the 3 O's treatment option, that is observation, orthosis, and operation. We can observe if curve is less than 20 degree, we can observe. And orthosis should be used different types of orthosis, that is CTLSO, Milwaukee brace, and TLSO, that is Boston brace. There is different types of brace. Other type of brace is Charleston brace and flexible brace, that is spine core brace, that can be used for conservative management. But in case of surgery, there are some objectives. Obtain a solid fusion and to have the top and the bottom of the fusion balance within the stable zone. That is the objectives of surgery of scoliosis. Indication, less than 30 degree of curve sometimes be instrumented if failed conservative treatment. But ideally 30 to 45 degree of Cope's angle with progression, this is the ideal candidate for surgical correction. More than 30 degree with cosmetically unaccepted in skeletal maturity, if female child, usually. Balanced double curve, if more than 60 degree and progressing, that should be considered. Adult with back pain, that is degenerative scoliosis, should be take consideration before surgical treatment. And the surgical treatment options are different options. In 1960s, there is a system of Harrington-Ross system. 1970s, there is segmental fixation, move fusion, Luque method, various methods. Posterior approaches are in 1980s, that is Cottrell and Duboset instrumentation. In 1990s, invention of pedicle screws and rods. And by the pedicle screws and rods, there is various methods. Reduction, reduce the number of the fusion level, reduces the number of the junctional problems. The most Miami instrumentation system is also previously done. Rod derotation technique system, it is also in consideration, and this is also running procedure, single rod, double rod derotation, various techniques. And now the axial translation techniques is a very good techniques for correction of scoliosis and make the unstable, flexible, or rigid deformity into a very nice 80 to 90% of correction can be achieved by these axial translational techniques. There are very many anterior approaches as well. That is Joyce procedures, Silk's procedures. Now, what is done in axial translational techniques? That is our main concern. It's a very good techniques. The concave rod is applied to the upper and lower screws. On the concave sides, all of them are tightened fully. Then on rod is captured but not fully tightened. This enables the rod to slide when curve correction occurs. Then the convex rod is applied to the upper level of the construct, and gradual capturing the subsequent screws is done from the top to the bottom, thus providing axial translation of the spine. Not only the sagittal correction, the rotation and coronal correction can be nicely done by these axial translational techniques. And there are other methods also. I have already mentioned. This is other method I have already mentioned. Now I want to show some case illustration. Miss Afroja of 14 years, female, presented to me the gradually increasing deformity in the spine and occasional pain in the dorsolumbar region, some respiratory difficulties, but no neurological sign. Her Cope's angle was 75 degrees, and techniques was axial translational techniques. This is, you just see the preoperative photograph of the back and the X-ray. This is the 75-degree curves, Cope's angle. And this is the preoperative MRI, sagittal and axial, as well as CT chest, to see the deformity of the chest. And this is the perioperative picture or photograph. And post-operative Cope's angle is now only 20 degrees. So there is much more correction without hampering any neurological deficit or involvement, without hampering any neurology. Case 2, Master Shipon of 17 years old, male. Complaint was deformity of the spine and occasional dorsolumbar pain. He presented with the paraparesis and respiratory problem. His Cope's angle was 65 degrees and technique was rod derotational techniques. Preoperative X-ray, a photograph is the C. Now, this is the preoperative X-ray. In AP view, there is a 65 degree of Cope's angle. And lateral view, there is a dorsal kyphosis is more than 45 degree. And in a CT scan, sagittal and coronal, you just see that's how much there is a deformity at the dorsolumbar region. And this is the preoperative MRI, sagittal and axial section, perioperative photograph of that patient. And this is the post-operative Cope's angle, you just see only 25 degrees. So many degree correction done by the axial translational techniques. Now methodology, study design, retrospective study, duration January 2010 to December 2019. The total number of patients was 50. And there is a comparison between these two groups, axial translational techniques and the rod derotational techniques. Conclusion, the axial translational techniques is more correction than other techniques in idiopathic kyphoscoliosis. Discussion already been mentioned in result section that there is a more correction in axial translational techniques than other techniques with references. Discussion. Kendall et al. Showed the final correction of translation group by the 70%, whereas the other group is only 47%. In my study, the 74.35% correction is in axial translational techniques, then rod derotational techniques, where there is only 69.9% correction. Conclusion. Axial translational techniques with pedicle screw and rod construct through posterior approach is the best option to achieve good clinical and radiological outcome for patients of adolescent idiopathic scoliosis. Thank you, everybody. This is my lovely university where I am working. Thank you, everybody, for patient hearing.
So thank you, Dr. Anwar, for your presentation on correction of kyphoscoliosis. It's indeed a challenging topic, and we'll be looking forward for future better results on this surgery. Thank you very much. So we have nearly come to the end of our presentations. So we have got one of the last paper, one speaker on endoscopic lumbar discectomy. And this paper will be presented by Muhammad Akshad Al-Masoor. Akshad Al-Masoor. May I request Dr. Akshad Al-Masoor to please present your paper. Dr. Masoor, can you hear me?
Technique is more correction.
Yes, okay.
Already been mentioned in result section that there is a more correction in translational techniques than other techniques with references. Discussion.
Once Isaac Newton told, "If I have sinned further than others, it is by standing upon the shoulders of giants." So they were and are our giants, upon whose shoulders we are working now. Mr. Chairperson and learned audience, welcome to Boscon 2021 and welcome to my session. My talk is on posterior endoscopic discectomy, learning curve and our experience in Bangladesh. So this is my hospital. This is Pabna Medical College Hospital where I am working now. Posterior endoscopic discectomy is an established method for treatment of lumbar disc herniation. Many studies haven't been reported in literature for lumbar discectomy by distal endoscopic system. Endoscopic discectomy provides a safe and minimal access corridor for lumbar discectomy. So on historical background, Professor Yasirgil and Professor Casper from 1977 and also Dr. Williams and neurosurgeon, they were doing endoscopic discectomy since their era. So this is Mr. Jean Destindo from 1993. He is doing his technique and this is his book. So Destindo endospine system consists of endospine tube, trocar and working insert. Working insert comprises 4 ports. 1 port for 0-degree endoscope, 2nd for suction cannula, 3rd for working instrument, and 4th for dural and nerve root detector. So these are the different parts of the Destindo endospine system, trocar cannula system. Anesthesia may be general or spinal, epidural or local anesthesia. The operative technique consists of knee-chest positioning. So these are the anesthesia and patient's position. 15 mm skin incision is made. Epinesis is incised using Meyo's scissor, and 1.5 cm wide periosteal elevator is used to activate paravertebral muscles subperiosteally. So these are the incision and marking devices. But in our setup, we do with the measuring scale. The endospine tube with trocar is pushed through the incision in the direction of posterior arch over interlaminar window, followed by withdrawal of trocar. And the working insert is then fitted over endospine tube. And the endoscope and suction tube are introduced into their respective ports. Any soft tissue bulging in the mouth of tube is removed till boundaries of interlaminar window, such as superior inferior lamina, passage joints are clearly visualized. And once the nerve root has been accurately identified, it is retracted using a nerve root retractor. Dural and nerve root retraction can be further aided by cottonoids. Depending on local findings, discectomy involving the extraction of the nucleus pulposus is then carried out. Epinesis is sutured using bakery fine suture followed by closure of the skin. So my study is on posterior lumbar endoscopic discectomy by Destindo's technique. It is a prospective study, duration from September 2016 to till date. And the place of study, most of the cases were in private hospitals in Dhaka and also some cases in my private setup in Pabna. And total patients are 40 and 2 cases were converted to open. And surgical technique or endoscopic discectomy by Destindo's technique. So inclusion criteria are patients having lumbar disc collapse with unilateral radiculopathy, on clinical evaluation positive SLR or femoral stress test, identification of a single nerve root lesion on MRI, and all patients have had fair trail of conservative treatment. And exclusion criteria are patients with bilateral symptoms, double root involvement, cardiac syndrome, and most clinical symptoms didn't match with MRI. So evaluation of my 38 cases are evaluated by using modified Knapp criteria. And most of the cases of my series are female, that is 53%. And the highest number of cases were in the third to fourth decade. And most common site of the disc collapse was at the level of lumbar 4-5, that is 71%. And more involvement was at the level of left side, that is 55%. And functional outcome of my study, excellent in 76%, good in 16%, and fair in 8%. So here are some case illustrations. A man 34 years old presented to me with low back pain and radiating to both lower limb, predominantly on the right side. So it was a diagnosed case of PLID at the level of lumbar 4-5 on the right side. And we did endoscopic discectomy by Destondos technique on that side. And these are the X-rays, MRIs, and during operation pictures and after the operation of the patient. And another case, male 39 years, presented to me with low back pain and radiating to the right lower limb. And it was a diagnosed case of PLID at lumbar 5, sacral 1 on the left side. And conservative treatment failed. So we did endoscopic discectomy by Destondos technique at lumbar 5, sacral 1 level on the left side. So these are the pictures of that case. So these are also the pictures of my doing of endoscopic discectomy in my private centers in Pabna. So these are the pictures of my training. So these are the papers of endoscopic discectomy of different levels, but there are not very much papers in the world of endoscopic discectomy are published. So tricks and pitfalls to overcome steep learning. Exact localization of the disc space is very important. And endoscopic anatomy should be maintained. Inconvenience due to muscle intruding into the outer tube is especially a big problem during the operation. So advice to overcome steep learning curve, attend courses on spine training. After attending the live demonstration, one should attend cadaver or hands-on plastic workshop. After learning the hand movements on cadaver or plastic model, then if it is possible, you should visit nearby surgeon who is performing endoscopic procedures with endospine. Then for the first case, one can try simple left side lateral disc collapse with root compression without stenosis. Usually start with simple lateral disc protrusion at lumbar 5 sacral 1 or lumbar 4-5 on the left side. And after each and every case, self-audit yourself and discuss your difficulties with your mentor in the spine. So possible complication in my series, 2 cases, dual puncture. So we had to convert it to open, but nerve injury, spondylodiscitis, wound infection, was piece left, or fracture spinous process, recurrence may also occur. So there are some limitations, lack of technical support, number of patients in my series is 4, and we are still at the primary stage. So take home message, it is a versatile technique but simple technique. Extruded and soft disc are strongly indicated. Though it is called minimal invasive procedure, but it is actually maximally invasive. So here is a video of my case. This is a case of PLID at the lumbar 5 sacral 1 on the left side, and it was a extruded disc, used disc you see here. And we did endoscopic discectomy by Destondos technique. Here fenestration is going on. After fenestration of the ligamentum flava, we dissect at the axilla of that case, and extruded disc was seen, and it was taken out by the hook. Yes, here the extruded fragment is taking out. Usually start with simple lateral disc protrusion at lumbar 5 sacral 1 or lumbar 4-5 on left side. It is not very difficult, but you have to be very careful because nerve root may be injured. Now further loose fragments are being taken out, and After that, we did foraminotomy also, and the root was completely free. So take home message, it is a versatile technique and the extruded and soft disc post-operative period was uneventful and patient was discharged just the first post-op and the patient result was excellent. So thank you very much for your patience hearing and thanks to the organizer to give me the opportunity here for presentation and thank you all.
So thank you very much, Dr. Mashur, for the presentation on endoscopic discectomy. But in my opinion, I feel selection of cases is very important to get a success in this endoscopy. Yes.
Professor Shohidujaman sir, please. One person left.
I know. It is Dr. Sharif Ahmed. I'm sorry, I missed him. But anyway, never led the river. So may I request Dr. Sharif Ahmed to present his paper on thoracolumbar bust fracture treatment. Dr. Junaid.
So thank you, sir, for giving me the opportunity. Can you hear me, sir?
Yes, sir, loud and clear.
Okay, sir. Just allow a few minutes to a few seconds to sharing my screen. So thank you, Mr. Chairpersons, moderators, learned audience from home and abroad. Assalamu alaikum and very good afternoon. So today I will talk on a very common fracture, that is an unstable thoracolumbar bust fracture with a very uncommon procedure, that is a single posterior approach for unstable thoracolumbar bust fracture with anterior reconstruction and posterior instrumentation. So I have nothing to disclose. You all know that thoracolumbar bust fracture is the most commonest fracture that encountered most commonly in our clinical practice. But still, there is controversy regarding the best treatment modalities. Fracture morphology, neurological status, and surgeon preference play a major role in depending the appropriate approach. Problem is that the combined anterior and posterior instrumentation provides the most stable repair, but the use of both approaches on a trauma patient may increase the morbidity. So, the anterior reconstruction of spine through only one approach can provide the effective outcome. So, if we see the epidemiology, we can see that total spinal injury incidence is around 210 per million per year. Among them, thoracolumbar spine injuries involve 90% of all spinal injuries. And again, bust subtype presents 10 to 20% of these injuries. So these patients have some goals, that is vertebral column stability restoration, kyphotic deformity correction, neural canal decompression, and early mobilization. So this can be achieved either by conservative or operative, but still there is controversy. If you think, suppose a patient need to be operation, you have to think whether you should go anterior or posterior or combined. If you think, if you do it by posterior, what should be the form? Is it the short segment, long segment, or combined? So let's see some case. So this is a case of bust fracture. You can see here that is treated nicely by a short segment fixation, but problem is there is failure due to loss of vertebral height. And this is another case that is also failure due to rekyphosis. And you can see here, this is also another case with a screw backage. And this is another case with a screw pull out. Even this may happen if we do it by intermediate fixation. That means that includes the fracture vertebra, or even in the long segment, or if you introduce the bone cement. So problem is, so how can we determine what should be the rule? So you have to think, determining the treatment, the most important things, the one is the motion segment preservation, kyphotic correction, neural decompression, as well as stability restoration. So how can I overcome this? So before going to start the treatment, you must assess the patient clinically as well as radiologically, and sometimes you have to select the appropriate form. And by selecting, you can apply the classification system, the one of the most classification system, that is the thoracolumbar injury classification system. By this way, you can determine whether this patient required conservative or operative. If you think that if the score is more than 5, then you can select the operation. And again, operation, there are lots of options. You can go it through anterior, posterior, or combined. The most important things, the load sharing classification, and that is our topic. So if that is based on the combination of the fracture, and that is also the apposition of the fragment and deformity correction. If your patient have the score more than 7, you must need a anterior reconstruction. So whenever a patient comes to you, you first think whether this patient required conservative or operative. If operative, you have to choose which approach. Should it done by only posterior or combined, or you can do it by both anterior or posterior. But today's topic, my emphasis, I can do it only by posterior through anterior reconstruction as well as posterior instrumentation. So this is a very small number of patients, only 8 patients with age range of 16 to 60 years. In my series, only the burst fracture who have a load sharing score more than 7 with a TLICS score more than 5 are included. So this is the case illustration number 1. So look carefully. This is a case with a lumbar 4 fracture. If you think, if you do it by only posterior, and either can be short or long segment, there may be chances of failure because anterior column is already destroyed. So if we think it do by long segment, you have to also think about the number of motion segment. That's why you have to choose very carefully. So in that particular case, what I did, actually, as it is a lumbar, so I thought it will be better to preserve the motion segment as well as to preserve the anterior column reconstruction. So that is done nicely by a short segment with anterior reconstruction through corpectomy. And you have to be very cautious regarding introducing of case to avoid the injury to the root. So this is another case with a fracture lumbar 3 with a kyphotic deformity with a anterior column failure. So again, this case I done through the single posterior approach with anterior reconstruction by using a cylindrical case. And you can see here the follow-up. This is the preoperative picture, and this is the just after 10 days later, patient can walk with a good neurological outcome, and patient is very much happy. And you can see the postoperative picture. There is good lordotic of lumbar spine as well as restoration of the anterior column as well as opening the anterior column. So this is the result. In my series, the mean improvement was noticed is 1.67 of ASIA score, and kyphotic angle was improved from 25 to 5 degree, and significant improvement of Boscon. The problem is only it takes long duration, at least 4 to 5 hours, and with a blood loss that on an average in my series observed, that is 440 ml. So in discussion, there is a study presented by Young et al. They have clearly shown the 3-column reconstruction through single posterior approach for treatment of unstable thoracolumbar fracture is a safe, effective, and offers some advantage over the classic posterior, anterior, or combined approach. This is also supported by another study. So in conclusion, I would like to say single posterior approach is a safe, cost-effective, and reliable surgical approach for reconstruction of all the columns of the spine. It reduces the operative time, blood loss, and morbidity associated with the combined approach with a good outcome. Thank you. Thank you for patient sharing.
So thank you very much to Junaid for good presentations. So we have come to the end of our session. So let me thank all the participants and the speakers. Best of luck. Stay safe. Thank you very much.
Thank you, sir.
Thanks all the presenter for the nice presentation. Thanks Shwedizaman sir to conduct this session. Wish good Boscon. Thank you all, sir.
I was looking for you.
we are with Max, sir. Yes, sir. Yes, sir.
Sir, we are here, sir. Shwedizaman sir.
Yes, sir.
Yes.
Sir, we are here.
Wonderful seeing. Good. I think it's going well.
Thank you, sir.
Okay. Okay.
আমি কিন্তু জাহাঙ্গীর দেখতে পারতেছি।
Thank you, respected chairpersons of the previous sessions. We want to move forward for the next sessions, session 4. And I would like to request Professor Dr. Muhammad Iqbal Kabi sir, Professor Fakhrul Amin Khan, and Professor Chandan will join from Chittagong, Fakhrul from Dhaka Medical College. Thank you, Professor Khandokar Abdullah Al Rizvi. We can see you. Thank you, sir.
Yes. Thank you, recognizing me.
Sir, Professor Iqbal Kabi sir, please start your session, sir. Unmute, please, sir. এই আমাদের একটু দেখাও স্যাররা দেখুক।
Now we can. I can see you people.
Yes, sir.
Thank
Yes,
you.
sir.
We're still there.
So you're inside the OT?
Yes, actually, unfortunately, I'm stuck up in the theater. I could not go home, so it has been difficult. I think I have a session supposed to be started at 4. So,
Dr. Nesar, you are searching when your session will be start. Your session will be start after this session, after completion of this session. Can you hear Dr. Shah Nesar? Probably you can hear us. Okay, Professor Iqbal Kabi sir, start please. We cannot hear you, sir. Dear admin, please. Sir, to unmute kora ache. Yes, you are unmuted, but there is connection problem probably. Still not, you are not audible, sir. Can you hear us?
Please remove your headphone.
Sir, ওটা খুলে got a problem. Right. Video off current. Admin off the video. Yes. Then. Dr. Rajiv, please wait, please.
Hello.
Hello.
Hello. Greeting. Warm greeting from India.
So warm greetings from also from Kolkata. Right?
Yeah, Kolkata. Yeah.
Yeah.
So missed meeting you all physically this time. Can see you.
Dr. Shohit, I think he can start till Kavi gets ready.
Yes. Before joining by Professor Iqbal Kavi and probably Fakhrul Amin Khan and Chandan Kumar Dash, you're not there. So we can start one paper.
Right.
This is by Lieutenant Colonel MD Jamil Jahidur Rahim. Jamil Jahidur Rahim.
Yes, sir. Sir,
you start your presentations and Professor Iqbal Kavi will join.
Okay, sir. No problem, sir.
The advantage of the 3 portal techniques for anatomical ACL reconstruction. Okay. Okay, fine. Probably you're sharing a screen. Okay, fine.
Sir, am I audible?
Audible and visible.
Okay, thank you, sir. Respected Chairman and learned audience, Assalamu alaikum and good afternoon. I welcome you all to my presentation on advantages of 3 portal technique for anatomical ACL reconstruction. Anatomic placement of an anterior cruciate ligament graft is critical to the success and clinical outcome of ACL reconstruction. Previously, non-anatomical ACL reconstruction was done through transcription. That was vertically oriented ACL graft. It could resist the anterior tibial translation, but failed to control the combined anterior tibial translation and internal rotation. Nowadays, surgeons are doing anatomical ACL reconstruction. What is anatomical ACL reconstruction? Anatomic ACL reconstruction is defined as positioning the ACL femoral and tibial tunnels at the center of native ACL attachment site. Anatomical ACL reconstruction usually done through 2 standard portals, anterolateral portal and anteromedial portal. Accessory anteromedial portal recently has been introduced. These are the sites of standard portal, that is antenatal portal and medial portal, located near the patellar tendon and high up from the joint line. The accessory anteromedial portal is placed near the joint line and more medially. Function of the portals. Anterolateral portal is used as a viewing portal. Anteromedial portal is for both working and viewing portal. The accessory anteromedial portal is used as a working portal for instrumentation and for drilling the ACL femoral tunnel. Advantages of anteromedial portal technique. ACL femoral tunnel is drilled independently of the tibial tunnel. Angle of the ACL tibial tunnel is not compromised during drilling of the ACL femoral tunnel. Medial portal technique does not require any special guides or instruments. This portal is used for inserting femoral interference screw for drilling the ACL femoral tunnel. Viewing the ACL femoral attachment site through the anteromedial portal also gets the need to perform a routine nosoplasty for visualization purposes. it has got some disadvantages. Posterior femoral cortex may be blowout when drilling through anteromedial portal. When drilling through the anteromedial portal, femoral tunnel length is shorter than anteromedial portal. The axial obliquity is significantly higher in anteromedial portal than anteromedial portal. Why we will use the accessory intermedial portal? ACL reconstruction used in the medial portal technique highly facilitated by the help of accessory intermedial portal. Accessory intermedial portal is placed under direct vision and needle guidance. Here we can look a short video clip. First, we will introduce a needle so that we should not damage the articular cartilage and meniscus. This is the side of anterolateral port. This is medial port and accessory anteromedial port. If we use the anteromedial portal as a viewing portal, we can see inside of the nose very clearly and identify the attachment of native ACL. Advantages of accessory anteromedial portal. Accessory anteromedial portal allows the ACL femoral attachment site to view through the anteromedial portal. The accessory anteromedial portal techniques provides improved arthroscopic visualization during drilling of the ACL femoral. Working instrumentation is inserted into the notch through the accessory anteromedial portal. We can use anteromedial portal as a viewing portal and accessory anteromedial portal for instrumentation if we create three portal techniques. Drilling through the accessory anteromedial portal increases the ACL femoral tunnel length. Creates a elliptical ACL femoral tunnel which is more anatomic compared to the femoral tunnel through the anteromedial portal. If we drill through the accessory anteromedial portal, it will create a elliptical tunnel and vision is very, very clear and that corresponds to the native ACL. It has got only one disadvantage, that is placing the accessory anteromedial portal too medially can damage the medial femoral condyle when drilling the ACL femoral tunnel. So in conclusion, if we create three portal technique, the anterolateral portal permits a broad and unobstructed view of ACL tibial attachment. Anteromedial portal allows a straightforward view of ACL femoral remnant and bony landmark in the intercondyle. The accessory anteromedial portal enables to reach femoral native insertion site of ACL. So, the three portal technique provides a better view of tissue remnant and bony landmark, facilitating anatomical positioning of ACL. So, last of all, thank you, sir. Thank you, everybody, for patient hearing.
Next A.
Yeah. Professor Iqbal Kavi, sir, are you connected with us? Professor Iqbal Kabir? We cannot. So probably we will move forward because Kabir sir is disconnected anyhow. I would like to request Dr. Rajiv Raman from India. Dr. Rajiv Raman from India. He will talk on decision making on meniscal injuries. His speech, decision making in meniscal injury. Okay, thank you. The screen is shared.
Yeah. Thank you so much, Team Boscon, and warm greeting from India. Just meeting you all physically this time. Can you hear me?
Yes.
Yes, can you hear me?
Yes.
Yeah, all right.
What
So I will be talking on decision making in meniscal injury because there is lots of dilemma in what should be done and in which situation what should be your approach. So in daily practice, if you see, there is a gap between what should be done and what is actually done. And this is where we have some issues on decision making, what should we do, what we should do in which type of meniscal injury. And if you see literature, there are variable opinion, whether to repair the meniscus or whether to resect the meniscus or to balance the meniscus. You don't have a single opinion in literature also. So if you divide the meniscal tear according to etiology, it's a traumatic or a degenerative tear. And yes, there is still ongoing debate what is the best approach for meniscal surgery. So believe me, my friends, for traumatic tear, the best option and the first option should be meniscal repair. And for traumatic tear, meniscectomy should be your last option because such you have a very robust tissue, you can repair those robust meniscus. But for degenerative tear, meniscectomy or balancing is the best option. And again, most of these degenerative tear can be treated conservatively unless you have a locking symptoms or not. One of the commonest tear we see on a day-to-day practice is radial tear. You can see here in this picture is a classical radial tear. Again, whether you will repair or balance it depends on the age of the tear, zone of the tear, and quality of the
ঠিক করলো হোস্ট কিছু একটা ঝামেলা করে রাখছিল বুঝছেন হোস্টের ঝামেলাটা ছিল যে হ্যাঁ না আমি বলি অপশনটা কি ছিল আমার
all right yeah should I continue, sir?
Sorry.
Yeah. So, and most of this radial tear along with ACL, if you are dealing with this radial tear with the ACL tear, you can leave it alone also. So, if you are having an undersurface tear or a radial tear with an ACL tear, believe me, leave it like that because of the good vascularity, that tear will heal nicely. So, horizontal tear and cyst. This is another common tear we see in our day-to-day practice, and always try to preserve as much of the meniscus as possible. And with your probe, you can identify which layer is the unstable layer. So try to debride the unstable layer and try to repair these two layers with a horizontal or vertical mattress suture. And never forget to empty the meniscal cyst or debride the meniscal cyst, because if you have balanced the horizontal tear, you have not debrided the cyst, most of the time you will have a very painful complex tear. Take time in planning because I want to preserve most of the meniscus because I don't want to have a degenerative changes inside the knee joint. So identify and reset the unstable layer of the meniscus. Be very judicious in saving the peripheral rib. So longitudinal tear or a bucket handle tear. So it's depend careful evaluation. Most of this bucket handle tear, if it is reducible, try to repair it. You can see here it's a big bucket handle tear, and whenever possible, suture it. The gold standard is all inside meniscal repair. You can see here this large bucket handle tear we are repairing with the all inside technique, and you can have a 2 or 3 vertical cinching sutures of starting from the posterior aspect to the anterior aspect to repair whole of this meniscus. And after that, you can see the whole of the meniscus has been repaired. Degenerative meniscus tear, as I told you, most of this tear can be treated conservatively. The only indication for surgery in degenerative tear is whenever your patient is having a locking symptoms or a click inside the knee. Root tear, nowadays we are repairing more of the root tear than the meniscus tear because of the traumatic injury, the pivoting effect of the knee over the knee. you have anterior horn avulsion, posterior horn avulsion. Sometimes you have a complex root tear also. So try to repair this root tear, because if you don't repair them properly, ultimately you will have instability in the posterolateral or posteromedial corner of the knee. So my dear friend, all tears are not same as customized. So you should customize yourself with the type of the tear. So one meniscus tear you see today is not the same you see it your next OT. So yes, you have to plan accordingly, very sincerely, and that will help you in decision making in meniscus tear. So these are the few cases. This is a 10-week-old bucket handle tear. So I am trying to reduce it. So if you can reduce it, try to repair it with a vertical mattress suture. Start from the posterior part and then gradually go anterior. It depends. Sometimes the question is asked, how many suture anchor you need? It depends upon the length of the tear. If you have a big tear, sometimes you can come out with 3 or 4 meniscal suture repairing device. And always try to give a vertical mattress suture, because it has a good sinking effect over the meniscocapsular junction. And once you have repaired it, you can see there is a robust tissue. You can probe; it's not coming inside, so it's a good repair. This is a very interesting case. You will see my arthroscopy friends are there. ACL with a partial thickness meniscus tear. So once you put your scope inside, you can see here there is an undersurface tear. You can see here I'm putting my probe inside and it's an undersurface tear. So partial undersurface tear, what are the treatment options? Believe me, my friend, don't waste your suture here. Most of this tear, if you repair the ACL, if you reconstruct the ACL, and just go for a simple debridement over the undersurface, it will heal properly. So partial tear, undersurface tear over the lateral meniscus. Never try to waste your anchor there. These anchors are very costly. Ultimately, your patient has to pay it. So just debride it with a saber. You can see I am just debriding the undersurface because of the good vascularity. And as you know, meniscus got its vascularity from the undersurface only. It will heal properly. So partial thickness tear. Your rule is don't try to put any anchor there. Just debride, just debride. This is another case. Now we can see is a avulsion injury, and which is more common with the lateral meniscus, posterior horn of the lateral meniscus. You can see, and this patient has a traumatic injury. You can see whole of the lateral meniscus has avulsed out, and it is just floating in the posterolateral compartment. So it's always better to repair such type of tear. You can see there is the osteochondral defect also here. So if it is less than 1.5 centimeter and it's well covered, can be well covered by meniscus, leave it, because that will be healed. That will be healed with the fibrous cartilage also. So the first and most important step is make your tunnel in the posterior part. And you can see here I am using the ACL jig to make the tunnel in the posterolateral part. Be careful here because you have neurovascular bundle here. Now pass your suture loop and park it in the anteromedial compartment. You can see here, now I have passed my suture loop and parked it in the anteromedial compartment. Now we have different device available now to take a bite through this tear. You can see here, and this is a self-retrieving suture passing device by Smith and Nephew. And once you take a bite, you can see you can just, because it's a self-retrieving device, you can take all of the bite from the inferior surface toward the superior surface, and then it's coming inside. You can just pull it inside the joint. Here you can see I have taken my bite, and once I am taking my first pass mini out, here the whole of the suture is retrieved over the anterolateral portal, over the anteromedial portal. Now you can put 2 or 3 knots here, half-inch knots, 3 or 4 half-inch knots here, and you can see here I have tied it with a half-inch knot. Now you have to pass the suture through the tibial tunnel over the anterolateral aspect of the tibia. Here you can see now I've passed it, and once you fix it over the post, you can see the whole of the meniscus is sitting down nicely over, and the osteochondral defect was there, that is well covered by the meniscal tissue. So most of the meniscal injury, meniscal root injury, try to repair it on day 1 with the ACL reconstruction, and do this meniscus root to prepare before ACL reconstruction, because once you have reconstructed your ACL, your knee is very tight to do this, pass this instrumentation over the posterolateral or posteromedial compartment. This is the last case. It's not very uncommon scenario. We see once we have balanced the discoid, we have very unstable layer over the peripheral rim, and always try to preserve this peripheral rim, because if you preserve this rim also, you are preventing the degenerative changes inside the knee joint by 40 to 60%. To try to preserve, once you have removed this whole of the discoid, you can see there is a complex tear over the rim. So There are two options. Either you can go for a meniscectomy or a repair of this peripheral unstable rim. So nowadays we try to repair this unstable rim, and that can be done by the vertical mattress suture. You can see here, this is same self suture passing device. It's a 2-0 non-observable fiber wire, and just you take it out because it's a self-retrieving device. You can see here the whole of the meniscal tissue is getting cinched with the suture passing device. And once now you use your shoulder knot pusher to take a vertical mattress suture, and you can see here this is a shoulder knot pusher by which I am just tying it. And try to put your knot towards the capsular side, which is very difficult in menisci, but and then as we do in meniscal repair, the Bucket 112 start from the posterior aspect, then repair the body part and come anteriorly. You can see after putting 3 or 4 vertical cinching suture, you have a very robust meniscal rim. You can see here you have a very robust meniscal rim, and that is important because now I have preserved the meniscal rim. And this is important. You can see 1, 2, 3, 4 vertical mattress suture with 2-0 orthocord or 2-0 fiber wire. You can just stabilize this unstable rim, and if you preserve this rim also, that is very important to prevent degenerative changes. And now with my 6th finger, that is my probe, I am pulling it out. You can see now the whole of the peripheral limb which was unstable is very stable now. So my dear friends, these are the few cases which I want to share, and I would like to share with you about meniscal injury. So once you get a meniscal injury, first thing and most important part is that decide upon the age of the patient, the duration of the injury, and the type of the tear. And in 2021, I like to say, try to preserve the meniscus, because if you go for meniscectomy, you are just inviting a degenerative changes inside the knee joint. Thank you.
Thank you, Dr. Rajiv.
Thank you, sir. Thank you, sir. Thank you, Iqbal, sir.
Rajiv, it was a good paper on how to manage different meniscal injuries. Thank you, Rajiv.
Thank you so much, sir.
And good to see you again. The next speaker will be Dr. Chaudhry Iqbal Mahmood from BSSMU, and his paper is on revision ACL reconstruction. Dr. Iqbal, you are.
Yeah, can you see my slides?
Yes.
Yeah, I'm audible.
Yes.
Okay, thank you very much. Respected chairperson and dear colleagues, good afternoon and assalamu alaikum. I'm going to present a very complex and big topics, that is revision ACLR. Mainly, I'm going to focus on the misplacement of the tunnels. So I have no disclosures. Many times a patient come to you after ACL reconstruction that, Doctor, what happens after my intercruciate ligament reconstruction? They usually come to you with recurring instability, loss of motion, and persistent pain. So if you see, there are 120,000 primary reconstruction occur in the world, in the United States. As the number of ACL reconstruction increase, the number of revision ACL reconstruction also increase. So if you see the literature, the studies describe that the rate of revision ACL is not so uncommon. That is 1.7 to 7.7%. So how is a successful is ACLR? If you see the literature, that 63 to 69% of the patient go to return to play, playing at the same level is 43%, and 30% not able to return to sports. So re-injury, even higher in a younger patient. So what are the causes of revision ACLR? If you see, there's a large Mars group study which indicates that traumatic and technical errors are the most common cause of ACL failure. Among the technical error, ACL malposition of the tunnel is the most common cause. So what malposition causes the ACL failure? Poor tunnel position cause rotational instability, increased graft stresses, and non-anatomic reconstructs ultimately lead to abnormal knee kinetics and limited range of motion, which may lead to early failure. So graft placement in single bundle ACL are essential for knee mechanics and transplant survival. ACL revision surgery is performed when a first time ACL repair or ACL reconstruction did not work and the surgery has to be redone. And recurrent instability can be defined as the failure of the reconstructed ligament to provide adequate stability. There are actually no definition for ACL failure. So we can assess the ACL failure by objective test and subjective test. So the outcome of revision ACL is not that good like primary ACLR because the likelihood of failure is 3 to 4 times than the primary ACLR, and rate of return to sports is also low. Our rates of associated chondral and meniscal injury is also high. So before doing the revision ACLR, the pre-operative planning is very important. So before entering the OR, you have to check all the previous data and records of the patient, how actually went wrong on the previous surgery. And so what did it fail? What is the present condition of the knee? What graft was used? And what implants was used for fixation? What is the tunnel position, tunnel enlargement, if there is tunnel enlargement widening? And what is the bone condition? These are the questions you have to ask before going to revision ACLR. So history and clinical examination is very important before doing the revision ACL. You have to do all the clinical examination to assess the stability of the knee, and if there is any associated injuries you missed in the primary ACLR, like if there is a meniscal root tear or ramp lesion, or there is any other associated injuries like posterolateral corner injuries, or if there is any malalignment of the joint. Then after clinical examination, you have to do the X-ray, MRI and CT. X-ray, these imaging models will give you an idea about the position, if there is a malalignment or the varus, or there is increased posterior slope, or the position of the previous graft and previous fixation devices. There is a widening of the tunnels, and CT will help you to measure the tunnel widening and tunnel length, and MRI will give you idea about whether there is any associated injuries or not. So before doing a revision ACL, you have to do all these investigations. So femoral tunnel misplacement, if the femoral tunnel is too shallow and high, in that case, the graft will be taut in flexion, and it will give you increased tension on the graft and ultimately fails. And if the graft is vertical, in that case, it will give you graft tension, high tension and extension, and ultimately the graft will fail. These are some ways you can measure the correct position of the femoral tunnel after surgery. This is the femoral inclination angle in the MRI, and these are the femoral tunnel angle. You can assess the correct position of the tunnel before doing the revision SLR. And in case of tibia tunnel malposition, it may be too anterior. In this case, you can see the tunnel screw is very anterior, or it may be too posterior. So in case of and you can assess this by simply Amis-Jacob line. It should be on the 40% from the anterior side, the exit point intraarticularly. If it is too anterior, it will cause roof impingement during extension, and loss of extension ultimately leads to graft failure. And if it is too posterior, it will impinge the PCL, and ultimately it will decrease the flexion and leads to graft failure. And if it is too lateral, like just lateral to the medial tibial spine, if it is lateral to that, it will cause the lateral impingement, and it ultimately leads to graft failure. So for better revision SLR, the graft selection, tunnel creation, fixation devices, associated injuries, and individualized careful slow evaluation is important. So if we see the tunnel placement, it may be, in case of femur, it may be anatomic. That is, the ACL tunnels are within the anatomic footprint, or it may be non-anatomic. That means the completely incorrect position by outside the footprint in the previous primary ACL surgery, or it is partially correct, but overlapping the anatomic footprint. These are the scenario we can get in tunnel misplacement. In case of non-anatomic, completely incorrect, that is outside the footprint. But that means that in case of transtibial technique, the graft is vertical and it is complete outside the anatomic footprint. These are the cases, it is easier to do revision surgery because you can create a new tunnel without hampering the other the implants, previous implant. So you can do a separate tunnel, anatomical position, and you can by it can be done revision ACLR. A non-anatomic, that is, as I said, here is a vertical, the previous implant side, and you can do the lower anatomic tunnel. So without touching the previous implants, you can do it with a endopartent fixation in the lower anatomical side. If partially correct, this is the most challenging situation. That is, the tunnel is near anatomic, but if you do a tunnel near to the anatomic side, it will overlap or crossing your previous tunnel. In that case, you can do two-stage surgery with bone grafting, or you can one-stage surgery by diverging the angle of the tunnel, or over the top procedure. That is, you have to divert the graft posterior to the femur through a separate lateral incision. This is the over the top position. This is two-stage by bone grafting. And tunnel, this is the divergent technique. You can just in a different, by just creating the tunnel differently, you can avoid the tunnel overlapping. And another situation is anatomic correct tunnel. In this situation also, you can use the previous tunnel. If there is a metal implant, you can remove the metal implant by just removing the metal implant and debride the remaining of the tunnel with curette or bar or anything, remove all the fibrous tissue. Then you can use this tunnel, with a, use the graft bone patellar bone tunnel with a bigger bone plug and with a bigger interference screw. If the tunnel diameter is more than 16 degrees, then you have to second stage it. So this is if there is tunnel is anatomic position. Here is a case. This case was done previously by open technique. Here you can see the tunnel is in the tibia is very anterior, and this the graft is the discontinuation of the is of the vertical graft. So here you get this is the graft tissue which is lax, and it is attached to the PCL and roof of the intercondylar notch, and this medial side of the lateral wall is quite empty. So it is easier to do revision by creating an anatomic tunnel in the femoral side, femoral condyle. Here you can see through the enteromedial, extraenteromedial border, you see the femoral attachment size. You can mark it or by OWL or a radio frequency device. It's quite posterior and below the intercondylar notch, and just bifurcate notch here. You can make an anatomic tunnel in the revision case. So these cases, completely non-anatomic cases, is easier to do a revision because you don't have to take care of the previous implant. So yes, this is the guide wire through the anatomic footprint. This is the tunnel at the posterior lower part of the femur. This is the passing suture. And this is the graft. This is the graft. In case of tibia, it is better. There is a technique called sequential eccentric drilling. If you use this technique, then it is easier to make a tunnel in the anatomic footprint. Here you can see what you have to do by after passing the guide pin, you have to ream by smaller reamer. That is start from the 4.5, then adjust the tunnel position. Then you will do the reaming according to the graft size. So essential, then in that case, you will never miss the anatomic site for creating the tibial tunnel. Here you can see the creating tibial and passing of the graft. So what are the filling options in case of second stage surgery? Filling option, you can fill the defect if the tunnel diameter is more than 14 millimeter by graft, autogenous iliac crest graft, or any other autogenous graft, or allograft. Western countries, there are allograft bone dangles were available, but this is not available in our country, or any bone substitute calcium phosphate. These are the techniques you can fill up the defect and do a second stage after 4 to 6 months. And tunnel preparation, as I already said, if the tunnel is in the anatomic position, you can remove the hardware. If there is a biodegradable screw, you can ream through the screw, because biodegradable screw are very difficult to remove. If metal screw, you can remove the metal screw and use this tunnel by a bigger graft and bigger and interference screw. You have to remove all the fibrous tissue, all the material from the tunnel before inserting the revision tunnel. And fixation, there are different fixation devices you can use according to your need. But in the revision cases, you can augment the fixation with a double fixation. Like in case of aperture, you can use the aperture with a suspensory, and also you can use in a tibial side with a cortical screw and washer, in addition to interference screw. And never forget to address the if there are associated injuries, like in most of my cases, I do the lateral extraarticular procedure like lateral extraarticular tenodesis. If there is any increased pivot shift test, or if there is increased laxity, you have to address the posterolateral corner also. You have to address the bony malalignment like varus. If there is varus alignment, you can do a osteotomy. Or if there is increased posterior slope that is more than 14 or like that, you can do an anterior osteotomy to correct it. Otherwise, it will fail again. This is the posterolateral corner. You can reconstruct the posterolateral corner by Laprade method or Larsen method, or you have to adjust the, if there is medial injury, MCL reconstruction you have to do. So in conclusion, revisional ACL reconstruction results in inferior outcomes than the primary ACL reconstruction. Challenging procedure requiring multiple technical consideration. Careful preoperative evaluation and planning is required. Sophisticated surgery, including individualized graft selection, anatomical tunnel placement, and secure fixation. Individualize the procedure, 1 stage or 2 stages. Individualized rehabilitation are essential key to a successful revision ACL surgery. So my take-home message is, don't do it right the first time. If you don't do enough revision to feel comfortable, send the patient to someone who does a high volume. Do the right thing for the patient, always no exception. Be humble. And never forget that it is not in second primary surgery. Thank you very much. Thank you for your patience.
Thank you, Iqbal. Thank you for the very important presentation. These days, we are having more arthroscopic surgeons, and we are having more arthroscopic surgery. So now we will be needing more and more revision surgeries. That's obvious. Thank you, Iqbal. The next speaker is a very important person, IPS Oberoi. He is from India. He's a renowned knee and hip replacement surgeon, and also an arthroscopic surgeon from India. He's from he works in the Artemis Hospital in Boscon. Dr. IPS Oberoi, see your floor. Are you there? Dr. Oberoi.
Sir, he is absent.
Hello. Sir, this 2% from India is absent, sir.
Okay, okay. So we go over to the next speaker.
Sir.
Yes, we go over to the next speaker. The next speaker is Dr. G.M. Jahangir Hussain from Nittor. He's talking on arthroscopic Bankart lesion, a video demonstration. Dr. Jahangir Hussain, it's your floor.
Assalamu alaikum, sir. I am audible and visible?
Yes, yes, you're audible, you're visible.
Respected Chairperson, Assalamu alaikum and very good evening, and dear audience from home and abroad. Welcome to the virtual Boscon 2021. I am privileged to be a part of this Boscon and as well as a part of this session. Mostly it is arthroscopic session. I am presenting now the arthroscopic Bankard repair. It is a new one for our newer arthroscopic surgeon, but who are doing already a shoulder arthroscopy. It is very much known and basic to them. So I am very much eagerly to introduce this procedure to our younger orthopedic surgeon. It is just video presentation, not by the theoretical lecture. You can see I am Dr. G.M. Jahangir Hussain, working in NITOR, Dhaka, and welcome to you this arthroscopic Bankard repair, which is I going to present. Before going to the arthroscopic Bankard repair, there is some sort of work which should be done before, like evaluation of the lesion of the joint and release of tissue from the glenoid rim and neck, which are distorted due to the recurrent anterior shoulder dislocation, glenoid preparation, and the anchor insertion. You can see this is the shoulder basic anatomy from the posterior portal. You will initially see that is subscapularis tendon, and you can see this is the anterior glenoid rim. That is lack of, detachment of the labrum. There is no labrum here, and also you can see there is a anterior glenoid bone loss due to the recurrent anterior shoulder dislocation, and which is a common occurring about in case of recurrent dislocation. It is about 70 to 80% bony Bankard lesion. In case you can see that is intact posterior labrum, which is a bumper-like effect which causes to prevent the posterior dislocation. But in this condition, there is deficit of anterior lesion. You can see that is posterior superior labrum, also the bicep tendon which exists from the joint behind anterior to the supraspinatus muscle and anterior to the subscapular. You see, this is this supraspinatus muscle which is attached to the articular surface of the humeral head. And in this situation, you use the bare area, which is the muscle above, which is the infraspinatus and the teres minor. In this situation, you can see there is a Hill-Sachs lesion which is due to a recurrent of anterior shoulder dislocation. And for the initial of repair, we can go through the release of soft tissue from the anterior glenoid and labral tissue and thick fibrous tissue by the shaver blade, as well as we can release the soft tissue and thick fibrous tissue for repair of the labrocapsular compared to the glider rim by the liberator knife, and as well as to liberate the tissue as well from proximal to remove, to pull it from distal to proximal, as well as from medial to lateral, to create a adequate bump or repair to the anterior glenoid rim. And in this situation, we go up to the lower part of the neck of the glenoid and up to the subscapularis muscle. And then we sometimes use the radio frequency ablator. You can see here that it causes thick fibrous tissue release purpose, as well as when there is a bleeding to coagulate the bleeding point and to cut the tissue. Sorry, I am audible, sir? And use RASC to decrease the bleeding surface for the healing of labral tissue. There is adequate release of labrocapsular tissue from the anterior glenoid rim for repair of the anterior glenoid rim. You can see first stage of insertion, that is dealing, is come to dealing with the anterior glenoid rim to insert the point. Next, it comes to the external view of the repair, that is insertion of the anchor. It is always biodegradable anchor. Initial my surgery, I used the titanium anchor. Now I do the biodegradable anchor. It is about 2.7 millimeter in dia, and with this, that is 2 suture threads connecting to the bio anchor, which is escaped through the outer portal. I insert this is anchor suture through the anterior inferior portal of this. And next step come to is the tissue penetration. Sometimes I hook suture hook to penetrate penetrate the tissue. Sometimes you shuttle for the penetration of the tissue. In the external view, you can see there is a knot tying. There is several types of knot, but I personally use a Duncan variety knot, which is the non-locking sliding knot with several hairs of the hashing the several half hisses to create a knot. And in this procedure, I initially create a knot, external knot, and this knot I creating traction suture, pulling the traction suture, I push it to the interior of the joint, and then at the end when this knot come to the anchor suture, I insert the knot pusher to tighten the knot to the anchor. You can see in the inside of the joint now, and this is this inside of the joint. I push the knot with the knot pusher to come to the anchor where I insert it. And there is adequate labrocapsular tissue which are liberated by liberator, ablator, as well as shaver, and come to I not put it in the tie them not to the anterior glenoid. I put this first anchor at the 5. I think it is clock position. It is 5:30 clock position, and it is 6 o'clock position. It is 5:30 clock position. I put the suture penetrator at the 6 o'clock, and I pull the tissue proximally, that is distal to proximal, and that is medial to lateral towards the anchor. Towards the anchor where I inserted, and after 2 to 3 half pieces, I tighten, as well as reverse knot tying. I tighten the knot, and then come to the next step, cutting of the my knot. So this is the first knot I given at 5:30, then at 4:30, then at the 3:30 o'clock position. Usually anterior banker differ, it requires 3 anchor usually. And this is my video presentation, and thanks for attention and hearing this. Thank you, sir.
Nice talk, Jahangir.
Thank you, Dada. Welcome.
Kavi sir, please unmute.
Yes.
Thank you, Dr. Jahangir. Thank you for the wonderful video presentation. There was one more speaker from India, Shumadeep Dotto. Is he present? So I understand he is not present.
Somadip, are you there? I think he was there. Some network issue is there.
Okay, we can wait 1 or 2 minutes to see if he can come online. Somadip?
Yes, sir. Probably he's present.
Okay, that's good. We are eagerly waiting for you. Somadip is from Kolkata, India also. And he is, I think, working in Narayan Multi-Specialty Hospital. That is what is hospital. Somadip, yes, I can see him, Somadip. But he's still mute. Dr. Somadip.
We can. I think some network issue is there.
Probably.
He's muted. He's still muted.
Yes, Shomodeep here, sir.
Yes.
Okay, thank you. We can see you, Shomodeep.
Yes, I'm here. Okay. Can you hear me?
Yeah.
Yes, Somadip, yes.
Okay. Should I start?
Yes, you can start, please.
Okay. Thank you. Thank you very much, the Bangladesh Orthopedic Society, for giving me this opportunity to present here. Last time I was there physically, so I'll miss you, and hopefully next year we'll join you. So, so straight away I'll go into the presentation. So this is suppose this is an MRI report presented in my WhatsApp to by a friend or colleague. So which says only that ACL tear. Now the big question comes.
Please share the screen.
Okay, just a minute. Can you see my screen?
Not yet.
No, not yet.
Okay,
try again.
Okay. Now is it okay? Okay.
It's okay now. It's okay now.
Okay, thank you. So this is an report, MRI report, which you often get from our friend colleagues, that the patient has a ACL TR, come to my place and do an ACL reconstruction. So for the next couple of minutes, I will go through the details that if these all ACL TR need reconstruction. So first of all, we have to understand what is the problem a ACL TR patient will have. The primary is the instability. What is an instability? It's a propping sensation in the knee or giving away with the weight bearing. So we all know ACL is not a radiological or MRI finding. It's basically a clinical finding. MRI is only to prove our diagnosis and to find out associated meniscal injury, and from litigation issues also, and for patient confidence. But basically, MRI is ACL TR is not an MRI diagnosis, it's a clinical diagnosis. So what is the treatment goal of our ACL surgery or ACL reconstruction? The primary goal is restore stability, at the same time protect the meniscus, also protect the articular cartilage, and return to sports in a sports person. So I will go for next couple of minutes for a different scenario of patients, and we will discuss those patient needs an ACL surgery or not. Suppose a 14-year-old football player has an injury who has a positive clinically lash band, positive pivot shift, has gone for a rehab for 4 to 6 weeks, but not responding. So these patients should go for an ACL reconstruction surgery because he has to protect his meniscus for further injury. Also, at the same time, if he has any chance to go to the sports, ACL reconstruction is only the answer. But it's a different ACL reconstruction than a conventional one. It should be a fascial separating or a transfascial, depending on the Tanner or Reiser stage. So next, come to another patient, another housewife, female, 36 years old. She had a twisting injury while in a beach vacation. She had no instability, but she has gone to somewhere and done an MRI, and MRI comes out to be an ACL TR. So do this patient need an ACL reconstruction? Because she doesn't need a pivotal activity for her lifetime. So only ACL TR should not be addressed in this patient. If at all a meniscal TR is associated or a meniscal symptom is there, then she should go for a meniscal surgery and associated ACL surgery. But only ACL TR in this profile of patients should not be addressed. Another patient, a 95 kg female heavyweight, a staircase injury during shopping mall. She had an occasional instability. MRI shows a complete ACL TR. So what is the plan of treatment? Because in these patients, the female obese patient, graft is a big problem and high chance of failure is another problem. So ideal plan of management should be weight reduction, strengthening her knees, and then if she has any instability, then she can go for an ACL reconstruction. At the same time, associated bony surgeries may be done. So another spectrum of patient is a genu varum deformity with a ACL reconstruction. These patients, because he has an angular deformity in the knee, any ACL reconstruction only will not suffice until and unless we correct the angular deformity there. So if at all we have to go for ACL reconstruction, we first correct the angulation, we have to correct by an ITBL osteotomy or distal femoral osteotomy, whichever suits he or she, and ACL reconstruction at the same time, or we can go for a slope correcting surgery to prevent the further instability in this spectrum of patients. Same thing happens to an genu valgum deformity and genu recurvatum deformity. Another spectrum, a 36-year-old male following a road traffic accident. He has the MRI done. MRI shows a ACL tear, but a Hoffa fracture is there. The primary importance is to be given to the bony injury. So first, the bony fragment should be fixed anatomically as it's the intraarticular fracture. Hoffa should be fixed with a standard approach with the canceller screws or plate, whichever you feel is perfect. Then he has to gain his range of motion, and if after that if he has an instability further, then we can go for an ACL reconstruction, not as a primary management. Another spectrum is an ACL tear in an old age. We get a lot of patients in their 60s, 70s, MRI done anywhere has shown the ACL tear. So what should be done? These patients, ACL reconstruction is at all not needed. The primary treatment should be the treatment of osteoarthritis. Depending upon his grade, he has to go for an physical therapy or whatever mode of therapy suits him. But ACL deficiency is not the major problem in these patients. Another spectrum, 32 years, office executive, recreational sports injury. He had a ACL with a middle meniscus tear. These patients should be operated because meniscus, to protect the meniscus, we have to go prevent the further damage to the meniscus only by stabilizing his knee by ACL reconstruction. So ACL reconstruction associated with meniscal procedure is the ideal answer for those patients. So there is also a paper that ACL reconstruction is not only for the ACL, it is beneficial to the meniscal also. There are repeated papers are coming that ACL reconstruction is also beneficial to the meniscal to prevent secondary meniscal damage. Another spectrum, 21-year professional footballer who has an ACL tear, he needs constant pivoting. So ACL reconstruction is a must for this patient. But we have to again counsel this patient because there is not 100% chance of a professional player to go back, return to the same level of sports after ACL injury. There is chances of 50 to 60% that he may not go to that level of sports that he has done pre-injury. So this patient should need a proper counseling that ACL reconstruction doesn't mean that he will go back to that same level of sports after reconstruction, but to go to the maximum level of maximum sports life to him is ACL reconstruction is the answer. Another question is why we should do ACL reconstruction. There are different papers, acute ACL reconstruction versus the ACL reconstruction in a 6 weeks or 3 months. So ideally still nowadays there are papers that says that if you do it acutely, there is more chance of synovitis, stiffness and that. So most people across the globe prefer to go for a 4 to 6 weeks gap after the injury to get the knee quiet and then go for ACL reconstruction. So our take-home message is that, so primary aim of ACL reconstruction is to treat instability, not to treat MRI also again. And treatment depends on the activity level of the patient. If it is a highly young active patient, needs constant pivoting, he can go for ACL reconstruction. In a young active patient, yes, but there are some spectrum. We all know the copers and non-copers. There are a lot of sportsmen in this subcontinent. We see that these patients, sportsmen had an ACL injury. They didn't go for surgery. Still, they have done their sports life quite successfully. So the question of copers and non-copers you have to keep in mind, you have to discuss if you go for the sports person surgery, that the level of sports he has done previously before the injury, he may fail, may not go back to that level of sports. after the surgery. So thank you all. Thank you, Bangladesh Orthopedics Association, for giving me this opportunity. Thank you.
Thank you, Dr. Somaya Deep. That was a very interesting paper. Yes, I would say try to assess the amount of instability before you go for ACL reconstruction.
Obviously.
And on the only way that you can assess the amount of instability is number one, the duration. Give the patient some time, 4 weeks, 6 weeks. Give him quadriceps exercise. Give him a proper physiotherapist and reassess him after 4 weeks, 6 weeks. Then if you are satisfied that he has insignificant instability, then you go for surgery. If the patient is happy after 4 weeks, I have every reason to be happy myself for not doing surgery.
Yes.
Thank you.
Thank you.
Do we have time for questions and answers?
No, sir.
We are very late.
Sir, you conclude the session, please. Sir.
Okay, so this arthroscopic session was very interesting, and I have nothing more to add. I hand over the session to you, Chairman of the organizing committee. Thank you.
Thank
you, everyone. Greeting from India.
Okay, thank you. Thank you, everyone, especially Professor Iqbal Kabir sir for conduction of these sessions.
Rajiv, Shamya, bye.
Okay, thank you. Because we are running short of time, we want to go for the next session. I want to request Dr. Khondokar Abdul Awal Rizvi sir. Professor Khondokar Abdul Awal Rizvi sir. Please start your session. Probably Dr. Jamal Ashraf is not.
Okay, thank you, Dr. Shohit. Actually, I think we are quite late. We are late by more than 1.5 hours. Anyway, this is a great opportunity to start the session number 5, scientific session number 5. We have a lot of papers in this session. Do you have any other chairpersons joining with me, Shohit? Or I am alone? Is there anybody also with me connected from outside?
You alone is present here. We are not able to communicate with Jamal Ashraf.
Okay, thank you. So we have about 9 papers in this session. Okay, the first paper is effectiveness of single dose regimen of intraarticular versus intravenous tranexamic acid in primary total knee arthroplasty. It is a prospective randomized control study. The paper is going to be presented by Dr. Nisar Ahmed Shah from India. Dr. Nisar Ahmed Shah, are you connected with us?
Yeah, Assalamu alaikum, sir.
Walaikum assalam. Welcome, Dr. Nisar. So are you ready to share your slides?
Yes, sir.
Please continue.
Hello, sir. Am I audible, sir?
Yeah, right. Quite audible. Share your slide, please.
Dr. Nisar.
Sir, are sir slides visible?
You have to stop your share first, open your presentation, then share screen.
Yeah.
Sir, is my presentation visible, sir?
Yeah, it's visible now.
Okay. Myself, Dr. Nisar, I am from Kashmir, and I congratulate Boscon for organizing such a wonderful scientific session. Thank you very much for giving me a chance to present my research paper, which was to study the effectiveness of single-dose regime of intraarticular versus intravenous tranexamic acid in primary total knee replacement surgeries. It was a prospective randomized controlled trial done at Ganga Hospital, Coimbatore, India. As we all are well known with the total replacement surgeries, and thereby everyone has the concern of blood loss. The literature says that 1/3 of the patients require blood transfusion and are at the risk of having transfusion-related complications. Various methods are being used to reduce the blood loss, and tranexamic acid is one of the most commonly used drug, which is an antifibrinolytic drug for reducing the blood loss. Normally, there is not any associated risk associated with the tranexamic acid use in surgeries, but when we give the intravenous tranexamic acid, there is an uncertain risk of venous thromboembolism from IV administration, especially in the patients who are at risk of developing DVT. So now the trend is in favor of administering the intra-articular tranexamic acid in total knee replacement surgeries, which is a simple route of administration and directly targets the site of the bleeding with minimal systemic absorption, thereby reducing the post-operative bleeding. Although there is a consensus regarding the efficacy of the tranexamic acid in reducing the blood loss, but the ideal route of administration of tranexamic acid is still debated. Aim and objective of the study is to study the efficacy of the intravenous and intra-articular administration of tranexamic acid in terms of blood loss and transfusion rate in patients undergoing TKR, and to assess any complication rate, if any. The study was a prospective randomized controlled trial done in 150 patients at Ganga Hospital. Patients were screened before surgery on OPD basis, thoroughly evaluated with routine investigation as well as coagulation profile. All those patients were included who were having primary osteoarthritis and underwent unilateral primary total knee replacement surgeries were included in my study. I have excluded all those patients having pathology other than primary osteoarthritis, previous knee surgeries, previous revision surgeries, patients who have underlying coagulopathy, patients receiving anticoagulation therapy, and patients having history of thromboembolic and cardiovascular disease. Informed consent was taken from every patient, and patients were randomized into two groups, IV group and intra-articular group. Surgical procedure was it was done by a single surgeon under spinal or epidural anesthesia. Pneumatic tourniquet was applied. Approach was standard middle parapatellar approach. We have used the PS knee as PFC sigma from Johnson & Johnson in every patient. Tourniquet was deflated and hemostasis was achieved immediately after the implantation of the prosthesis. It was followed by the closure of the quadriceps and reticulum. Followed by the, we have used the subcutaneous suction drain, which was kept clamped for 1 hour after the surgery. Tranexamic acid administration was in case of intravenous group, we have given 15 milligram per kg with 100 ml NS at the time of giving anesthesia as slow IV infusion. And in intra-articular group, we have given 1.5 grams of tranexamic acid in 15 ml NS solution injected into the joint after the closure of the reticulum and quadriceps tendon, but before the subcutaneous closure. In the post-operative rehab was done as per the protocol of the institution. Aspirin was given as 150 milligram for 30 days after the surgery. We have used pneumatic compression devices during the hospital stay in every patient. We have investigations that were done was HB and hematocrit, which was done on immediate post-operative day, on the first day and on the 4th day of hospital stay. Patients were usually discharged on the 5th day. Doppler ultrasound was done in patients who developed symptomatic swelling of the cough or symptomatic features of DVT, either in the 4 weeks, 12 weeks, or finally at 6 months follow-up. Outcome assessment was based in terms of measurement of hemoglobin and hematocrit levels, volume of blood loss, and drain output, and transfusion rates. Complications, if any, were measured in terms of frequency of symptomatic DVT and pulmonary embolism, wound healing, and periprosthetic joint infection. We have used independent t-test analysis as a statistical tool in our study. In the preoperative demographics, we had mean age of 64 years in intra-articular group and 63.7 years in intravenous group. BMI was 29.5 in intra-articular group and 31.7 in case of intravenous groups. Mean preoperative HP was 12.9 in intra-articular group and 12.4 in intravenous group. And mean total blood volume was 3.86 liters in case of intra-articular group and 3.94 liters in case of intravenous groups. In the results, in case of intra-articular group, we have the mean post-operative HB of 10.6. In case of intravenous group, it was 9.9. This mean post-op hemoglobin was slightly higher in case of intra-articular group, which was statistically significant. HB drop in case of intra-articular group and intravenous group was 2.2 and 2.5 respectively, which was not a statistically significant difference. HB loss in case of intra-articular group was 100.2 grams, and in case of intravenous group, it was 9.4 grams, 94 grams, which again was not statistically significant difference in between the two groups. Total blood loss in case of intra-articular group was 693 ml, and in case of intravenous group, it was 753 ml, which was not statistically significant in between the two groups. Brain output in the two groups was 45 ml in case of intra-articular group and 47.8 ml in case of intravenous group, which is not a statistically significant difference. Number of blood transfusion in case of intra-articular group, only one patient received the blood transfusion, and in case of intravenous group, only 2 patients received the blood transfusion. Complications, we have no symptomatic DVT or periprosthetic joint infection in the 6 months follow-up, but electrolyte imbalance was in 2 patients in IV group, chest pain and abnormal ECG, 1 patient in intra-articular group, and 2 patients in case of intravenous group. Superficial infection, 2 patients in intra-articular group and 1 patient in intravenous group. And ecchymosis, 1 patient in the intra-articular group and 2 patients in the intravenous group. Superficial infection healed within 1 or 2 weeks of dressings and oral antibiotics. So in summary, we have the findings that intra-articular administration of tranexamic acid has shown comparable efficacy and safety profile to routinely given intravenous tranexamic acid. Intra-articular administration has an added advantage that it targets bleeding locally with potentially reduced serum levels when compared to the IV dosing regimes. Thereby can be a safe regime even in patients with risk of thromboembolism. Due to reduced systemic absorption of intra-articular tranexamic acid, it can be adopted as an attractive route of administration by the surgeons who are hesitant in using IV tranexamic acid, especially in patients at the risk of thromboembolism. So the surgeon may select one of the methods according to the clinical status of the patient. Thank you very much. I thank the Boscon 2021 organizing committee who have given me a chance to speak on this topic. And this is an open invitation from me to everyone to visit to Kashmir once in their lifetime. Thank you, sir.
Well, thank you, Dr. Nisar Ahmed Shah, for your beautiful presentations, especially presenting a research work which is truly a randomized control trial. This gives us confidence in using this TXA. TXA is being used by many centers in the world, but we still are hesitant in using TXA because of the fear of this deep vein thrombosis. But intra-articular use of TXA definitely is more beneficial than IV.
Yes, sir.
Thank you. And thank you also for inviting us to visit your beautiful place. Okay.
This is an open invitation, sir. Please, sir.
Okay, it's a pleasure. Thank you very much. We were also invited to visit Dhaka when the COVID situation is better.
Inshallah, sir. Next session, I'll be there, inshallah.
Okay, thank you. Now, our next presenter is Dr. Arun Khannan from India. Arun Khannan, are you there?
Sir, absent.
Arun Khannan from India.
Sir, absent,
He is absent. Okay, so then our next presenter is Dr. Muhammad Sirajul Salehin from Bangladesh. Salehin is going to present a paper on surgery for pelvic bone malignancy.
Thank you, sir. Am I audible?
Yes, clear.
And my screen is sharing or not?
Yes, they are sharing. Fine, everything is fine. Continue.
Okay. Honorable Chairperson of this session, my teacher, Professor Khondagal Abdullah Rizvi sir, and learned audience from home and abroad. I am Dr. Mohammad Shiajus Salihin, working as a assistant professor in the Department of Ortho-Oncology in our National Institute of Cancer Research and Hospital. And I am very much grateful to the team of Bangladesh Orthopedic Society giving me the opportunity to present my paper. And my topic is surgery for pelvic bone malignancy. The pelvic tumors have larger disease volume and has a higher stages. It is surgically challenging and there are limited reconstruction options. So what are the common pelvic tumors? The common pelvic malignant tumors are chondrosarcoma, Young sarcoma, osteogenic sarcoma, metastatic bone tumors, and chordoma. So there are various reconstructive options. These are pseudoarthrosis, arthrodesis, pelvic prosthesis, allograft or allograft prosthetic composite. So why a special mention? Because when we're dealing the pelvic bone malignancy, it is very much challenging because it has a high rate of morbidity and the prognosis is not so good. So what are the challenges? The first challenge is it is difficult to diagnose because sometimes we miss the diagnosis in plain X-ray. So MRI is mandatory to see for the proper diagnosis of the pelvic malignancy. And the next step of challenge is evaluation. Take proper history. Sometimes patients come with us low back pain or pain in the hip, and we do lumbosacral spine X-ray or MRI, and we mistake to diagnose the pelvic malignancy. And the next step is the challenge is biopsy. When we suspect that it is a case of pelvic malignancy, most of the time we write the investigation CT guided FNAC. Never do FNAC in case of bone malignancy. We have to do core needle biopsy, that is jump city bone marrow needle biopsy or incision biopsy. And biopsy must be done by the operating surgeon, because if we have the final destination is the surgery, so the biopsy should be in the final incision mark. And the next step of the challenge is the treatment. So when we're dealing the pelvic bone malignancy, multidisciplinary team approach is essential, because for proper delineation of the disease, we need good radiologist and histopathologist and medical oncologist, radiation oncologist, and the orthopedic oncosurgeon, and also surgical oncologist also essential. So for doing the surgery, a good planning is essential and good imaging is essential, and good OT team is essential, because in this surgery, there is a loss of lots of blood. So we need hypotensive anesthesia. Good anesthesiology is essential, and when we deal the pelvic bone malignancy, and vascular surgeon is essential. And the next step is the resection. Always we have to do R0 resection. So resection of the tumor without entering the tumor. And sometimes marginal resection is essential when the tumor is close to the neurovascular structure. And the next step of the challenge is reconstruction. So what is hemipelvictomy? Hemipelvictomy is a rare procedure that is used primarily in the management of the primary malignant tumors, but also in the rare instances in the management of the metastatic tumor, severe trauma and infection. Two types of hemipelvictomy usually performed: internal hemipelvictomy and external hemipelvictomy. So in internal hemipelvictomy, we usually remove the tumor without entering the lesion. That is R0 resection. It always maintain the reasonable function and always try to preserve 2 or 3 structures. That is lumbosacral plexus, hip joints, and femoral neurovascular bundle. So internal hemipelvictomy consists of a resection of the bone segment and compromised tissue of the pelvic girdle and preserving the femoral vascular nervous bundle and the sciatic nerve. And in this way, making it possible to preserve the lower limb of the patient. So there are 4 types of internal hemipelvictomy usually performed. And type 1 is the resection of the ilium, which may or may not include the gluteal muscles. And type 2 is the periacetabular resection, which may or may not include the hip joint. And type 3 is the resection of the ischium and pubis. And type 4 is the resection of the whole hemipelvis. And this is the approach when we perform the internal hemipelvictomy. And this is the utilitarian extensile approach. It gives good exposure, and that is a complication of flap necrosis in the superficial teeth. So this is the preoperative incision mark, and these are perioperative images. And after closure of the wound, this is the T-shaped utilitarian approach. So surgery, the reconstruction is customized for each patient. It depends upon the age, functional demand, and life expectancy in case of metastatic disease. The type 1 and type 3 internal hemipelvictomy, there is no need of reconstruction. So reconstruction usually done in case of type 2 internal hemipelvictomy. So the options are arthrodesis, pseudoarthrosis, extracorporeal radiotherapy, allocomposite, pelvic endoprosthesis, or saddle prosthesis. So 2 types of arthrodesis usually we perform. One is iliofemoral arthrodesis, and it gives stable function, and there may be limb length discrepancy and limping gait. And ischio-femoral arthrodesis, there is no limb length discrepancy, and there is a chance of high failure rate of union and painful symphysis. Pseudoarthrosis, it is usually performed in the less functional demand patient. The hip may be unstable, floating hip may occur, and there is a less complication in this type of surgery. So in case of pelvic reconstruction, the prosthesis is one of the options, and we can use modular metal prosthesis, customized prosthesis, trabecular metal prosthesis, ice cream cone prosthesis, or ceramic component. So this is a journal. It was published in the Elsevier, and the study was performed in Indonesia, and they have done pelvic resection and several types of reconstruction in case of pelvic malignancy. And this is my series. Case 1, it is a 38 years male patient complains of pain and swelling over the right groin region for 6 months and unable to walk and sit due to pain. And pain was gradually progressive in nature and no history of trauma or infection in recent past. So it was a diagnosed case of chondrosarcoma in the ilium with the gluteal region. And this is the X-ray finding, and this is the MRI finding. And this is the perioperative image. We have given the utilitarian extensile T approach. The incision start from the pubic tubercle and goes to the back over the ilium and in the gluteal furrow. And this is the perioperative image and reconstruction of the pelvis. And this is the specimen. And this is the post-operative images. I have no CM in my institute, and fortunately the ISTO is well introduced, and there's a sacroacetabular fixation was done, and third post-operative patient is stand in his own foot, and the 14th post-operative day after removal of the stitch, patient is walking with walker. And this is another case, 45 years female presented with pain and swelling in the left groin after receiving 6-cycle CT and RT. And she was diagnosed as a case of chondrosarcoma, which was not responsive to CT and RT. I also mentioned that chondrosarcoma is totally chemo-resistant tumor. Surgery is the main option, but unfortunately patient got 6-cycle CT and RT. So we have done level 2 and level 3 internal hemipelvictomy. And this is the X-ray finding, chondrosarcoma in the periacetabular region, and this is the MRI, and also the pubic rami chondrosarcoma. And we have done level 2, level 3 internal hemipelvictomy. These are paraoperative images. These are femoral nerves, vessels, iliac vessels and nerves, and these are femoral head, and these are specimen. And we have done level 2, level 3 internal hemipelvictomy with mesh plastic, and these are pseudoarthrosis performed in the left hip region. So, and in the third case, 12 years old female presented with osteosarcoma of the right hip bone, and it is chemosensitive tumor. So patient received 4-cycle neoadjuvant chemotherapy, and level 1, level 2 internal hemipelvictomy was done, and reconstruction by lumbosacral with femoral arthrodesis by fibula. And this is the osteosarcoma in the right hip region with the periacetabular region, and this is the MRI finding. This is a large tumor. So we have done this paraoperative X-ray, level 1, level 2 internal hemipelvictomy, and this is the femoral head and the fibula, and fixed with the lumbar region. And this is specimen. And this is a post-operative X-ray fixed with the fibula with the femoral head, and patient is sit on his bed in the fourth post-operative day. And this is another case, 35 years old male present with swelling in the right gluteal region, and biopsy reveals chondrosarcoma. So surgery is mandatory. There is no scope of chemotherapy or radiotherapy. And we have done level 1 internal hemipelvictomy where no reconstruction of the pelvis is needed. And this is the X-ray. This is the MRI finding, and this is a CT scan of the pelvis. And this is a paraoperative X-ray, paraoperative images. We have done level 1 internal hemipelvictomy, and planning is done by giving K-wire from inside to outside, and we mark preoperative planning by MRI and paraoperative planning by K-wire marking. And we're cutting this hemipelvis, and this is the 14th post-operative day. Patient sit on his foot, and patient is walking with a single stick. So the most common complication after internal hemipelvictomy is the wound infection and flap necrosis. So the risk of internal hemipelvictomy include there may be leg length discrepancy, there may be flail hip or floating hip, or there may be hip instability. So our future direction is we must have better imaging, and we must have better planning. And in our Western country, they always use navigation. In our neighboring country, they also use navigation, and navigation-assisted surgery give easy and good surgery. And we hope for 3D printing implant for future direction. And lastly, I always remember my mentor, my professor, my teacher, Professor Iqbal Kavi. He is my inspiration to make me an ortho-onco surgeon, and he is the world-renowned pelvic ortho-onco surgeon, Professor Lee Jays. I have opportunity to work with him. And thank you very much. Thank you, Team Boscon, to give me the opportunity to present my paper. Thank you very much.
Thank you, Dr. Shirajus Salehin, for your beautiful presentation. Malignant tumors of the pelvis is a difficult situation, and management is always challenging. In our country, I know few surgeons dare to operate on malignant condition of the pelvis. Another problem is patient presenting to us in late stage, quite late, but the tumor is very big. So this is definitely a big challenge. You are doing very good. I'm quite impressed, and please keep it up, okay? And try to improve yourself further so that you really can help our deserving patients. Thank you very much. Now the next presenter is Kaji Shohidul Alam from Bangladesh. Dr. Kaji Shohidul Alam is around? If he is not here,
yes, he's
is he
here.
Okay. So his paper is evaluation of results of valgus osteotomy for treatment of varus as a result, as a consequence of septic arthritis of the hip joint. So Dr. Kaji Shohidul Alam, please present your paper.
Good evening, everyone. I'm Dr. Kaji Shohidul Alam, working as an assistant professor in Pediatric Orthopedic Department of Dhaka Medical College Hospital. And today I'm going to talk about treatment for coxa vara as a sequel of septic arthritis of hip by valgus osteotomy. So what is septic arthritis? It's a pathological microbial invasion of the joint space along with the inflammation. And this whole scenario also known by pyogenic arthritis, infective arthritis, or suppurative arthritis. The most common sequelae of septic hip noted are the coxa magna, coxa breva, coxa vara, coxa valga, leg length discrepancy, pseudoarthrosis of the neck of the femur, pathological dislocation that leads to joint instability, and stiff knee hip that occurs due to bony ankylosis. A lot of classification systems are there for the sequelae of septic arthritis of hip. Unka, Choi, Forlin, Johari, Iribrook, they all developed their own classification by their experiences. Among them, the Choi classification is most widely used. So let us have a look at it. In Choi classification, it has got 4 types. Each of them are again subdivided into 2 subtypes, A and B. In Choi type A, there is no damage to the head or physis or neck. All the hip develop normally later on and defined as 1A. Some develop coxa magna due to increased vascularity and it will be defined as 1B. In Choi type 2, there is physeal affection. If the whole physis is involved, then it will lead to coxa breva and it will be defined as type 2A. But if the medial side is involved, it will lead to coxa vara. If the lateral side is involved, it will lead to coxa valga. If the anterior or posterior portions are involved, it will lead to increased anteversion or retroversion respectively, and all of them will be defined as type 2B. In type 3, the neck is destroyed and a slip occurs. If the slip occurs with the varus or valgus or version changes or in combination, it will be defined as type 3A. Sometimes a pseudoarthrosis of the neck are developed and it will be defined as type 3B. In this scenario, the head and neck will move as a separate pieces. In Choi type 4, the head and neck are destroyed. The maximal destruction occurs in these types. If a small beak is present, which will give some sort of stability, it will be defined as 4A. If the complete destruction has occurred and the proximal femoral become rounded, it will be defined as type 4B. Before commencing any surgical treatment for the septic arthritis sequelae, remember that it has to be delayed because there is always danger of reactivation of old infection. So make sure that the old infection has subsided completely. The strength and general states of the bone need to be improved with time. The status of the proximal femur and the femoral head should be definitely determined. There is always high chance of remodeling, so don't go for surgical correction for minor deformities as they will be corrected automatically with time. The surgical treatment actually aims to stabilize the joint, to correct the deformities, to equalize the length, to retain the mobilities, and to relieve the pain if present or minimize the risk of pain developing later on. In my topic, I'm going to talk about the coxa vara deformity that developed due to surgical developed due to septic arthritis sequelae, which will be dealt by valgus osteotomy only. And this procedure actually stabilizes the joint and correct the deformities. So before I show you the cases, let me show you what actually do paraoperatively by this valgus osteotomy. In this X-ray on the right side, we can clearly see the neck shaft angle is reduced. That means it is in a coxa vara position. First, we determine where the osteotomy site will be. Usually, it is in the subtrochanteric region. Then we took a plate on the lateral side of the femur and bend it at the osteotomy site with a desired angle that will correct our coxa vara deformity. Then we do the osteotomy align the distal part of the femur with the distal part of the plate, fixed with some screws. And when you put back into its normal anatomical position, it will reveal that the whole construct developed into a normal neck-shaped angle. So the coxa vara is corrected. The proximal most screw here will also act as a trochanteric epiphysiodesis, which is very much important, because if we do not do so, the whole construct will go back into coxa vara with time because the physis is still active there. So let me show you some cases now. This is a 6-year-old child who was diagnosed as a case of septic arthritis of hip at the 4 years of age, but the patient's parents didn't take any treatment, though advised for admission, open debridement, and IV antibiotics. Now they ended up with limping gait and pain, and this is how his X-ray is showing right now. It is CHOI type 3A. So we did the valgus osteotomy with trochanteric fascial growth arrest. The limb length discrepancy is now 1.5 centimeter. Otherwise, the child is doing okay. This is my second case. 10-year-old boy came with a complaint of limping gait with shortening. He was diagnosed as a case of septic arthritis a few years back. And he was treated by open debridement of the joint, but unfortunately, no radiology were available when he came to us about that procedure. This was the X-ray that we took first time when he came to us. It is clearly now showing the coxa vara. We advised for admission and wanted to go for valgus osteotomy, but the patient's parents didn't agree and they went back home. After 1 year, they again came back with more worsening limping gait. And this is how his X-ray looks like right now. As we can clearly see, the coxa vara is now more pronounced, and the neck has started to destroy, almost looking like a pseudoarthrosis of the neck of the femur. This time they agree for the surgical procedures, and we go for valgus osteotomy with fusion of the trochanteric physis. But it didn't well as we expected during the surgery. If the postoperative X-ray clearly shows the valgus osteotomy was there, but was not that much as we expected to create. After 1 year, when he came back, we can now clearly see the head and the neck again started to develop. That means whatever valgus osteotomy that we achieved were working. But the whole construct is now again back into coxa vara. The reason of which that we believe is that we may have failed to do the trochanteric epiphysiodesis properly. That's why even though the head and neck started to develop, but the whole construct is going back into varus position. So we again admit the patient and we again redo the valgus osteotomy with the trochanteric transposition this time. His gait is now improved postoperatively and the limb length discrepancy is now about 2 centimeters. So in both cases, we can see the limb length discrepancy has not been corrected in the first operation. So we are closely observing these both cases. If it becomes unacceptable later on, then we are going to deal at that time. So what are my take-home messages? Prevention of complications and sequelae should be prioritized. For already developed sequelae, appropriate and timely intervention is the key. Long-term follow-up till skeletal maturity is important, otherwise it will again go back into a new complication later on. Aiming at a painless, stable, and mobile joint is our goal. Thank you for your listening.
Thank you, Dr. Kaji Shoidul Alam, for your beautiful presentation and also showing beautiful illustrations. Okay. In the past, we had a lot of cases, similar cases of deformities, but nowadays we see less number of cases. Only a few days back, I had a patient who had post-septic hip deformities, adduction, flexion, and internal rotation following septic arthritis, where the joints were completely ankylosed. So the patient was at the age of 15 years old. So this is the age which is critical age. You cannot go for this kind of replacement surgery so early age. But these are the cases where you can go for these corrective osteotomies, proximal femoral osteotomies, and correct the deformities and mobilize the patient. By these procedures, you can actually equalize limb length deformities, limb length deficiencies as well as So thank you very much for your beautiful work. Please keep it up. Thank you. Our next presenter is Dr. Sharon S. Patel from India. Patel, are you there? Is he present?
Probably Dr. Sarwar Salam will present now. Sarwar Ibn Salam.
So the next presenter is Dr. Sarwar Ibn Salam. He is also presenting his very interesting case, arthrogryposis multiplex congenita, the management difficulties. So this is really a difficult case, difficult condition. Most of the time we are very frustrated. So let us see how Sarwar can help us. So Sarwar Ibn Salam, please present your paper.
Sir, can you hear me, sir?
Yes, nice.
And see my presentation, sir?
Yeah.
Oh, so I should start. So thank you very much. Honorable Chairman and my respected teacher, my teachers, colleagues, and my junior colleagues throughout the whole country and someone from outside also. So today we are going to present on arthrogryposis multiplex congenita. We all know, all the orthopedic surgeons in the world, we know that there are a few things that orthopedic surgeons cannot solve properly, fully, and AMC is one of them. So let us see what are the things. We all know these things. This is a very rare congenital disorder. There are multiple joint involvement. Usually there are, I have found this thing that at least more than 2 areas and more than 3 joints, when we get this involvement or deformity, it can be called AMC. There is also muscle weakness and fibrosis. Actually, muscle mass is less there. And this is a non-progressive disease. So how this arthrogryposis came? Arthro is joint. This came from Greek. And gryposis is curve. You can see this little child. This child came from Tangai. And how much curved or crooked his limbs are. So arthrogryposis comes from there. Diagnosis, there is no direct way of diagnosing. Actually, we do it by ruling out other causes and clinical examination. Sometimes muscle biopsy are also said to be done. So there are features we have read when reading orthopedics, that doll-like limbs. Actually, the dolls of the older days had this type of, not the present days dolls are like that. So there are limbs are fusiform. There is less skin crease and less webbing and joint contracture, all we know. Epidemiology, the arthrogryposis itself is 1 part 3,000 live birth. This is so it's rare. And amyoplasia, which is more commonly known and which is the commonest of the arthrogryposis, or classical arthrogryposis, it is 1 part 10,000. This is the epidemiology. About the etiology, grossly this is said in later pregnancy when the fetus cannot properly move inside mother's womb, that may cause. And there are other things also like infection and other things. So if we go to define group of unrelated diseases with the common phenotypic characteristics of multiple congenital joint contracture is arthrogryposis multiplex congenita. And if it is the amyoplasia or the classical arthrogryposis, this is like this. There are usually internal rotation of the shoulders, extended elbows, flexed hands and wrists. Knee could be extended or flexed both. There is usually talipes, and in many cases is located at hips and knees. Amyoplasia, all 4 limbs are involved in 84% cases, lower limbs 11% and upper limbs 5% cases. Sometimes there is also scoliosis. Distal arthrogryposis is another type, which is also called Freeman-Sheldon syndrome or whistling face syndrome. The child on the right side, you can see the face, and this 11-year-old child, it seems that the child is whistling, and the whistling face syndrome comes from here. And Freeman and Sheldon, as they described it, it comes from there. This is a type of distal arthrokyphosis where mostly the feet, ankle, and legs, wrist, these areas are involved. You can see this little boy. This is so smart. Usually the arthrogyphotic child have normal or more than normal IQ. Their only problem is with walking. So you can see his feet and ankle and the hands, how much deformed are they. So what is the general management? General management, we all know this is gentle stretching and giving plasters, giving braces, plates throughout. Even just after the birth, we can start with these things. And sometimes the soft tissue release is also done. Muscle transfer, someone advocates, not always done. And there are osteotomies and there are hemiepiphysosis. These all things may be needed in different types of arthrogyposis multiplex congenital. So let us see some cases. This one, you can see the lower limbs in the right picture. The lower limbs are okay, beautiful, but upper limbs are involved, wrist, elbow on either side. So this is one of those 4% only in a myoplastia when upper limbs are involved. So this particular case would not be that much difficult to manage because the child will be able to work with some exercises, splints, plasters, and maybe surgery. This upper limbs can be workable. Look at this child. How communicating and sharp looking the child is. But look at the lower limbs. There is valgus bilateral, genovalgus, CTV bilateral, and he had also DDH. So many things we need to do for this very child. I took this picture when giving a examination in Mitor. And this 12-year-old boy, this is arthrogyposis. This is not myoplastia. Came with this thing. Fixed flexion deformity, 70 degrees on the right side and 90 degrees on the left side. Right foot equinovarus, left leg externally rotated. All these things. And at the age of 12, it is very difficult to manage all these things. And in many instances, this case I got in 2010 in Dhaka Medical College Hospital. You see all these 6 joints, both the hips are dislocated, both the knee are dislocated, and there is equinovarus deformity. So which one is to be done, or which one is to be done at first? There is a general consensus that we should start with the knee and then the club foot. So by the age of 6 months, 4 to 6 months, we should correct these 2 things. And then by the age of 1, we should go for that hip dislocation correction, so that by the age of 1, this child can have the ability to work. So we had 22 patients over the last 12 years in DMCH and in some other hospitals, and age was 12 months to 2 months to 12 years. Actually, we had few more patients, more older patients, in fact. And the treatment continued with stretching plasters, braces, surgery, hip, knee, foot surgeries, and hemiepiphysosis. And this is that child I said came from Tangail. I convinced them that with series of plasters, after exercises, I sent them for exercises. They came back after exercise. And this is the second set of spica done. And you can see the flexed, abducted, externally rotated hip was coming in near normal. But after 2 spicas like that, the patient didn't come anymore. So this is one of the older child, 15, 16. You can see her knee had restricted flexion, but she was able to do with the knee. There is no dislocation. But please look at the ankle and foot. She was just walking on the dorsum of her foot. And the mother came at this age that she needs some correction. So we didn't do much of soft tissue release. We did some tendinochilus lengthening, of course, but we went for this dorsolateral wedge osteotomy of foot. And you can see so much of correction we had to do here, and the foot doesn't look good here, but you can see the girl is standing plantigrade, and before the surgery she was standing and walking like that, and she now her walking is not normal yet because she still have some deformities. She cannot dorsiflex the ankle beyond 10 degrees. So, but she is at least plantigrade, and they were happy. So this is one of the cases that I could follow up for long and treat this child for long period. In 2009, I found we received that child at the age of 4 months, and you can see there was knee flexion, equinus of both ankle and wrist flexion, and in this right hand there was end-bearing deformity. Distal part of the fingers were not present. So we went with serial castings and serial plasters. She had 30 degree of knee fixed flexion deformity. Equinus of both ankle was 45 degree and both foot adduction was 30 degrees. So we went for stretching plasters for the knee and posteromedial, and after stretching plaster for ankle, we went for posteromedial release, and that was a good correction. So knee was not fully corrected with stretching, so we had to do hamstring lengthening and posterior capsulotomy of knee, and we did posterior capsulotomy. It was somewhat corrected by the age of 1, but the baby again came back at the age of 3. He could not walk, and knee again came back to 35 degree of fixed flexion deformity. So this time we went for, this is at the age of 4 months, and this is at the age of 3+ years. And this time we went for distal femoral recurvatum osteotomy. You can see this much recurvatum we have done, and we put plasters. So correction was not full, but at least 10 degrees of flexion was still there in knee. Ankle was somewhat well corrected. So after this surgery, she could walk direct, and let's see, yeah, and she could walk. The baby looks happy. She falls and can stand and walk again. Actually, those will win in life when they fall and get up and start walking. So if we go to discuss the paper we have just presented here, children with arthrogryposis have a good IQ. I said good or above average IQ. Treatment is focused on obtaining maximal function, maximal correction by the age of 1. And in Bangladesh, we do not go to get that chance always. Some contracture may seem to worsen with age, but no new joint usually are involved. And 25% of the affected patients are normally non-ambulatory. So an early program of passive stretching exercises for each contracted joint with serial printing and plasters is essential, and this will help the child to have a better life. So today's take-home message for this AMC will be, AMC is incurable. We cannot cure AMC, but we can improve the situation. And treatment is focused on 2 things mainly: independent ambulation and independent function of extremities for activities of daily living. And early management ensures the baby a better life. So thank you very much. And I conclude with the picture, this picture. This is, if you remember, this was one of the last pictures of Sumirul Islam Babu, and it was drawn by someone else. So our younger brother, a great human being, Sumirul, died about a year back, and in his loving memory, I conclude today. Thank you very much.
Thank you. Your subject was a very difficult subject. This treatment of this arthrogryposis requires a lot of patience, lot of understanding of these conditions, and it takes very long treatment. And treatment should be started as early as possible, following the birth of the baby. And there are some deformities which can be corrected by serial plaster if you start early treatment. If you wait, then things knee joints, dislocation, anterior dislocation of the knee joint. So you can correct this deformity if you start the treatment very early by even by serial plaster. Okay, so I'm very happy that you have a lot of cases and you are quite experienced now. Okay, and there are some other pediatric surgeons also helping our difficult pediatric conditions. Okay, this is very encouraging. Thank you again for your work in this field. Okay, now our next presenter is Junaid Hakim from Bangladesh. Junaid, your paper is Management of Complex Diabetic Foot Ulcer by External Fixator. Our experience by Bardem in Bardem General Hospital. So, Dr. Junaid Hakim.
Am I audible?
Yes, nice. Yes,
Okay.
you're quite audible.
Thank you, sir. Thank you, Bangladesh Orthopedic Society, for giving me the opportunity to present my case. I now like to share. Okay. Okay. So I am working as an assistant professor in the Department of Orthopedics and Traumatology in the Bardem General Hospital and Ibrahim Medical College. And my topics will be management of complex diabetic foot ulcer by external fixator. I will be sharing our experience in Bardem General Hospital. This is the ulceration, infection, and gangrene and amputation. Amputation associated with chronic complication of diabetes are a major source of morbidity and leading cause of hospital admission. Foot ulcers are a common, serious, and costly complication of diabetes, preceding 84% of lower extremity amputation in diabetic patients and increasing the risk of death by 2.4% fold of over diabetic patient without ulcers. The lifetime risk of a person with diabetes developing a foot ulcer is 25%, and in every 30 seconds, a lower limb is lost somewhere in the world as a consequence of diabetes. This is a prospective continuous case series. We had dealt 9 cases. The study time was 2019 to 2020. We classified all the cases following the Wagner classification. All were graded 2. All the patient had ulcer on or around the ankle joint, making overlying foot and joint capsule exposed exterior. Foot ulcer were assigned as complex as all the patients were associated with systemic toxicity and septicemia. There, the 9 patients that you said, 3 patients are female and 6 were male. All the patient had age was in between 50 to 70 years, and the mean age was 61.5 years. All patients had one or more complication of diabetes like chronic renal failure, ischemic heart disease, hypertension, and cardiovascular disease. Except ankle joint and duplex scan of limb were done in all cases, along with other necessary relevant investigation. Locally made external uniaxial external fixator was applied. There you can see the joint capsule and ankle are not opened. 2 or 3 Sanjay pin was introduced into the shaft of tibia, 1 pin in the calcaneum, and 2 smaller pins at the first metatarsal. Pins were connected by 2 L-shaped rods and upon one another. These are the external fixator which were commonly used in where we were in our period of residency. So you can see, and these were very popular among us. So when our colleagues in Bardem, especially surgery and other colleges, and we found this kind of ulcers around the joint, and we found it quite difficult to stable the ankle. So we just thought that why not we use this kind of external fixator to keep the stability of the ankle joint. That is the reason that we started applying this this external fixator, especially ulcers around over the ankle joint. So vacuum assisted closure was applied in 3 cases after giving the stability of the ankle joint by this external fixator. Changes of vac and dressing was done according to the need, and except the ankle done routinely in all cases. I have already mentioned that all patients were advised for assisted walking with X-fix external fixator and normal walking after removal of external fixator. Now I would like to show some of the cases. This is the one case that has been referred by our surgical colleague. There you can see the ulcer in the medial aspect. This one has been, this case again has been referred from my surgical colleague. There after applying the external fixator, he has done a skin grafting. And this one is, you can see the ulcer is granulating. And this one is done by the last case was, this case was referred by our plastic surgery colleague. They just put a free flap after fixing the joint with this external fixator. So improvement in quality of life as ambulation was possible immediately after surgery with external fixator in situ. Wound coverage was possible within 10 weeks time. Average it was 8 weeks. High level of patient satisfaction as all the patient went back to the normal life, avoiding psychological and social stigma of amputation. Yes, we did have some complications. One is that in 2 patients, we had some pin track infection. In 1 patient, the arthrogenic ulceration on the contractile leg, as because this patient was in ICU. It was shifted to ICU due to some morbid conditions. So in the ICU, he just became restless and that ulceration happened. And difficulty in maintaining comfortable posture with X-fix. Yes, of course, this X-fix will not give you the comfort. And loosening of a smaller sunspin, especially in the metatarsal, it happened in 2 cases. But luckily, nothing serious. We just managed all the cases quite well. We are lucky. 20% of all the diabetic patients get admission in the hospital for foot ulcer and foot problem in their lifetime. Uncontrollable wounds caused by infection, larger size, vascular insufficiency, compromised immune status, and unstable skeletal framework require multiple operations in case of foot ulcers. Aggressive debridement of all dead or devitalized tissue and bone while sparing the healthy tissue for closure is the most important step. Leaving large wound to heal by granulation and secondary intention may take several months following a surgical debridement for a complete closure. External fixators may be used in complex diabetic foot wounds, ulcers. Those are difficult to salvage using conservative methods like casting, bracing, or traction, especially across the joints. So external fixators have an established role in treatment of trauma and osteomyelitis, as I have already mentioned. This kind of external fixators are quite familiar and also very popular during our residency time. And now still we are using this kind of external fixator in case of trauma cases. In case of soft tissue healing across the joint, external fixator gives stability of the joint and minimum motion, preventing descent or breakdown of the graft or flap. Immobilization with a cast makes it difficult to follow the wound and place pressure over the reconstruction. External fixator can be removed after wound healing without giving anesthesia as an OPD. As I have already mentioned, my surgical colleagues as well as my plastic surgery colleagues, they were referring the cases. They were actually asking me to solve the problem of applying the cast, because every time while you are doing the dressing, you have to remove the cast and the flap, especially the flap, and sometimes the graft is become difficult to manage and they just got out of the skin. So this kind of problem was happening. So we just decided to maybe why not just we put this kind of external fixator, especially while fixing the ankle joint, and they were quite happy. So in a study by Petro B. et al. Demonstrated that the application of external fixator in exposed joint decreases the wound size more effectively in 52 days as compared to the wound managed by slab support. Another study by Nayak et al. On 32 patients with complex diabetic foot wound were treated by external fixator and found quite satisfactory result. So in our study, all patients had satisfactory result with an improved quality of life. Poor compliance with external fixator was a common complaint, but it may be ignored considering the quick recovery and early embolization. Number of patients within such long period was small. Yes, of course. Need to compare. Yes, the last point is that we need to compare after these cases. with that of the applying the cast so that we could have get up the better which one is working better. This was the just is our observation that we were getting some good results using this external fixator. So in the conclusion, we can the advantage of this treatment is to decrease the mobility at wound site, approximation of wound margins, better joint stability and alignment, less hospital stay, cost effectiveness, and limb salvage, and finally better quality of life. I like to acknowledge because diabetic foot case is a multidisciplinary approach, so I like to put special thanks to my department, all the department, general surgery, plastic, especially endocrinology, cardiology, anesthesiology, nephrology, because all this patient, ICU, neurology, because all these patients were suffering a lot of diabetic and also associated complications. So these are the references that I have used. So thank you everyone for your kind and patient sharing.
Thank you, Dr. Junaid Hakim, for representation and also for taking care of the diabetic feet. These are the group of the patients that are most neglected, and sometimes they're really frustrating. All the key number of patients require amputation. This is the most unfortunate part. But this group of people require definitely much more intelligent care. And thank you. You have been treating diabetic feet, and you have shown quite a good number of cases with good result. Okay, this is really encouraging. Thank you. Our next okay. Our next presenter is Dr. O.Z.M. Dostogir. Are you there, Dostogir?
Yes, sir.
Okay, so your paper is effectiveness of proximal femoral nailing in the treatment of type 3, type 4 trochanteric fracture. Please present your paper.
Assalamu alaikum. I am Dr. O.Z.M. Dostogir, Junior Consultant, NITOR. I am presenting the topics on current concept for assessment of an injured cervical spine. We know cervical spine injury comprises 2 to 6% of adult spinal trauma cases, among which 43% considered unstable. It is critical to rule out and clear the cervical spine before evaluation of multiple injured patients. It can be achieved by both clinically and radiologically. Evidence-based cervical spine clearance protocol is required to prevent further injury and can reduce healthcare costs and unnecessary exposure to ionizing radiation. The goals of clinical evaluation is to clear cervical spine clinically and to identify patients require additional radiographic investigations. In an alert patient, this first step should be straightforward and easy. In an unconscious patient who is clinically not evaluable, the clearance relies on imaging studies only. Suspicion of a cervical spine injury must be maintained until proven otherwise. C-spine clearance is very important. On admission of a patient following a trauma, 3 clinical scenarios might be encountered. 1, an awake alert patient without symptom, an awake and symptomatic patient, and unobtunded clinically unevaluable patient. According to Nexus protocol, clearance of cervical C-spine can be in cases of the following finding: no cervical pain and tenderness, no neurologic deficit, normal alertness, no intoxication, no associated painful detracting injuries. The radiological assessment, plain film. The 3-view protocol is usually standard: anterior, posterior, lateral, and odontoid view. In cervical spine trauma, plain films are accurate enough to detect 84% of all cervical injuries. In an obscured area, oblique views of a CT is recommended before discontinuing cervical immobilization. Radiological assessment, plain film. This is the 3-view protocol is usually standard exam. And cervical spine trauma, pain accurate in 84% of cervical injury. Adding the 3-view radiograph, active flexion and extension, symptomatic and awake patient with normal plain film with sensitivity 98.9% and specificity CT 93%. They are usually ordered to exclude suspected discal ligamentous injury. The value of these views in the acute setting is debatable due to possible false negative because of muscle spasm. In comatose present, it could be dangerous. Computed tomography scan is necessary. Highly CT scan surpass radiograph in detecting cervical spine injury, especially in obtunded patient. CT evaluation helps in defining pattern, morphology, and possible mechanism of fracture. Consequently, helps to determine the appropriate treatment strategy. In high-quality CT imaging available, there is no indication of extra plane radiograph. Symptomatic patient with normal radiograph CT scan used to exclude discal ligamentous injury. The limitation of MRI due to time needed transfer to the patient to MRI suite and to obtain the evaluation and to difficulties involved in monitoring comatose patients who are ventilated. This is a typical followed canarial C-spine role. This GCS 15 and stable trauma patient where cervical spine injury is concerned. Any high risk factor which mandates radiography. If age more than 65 years, dangerous mechanism, paresthesia or extremity. If yes, then go to radiography. If no, then if it is simple rear end motor vehicle injury, sitting position emergency department, delayed onset neck pain. If yes, then able to actively rotate 45-degree laterally. If able, no radiography. If unable, then do radiography. Patient transported in ER department. This is the protocol. In stable and alert, any high risk factor, just radiography. No, then no risk factor that allows safe assessment and movement. If yes, able to rotate, or yes, then no need to any X-ray. Then if no, then 3-view X-ray and consider CD if doubtful or inappropriate limb. AWAC and asymptomatic patient, in upgraded level 1 recommendation for clearing C-spine injury, the alert asymptomatic patient without a neurologic deficit who can complete a functional range of motion, examination, and is free from other major distracting injury may safely be released from cervical spine immobilization without radiographic evaluation. This recommendation is based on class 1 medical evidence supporting a level 1 recommendation. AWAC in asymptomatic patient, mandation and discontinuing cervical spine immobilization in such a situation. High quality CT scan is mandatory in AWAC and symptomatic patient. Choice for if CT is not available, then 3-view radiograph is recommended. In obtunded unevaluable patient, in level 1 recommendation in a patient that is not clinically examination to obtain a high quality CT scan. If CT is not available, a 3-view plane radiograph is recommended. In obtunded patient who had normal CT or normal radiograph, MRI seems to appropriate evaluation based on class 2 and class 3 medical evidence studies. In such a scenario, cervical immobilization can be discontinued if MRI within 48 hours is normal. So take-home message is rapid discontinuation within 72 hours of cervical immobilization is recommended in alert asymptomatic patient without a neurological deficit who can complete a functional range of motion. Examination is free from other major distracting injury may safely be released from cervical spine immobilization without a radiological evaluation. In AWAC and symptomatic patient, a high quality CT may rule out the traumatic unstable C-spine injury. In obtunded and unevaluable patient, high quality CT scan is first recommended in addition to MRI if CT is normal. Take home message another is missed C-spine injury might have catastrophic consequence. Avoid prophylactically extended C-spine, cervical spine immobilization, especially in comatose patient. Avoid exercise and unnecessary imaging studies for fear of hidden injury. Thank you very much.
Thank you, Dr. Giri. First of all, I would like to apologize for mentioning the different topic. Actually, I thought you would be presenting effectiveness of PFN in proximal femoral fracture. So I'm sorry because I didn't know that you were presenting on cervical spine. Anyway, that you have presented a beautiful topic. This is very important for all of us. So we must know how to evaluate the status of cervical spine following any traumatic event. Okay, thank you, Dastagir. Okay, now our next presenter is Dr. Javed Jahangir. Dr. Javed Jahangir, I don't have your title with me. Most likely it is something with proximal humeral fracture. Okay.
Yes, sir.
Mention your title and then read your paper. Thank you very much.
Am I audible, sir?
Yes, yes.
Can you see my slide, sir?
Yeah, nice, beautiful.
Honorable Chairperson, distinguished faculties, and dear colleagues and the audience, I welcome you all to Boscon 2021, which is presenting in a hybrid form. This is March, the month of independence, and we are celebrating 50 years of our independence. I paid my due respect to all the martyrs and the freedom fighter. I'm going to talk about fracture dislocation of proximal humerus in young patients. So, I would like to quote a quote from R.H. Cofield, who said adequately and describe the proximal humeral fracture. Use adequate radiogram to understand the traumatic lesion. Be careful denying older patient effective treatment. Use a safe and simple surgical approach. Know the option for internal fixation. Recognize the value of prosthetic replacement. Avoid technical pitfall and thoughtfully supervise the postoperative patient care. In these 5 lines, he almost adequately described the whole of the proximal femoral fracture, humeral fracture. So about 1 to 3% of all shoulder trauma. And in young patient, this is more likely by fall from height or vehicular accident. So you all know 80 to 85% proximal humerus fracture can be treated conservatively. It's only 20% patient that needs surgery. And in this group, much or surgery is not absolute. This is relative. But in some group of patients, the surgery is almost mandatory. This is one group in which the surgery is more likely to be done. So we all know the landmark paper in 1970 by Near, who described the proximal femoral fracture in a very elaborately fashion. And extreme of this classification is we see the fracture dislocation, either in the form of anterior or posterior, in 2-part, 3-part, or 4-part. Another important criteria to describe the type 1 and type 2 fracture dislocation, anterior fracture dislocation by Robinson in 2006. He described in type 1, there is a capsular lesion which is more than, capsule is more than 2 centimeter intake, and there is a visible bleeding perioperatively when we drill the head. And in type 2, there is a much more capsular injury and cavern triggering causes no bleeding. But we also have to categorize the true anatomic classification. So in type A, the dislocation of the is associated with proximal humeral fracture, and type B, dislocation with glenoid fracture. Again, the proximal humeral fracture can be divided into A1 to 7, in which greater tuberosity fracture, lesser tuberosity, 2-part, 3-part, or again it's divided into anterior and posterior. So the type B, in which the rim of the glenoid is fracture and it is divided into B1 to 4. So fracture dislocation may present in a very dramatic way, but sometimes you see in this patient, he sustained a proximal femoral fracture dislocation 3-part. We have to reduce immediately as the patient calm, and patient later denied to go for surgical fixation. And very fortunately, his fracture is healed and is very good function with a smiling face. But other times you might very unfortunate. In this patient, is a posteriorly dislocated hip with wide displacement. The long-term follow-up show
though this fixation is reasonably well, it shows complete avascular necrosis of the humeral head. So there is a wide variety of instrument use, implant use to fix this type of fixation, and there is so many failure also. So what are the causes of this unfavorable result? There are so many factors. The most commonly cited factors are varus displacement, length of medial metaphyseal head extension, which is should at least be 8 millimeter, and integrity of the medial hinge. In this, the medial hinge is intact, but in this type of fracture configuration, where there is a medial hinge is not intact, there is a more chance of avascular necrosis and presence of head splitting pattern. So overcome this, you should know the anatomy and pathoanatomy. You should recreate the anatomy again. So in either open reduction internal fixation or closed reduction internal fixation, or for creep, R comes before fixation. So reduction is before fixation. So for anatomical reduction, we should know the metaphyseal torus concept, the posteromedial column, anteromedial column, and anterolateral zone should be restored again. And don't forget about the vascular anatomy. You see, we all know the anterior and posterior circumflex humeral artery. In so many studies shown that the anterior circumflex artery is fractured. During fracture, it is injured, and so very important is the posterior circumflex humeral artery, and it's a very large artery, and it is a reliable source for revascularization. So don't try to injure any of these one, either anterior or posterior circumflex humeral artery, when we fixing this type of fracture. So another important issue is you have to assess whether capsule is injured or not. When there is a capsular injury along with the fracture, you should do capsular repair along with the fixation. Otherwise you might fail. So when you do all these things, you might get a good result. But there are some other dislocation like interthoracic dislocation, which is very severe form. I don't go through for this. In our series, we have retrospectively reviewed 28 cases of fracture dislocation. Average age is 38 years. 6 patients have 2-part fracture dislocation, 13 patients had 3-part, and 9 patients have 4-part fracture dislocation. We faced major complications like avascular necrosis in 3 patients, secondary tuberosity displacements in 2 patients, and axillary nerve injury in 1 patient. The mean constant Marley score at 6 weeks is about 13.45. At 12 weeks, it is 14.46, and at 1 year, 17.78. So my take-home message is evaluate each type of injury carefully, both clinically and radiologically. Execute plan intraoperatively, and there should always be a plan B. Patient should be counseled regarding subsequent intervention like second surgery and hemiarthroplasty. Thank you. Thank you very much.
Thank you, Dr. Javed Jangi, for your nice presentation. This topic is also very favorite to me as well, because a few years back, I also presented a paper on proximal humeral fracture where
Sir, please unmute yourself.
frankly, it may not be that good, but in fact, surgery can yield good result. Do you listen to me?
Yes, sir.
It's okay. And thank you for your beautiful presentation. I think we have spent more than an hour. I'm not sure we have any time for question and answer session.
Sir, no question and answer session, please, sir.
So I think there is no time for question and answer session. I'm sorry for that as well. This is almost 6:30 now. So thank you everybody for staying with us for quite a long time. My special thanks to the presenters and the organizers as well. And also my special thanks to the foreign faculties, because with a lot of enthusiasm and a lot of interest, many of these presenters, especially from India, was with us for a long time. Thank you, all of you. With these few words, I'm concluding this scientific session number 5. Thank you all.
Thank you. Thank you, Professor Khandakar Abdullah Rizvi, ex-president of Bangladesh Orthopedic Society and the running president of Bangladesh Spine Society, for a nice conduction of a very beautiful session. So this is the end of the scientific programs. I can see Khulna division and Sylhet divisions along with us, and some of the members still are participating. So there is the closing ceremony. I want to request the President has given me the opportunity to conclude the session in favor of President of Bangladesh Orthopedic Society. So I'd like to request, first of all, the organizing secretary from Dhaka divisions, because in the morning, all organizing secretary from Dhaka divisions different divisions talk, but except Dhaka division, we kept his slot for the closing ceremony. So 1 minute, please. Dr. Aminul Haq Pathan, the organizing secretary from Dhaka division.
Thank you, sir. Thank you. Thank you, the chairman, organizing committee. Now, I'm thanking all the participants of the different division, from the different divisions, and for the patients hearing this long session from 9:30 to still. And thank you everybody for participating this type of our national conference. Sorry, not the national, international conference. Thank you everybody.
Thank you, Dr. Aminul Haq Pathan. On behalf of the organizing secretaries outside Dhaka city, I would like to request Dr. Mehdi Nawaz from Khulna, please give 1 minute conclusion speech. Dr. Mehdi Nawaz from Khulna, please unmute yourself and you speak from your side. Yes, we can see you. Very handsome, beautiful looking, always smart.
Yes. আমি ডক্টর রিজভি। জি, ভালো আছেন তো?
রিজভি স্যার, আপনার মাইকটা একটু ইনশাআল্লাহ অপারেশন ভালো আনমিউট করবেন স্যার।
Thank you, the chairman of organizing committee, Professor Dr. Shahidul Islam, and the president of Bangladesh Orthopedic Society, and also the secretary general of Bangladesh Orthopedic Society, and all the organizers of Bangladesh Orthopedic Society. I would like to express my heartiest thanks to all of them and all of 8 divisions, those who are participating in this program. In Khulna divisions, we were a huge number of doctors are present, and at last of all, we are present many doctors, and really in this hybrid form, we enjoyed a lot. And I think different societies of Bangladesh will observe this, and they will. I think it's my expect that different societies will see and observe it, and they will start their conference by this hybrid form. And last of all, I again thanks all of the orthopedic doctors of Bangladesh, those who are working in different places and those who are present at different places and 8 divisions and in also NITORs. Last of all, I would like to thank the senior professors and the professors of different countries, those who are attended in this Orthopedic Society's conference, because we really enjoyed their papers and they talked in a very nice manner. So I'd like to thanks to all the doctors abroad and home in Bangladesh. Thank you everybody.
Thank you, Dr. Mehdi Nawaz and all the organizing secretaries from outside Dhaka. Your hard work and sincere participations, we are encouraged and we will do another programs in future. So I would like to request the most working person in Bangladesh Orthopedic Society, whom we trust, whom we believe, and for his endeavor, we have achieved a very successful ending of Boscon 2021. The organizing secretary and the office secretary of Bangladesh Orthopedic Society, Dr. Mahfuzur Rahman Shaheen.
Thank you, sir. And I feel blessed. I feel blessed by your gracious presence and my gratefulness to you for being present here for at least 10 hours. So from 9 a.m. Now it is almost 7 p.m. My gratefulness to you and for your kind support and help to making this conference a successful one. I must say thanks to our organizing secretaries of 8 divisions for their tremendous effort and continuous support and continuous delivery of his advices to me for making the conference a successful one. And my gratefulness to my senior teachers, my colleagues, and my junior brothers for their kind support and help. And my gratefulness for the foreign faculty for their kind support and presentations. And last and most of all, my gratefulness to all the members of Bangladesh Orthopedic Society. Thank you, and please pray for me. And thank you again for giving me the opportunity to serve you. Thank you.
Thank you, dear Mahfuzur Rahman. I, as a chairman of the organizing committee, I trusted on you, and you did all the things with your co-workers, and finally, the president of Bangladesh Orthopedic Society and the secretary general of the society and the treasurers and other office bearers did a lot of work for successful conference. So I would like to request now the most dynamic, one of the most dynamic person of Bangladesh Orthopedic Society, the treasurer of Bangladesh Orthopedic Society, Dr. Mohammad Jahangir Alam. Please say a few words for the participants.
ধন্যবাদ যদিও বলার ইচ্ছা ছিল না পেরিফেরিতে আপনারা যা দেখিয়েছেন আমি কৃতজ্ঞ আপনাদের প্রতি কৃতজ্ঞ সমস্ত বাংলাদেশ অর্থোপেডিক সোসাইটির সদস্যদের প্রতি সারা দিন যে পরিশ্রম করে এখন আপনারা বসে আছেন বক্তব্য দীর্ঘায়িত না করে আবারও বাংলাদেশ অর্থোপেডিক সোসাইটির পক্ষ থেকে ধন্যবাদ জানিয়ে এবং কৃতজ্ঞতা জানিয়ে শেষ করছি ভালো থাকবেন জয় বাংলা জয় বঙ্গবন্ধু বাংলাদেশ চিরজীবী হোক
Thank you. There will be no more talk. Stay safe, stay fine. We want your future cooperations, your future participations for the success of Bangladesh Orthopedic Society, for the betterment of the members of Bangladesh Orthopedic Society. If we work together, we will achieve our goal. Thank you for participation. Thank you, the members of Bangladesh Orthopedic Society. Thank you, all divisional organizing secretaries for your hard work. So we conclude the session in favor of Bangladesh Orthopedic Society President and Secretary. So you are invited to attend tomorrow's AGM Already invitation has been given by our office secretary to your WhatsApp and message. So please check it. Thank you very much. Long live Bangladesh Orthopedic Society. Long live Bangladesh.